cochlear implantation in prelingual. Prelingual means before development of speech, deafness occurred. After 6 years, pinnaplasty. This is for this one. Can be done in any time. Cochlear implantation in postlingual deaf. Who is postlingual deaf? See, I have developed my speech, isn't it? I have been talking to you since last year. Last year, this year. How many of you are from last year? How many of you are from this year? Okay. So right. So cochlear implantation in postlingual means I am able to speak normally. Now suddenly my cochlea, there is some pathology and my cochlea got damaged and I am unable to hear. Now I am a postlingual deaf okay person. Now in this postlingual deaf person, so you can go cochlear implantation at any age of time. But in prelingual, before development of the speech, if the deafness occurred, that is prelingual, 6 years is the age limit. Okay. Now coming to the hematoma pinna. So it is nothing but, it occurs due to trauma, collection of blood in the space between cartilage and its covering perichondrium. Between the cartilage and its covering perichondrium, collection of blood will occur. So cause is mainly trauma and blood accumulates here that causes swelling and tight collection here in between the tightly attached layers. A small amount of collection may cause severe pain. Treatment is you have to decrease the size of the swelling, you have to relieve the pain, so you release the pressure. So how you can do that? By incision and drainage, and then to avoid recollection, do pressure dressing. If you do not treat promptly or if the patient do not get it treated promptly, complication may arise. So the surrounding pressure necrosis of the surrounding cartilage, surrounding areas fibrosis may occur. Ultimately the ear may look like a cauliflower or pugilistic ear. Now coming to the perichondritis pinna, the most common organism is Pseudomonas aeruginosa. Pain and redness over the pinna will be there, and tragus end, if you press the tragus, pain will be there, and lobule sparing, because there is no cartilage, so no perichondrium, so perichondritis cannot happen. So lobule sparing is seen in this perichondritis pinna because of no cartilage, and treatment is same because the causative is Pseudomonas. Anti-Pseudomonal antibiotics will form the treatment option. So piperacillin, fluoroquinolone, ceftazidime, cefoperazone, these are all your known anti-Pseudomonals. Coming to the nerve supply, the anterosuperior part is supplied. That means the root of the helix and the tragus are supplied by the auriculotemporal, which is a mandibular branch of mandibular division of trigeminal nerve. And coming to the central C-shaped depression concha part, that is supplied by facial and vagal branches. The vagal branch, another name is Arnold's nerve, and the remaining entire part of the pinna is supplied by greater auricular nerve. Greater auricular nerve, the nerve that supplies greater part of the auricle. So the entire pinna is supplied by the greater auricular nerve. Only the central concha piece is supplied by the facial and vagal branches, Arnold's nerve. The anterosuperior root of helix and tragus are supplied by auriculotemporal nerve. Now coming to the nerve supply of external auditory canal here itself. Now if we go from pinna towards the external auditory canal, it will be visible like this. Now in the external auditory canal, the anterior wall is supplied by the auriculotemporal and the posterior wall is supplied by the facial and vagal branches. And so whenever you are syringing, you will direct the water jet towards the posterior wall. That will cause immediate cough reflex due to stimulation of the vagus nerve. And now coming to the nerve supply of outer surface of the tympanic membrane, the anterior, the same, you continue from the anterior wall towards the tympanic membrane. The outer surface anterior half is supplied by auriculotemporal nerve. The outer surface posterior half is supplied by the vagal and facial branches. See the color. I have given the same color coding everywhere. So according to the color coding, try to understand the concept. Now coming to this, a patient diagnosed with earwax subjected to syringing. She developed a syncopal episode, maybe due to vagal bradycardia. Okay, parasympathetic stimulation. So when the tip of syringe touched the ear canal. So the cause is here Arnold's nerve, right? Okay. What is this Jacobson's nerve? This is supplying the, which part Jacobson's nerve is supplying, which is a branch of glossopharyngeal. This is supplying where? Anyone? Jacobson's nerve is supplying middle ear. Middle ear is supplied by Jacobson's nerve. So I can say that the inner surface of the tympanic membrane is supplied by Jacobson's nerve. Inner surface of the tympanic membrane is supplied by Jacobson's nerve, which is a branch of tympanic, branch of glossopharyngeal. Now coming to external auditory canal, You know the embryology, it is developing from the first cleft. The first cleft from outside deepens in between the first arch and second arch. From outside, the depression is called as first cleft. It deepens inside to form the first cleft, I mean external artery canal. From inside the first pouch in between the first and second arches, the depression from inside is the first pouch, which is lined by endoderm. You can see the cleft lined by ectoderm. So this is ectodermal lining. So squamous epithelium will be present here. This is endodermal lining. So mucosal lining will be present inside. So the endodermal pouch, the first pouch invagination lined by endoderm will form Eustachian tube. Okay. So in the surface, in the area of the tympanic membrane, outer squamous will be there, which is ectodermal origin. Inner mucosal will be there, which is of endodermal. In between these two, later, the middle connective tissue is there, no? That will form a middle fibrous layer in between these two. So that's why the middle mesodermal fibrous layer will form in between these two. The tympanic membrane will be having 3 different layers developed from 3 different germ layers. Now coming to the anatomy of the external artery canal, the outer part is directed upwards, backwards, and the inner part is directed downwards, forwards. So to examine the pinna is pulled upwards, outwards, backwards. The outer 1/3 is cartilaginous and the inner 2/3 is bony. And coming to the Eustachian tube, the outer 1/3 is bony and the inner 2/3 is cartilaginous. You can see to a central piece of bone, on either side cartilages are attached. This is one cartilage, this is one cartilage, and this is the bone, the central bone. So to a central bone, on either side the cartilages are attached. Now what happens to the external artery canal? Outer 1/3 becomes cartilaginous, inner 2/3 becomes bony. What happens to the Eustachian tube? Outer 1/3 becomes bony, inner 2/3 becomes cartilaginous, right? So the length of the external artery canal is 24 mm and the Eustachian tube is 36 mm. Now coming to the various swellings in the external artery canal. So if you take the outermost cartilaginous area swelling, in the cartilaginous area, the hair, the multiple hair is present and hair is connected to the hair follicles inside in the outer cartilaginous skin area. If you see the outer area, entrance area, you will see multiple hair over there. That hair is connected to the hair follicle inside and that is attached to the sebaceous gland inside. So pilosebaceous unit, you call it as. Infection of this pilosebaceous unit will cause the formation of this furuncle. Most commonly, Staph aureus is the main common organism here, because in the fingernails, whenever you are scratching like this, what happens? From the fingernail, epithelial breach. Now through that breach, the organism will enter inside. That infects the hair follicle inside and will cause the formation of this furuncle. So this is very acute infective. So infective means inflammatory, red in color, red and painful, and sudden acute onset swelling will be there. And the treatment is conservative. Anti-staphylococcal augmentin, your amoxicillin and fluoxetine, your aceclofenac you can give. Both that will be enough. And coming to the bony tumors, in the inner bony part, now the cartilaginous part is over. In the bony part, you do not have any hair or any sebaceous glands or cereminous glands. In the cartilaginous part only, you will be having all these glands and hair, everything. So a furuncle can happen only in the cartilaginous area. A furuncle cannot happen in the bony area. Hope you understood the concept. Now coming to the bony wall, here, a single large bony tumor is called as osteoma, and multiple small tumors are called as exostosis. So in osteoma will be large and a single, okay? And this is most commonly symptomless. Most of the times the patient comes with some other problem. Incidentally, on otoscopy, you will find these tumors. Of course, the treatment will be surgical excision. Now, when it comes to exostosis are multiple small swellings. Again, they occur in the bony area only. So they will be occurring in the bony area only. So these are small in size and multiple in number. And mostly these are seen in people who are getting exposed to cold water most commonly. Okay. So that's why you see most commonly this in surface, ocean surface, cool water. So surgical excision is the treatment of choice here. Now coming to the otomycosis, nothing but fungal infection of the external artery canal, and cause, it's seen in diabetics. Those who have less immunity, they will have more fungal infection chances. So and this is outer exposed area. So more chances of getting this infected. Immunocompromised people and earbud. So your famous Okay, ear treatment solution. Right. The most common organism will be Aspergillus niger, the black-headed filamentous dot-like growth, and second most common will be the Candida, which occurs as a creamy white yellow deposit. Pain, itching, musty odor, block, hardness of hearing, a varying mixture of symptoms can be seen. The treatment is first you go out for ear cleaning, not oral toileting, ear cleaning, and then go for antifungals, both systemic and topical. Systemic also needs to be given, not topical. Okay, antihistaminics to reduce the itching and analgesics to reduce the pain. So other symptomatically, you can add the other treatments also. So you can see here a whitish candida like growth everywhere, and you can see the blackish, okay, Aspergillus niger head, black-headed filamentous growth. So this is called as wet newspaper appearance. Now coming to the Ramsay-Hunt syndrome, also known as herpes zoster oticus, because this herpes zoster family organism is infecting the ear, and exactly which herpes is causing, varicella zoster virus is causing. You know, varicella zoster is very famous for causing chicken pox. So if a person has got Ramsay-Hunt syndrome in the elderly adult age, means in the childhood he must be infected with chicken pox. So that at that time antibodies formed, and this chicken pox got out in 2 to 3 weeks, and the virions started residing dormant in the geniculate ganglion. Okay, they are hiding in the geniculate ganglion since then. Now whenever you become immunosuppressive, immediately they come out and start attacking you. So they get reactivated and spreads along the, you know, the geniculate ganglion is a ganglion of facial nerve, so they spread along the facial nerve root. So painful vesicles along facial nerve roots, you know, the facial nerve distribution, everything, you know that, right? So on the concha area, on the posterior wall of the external auditory canal, on the tympanic membrane outer surface, posterior half. So you will be seeing painful vesicles all along the facial nerve distribution route. Antivirals, corticosteroids, and painkillers will be the treatment option. If not treated immediately or promptly, a facial palsy and SNHL may arise as the complications. Now coming to this question, painful vesicles on ear and facial nerve palsy. So Ramsay-Hunt syndrome and geniculate ganglion will be the cause. What is Melkerson-Rosenthal syndrome? I told you. What is Melkerson-Rosenthal? What is alternating facial palsy episodes? Melkerson-Rosenthal. One time this side facial palsy, one time that side facial palsy. And fissured tongue will be there. Edema of the lower lip will be there. So these are the features you see in Melkerson-Rosenthal syndrome. Gradinegos we will come to it, see in the petrositis, complication of CSOM. Now coming to malignant otitis externa, first of all, this is not malignant. Then why this is named as malignant? It is otitis externa, means external ear infection only, but the organism causing here is Pseudomonas, which invades into the tissue. So it is invading into the tissue, forming a tissue reactions, granulation tissues. It is mimicking a carcinoma. It is growing like a cancer, as a malignancy, behaving like a malignancy. So this otitis externa caused by Pseudomonas is called as malignant otitis externa. Now, why it is called as necrotizing otitis externa? The organism grows into the bone and soft tissue. It damages, necrotes that soft tissue, everything, or bony tissue, whatever it comes in contact with. So it is called as necrotizing otitis externa. Why it is called as skull base osteomyelitis? See, this is the bone, the partition between the cranium and the ear. So the organism is coming and damaging this bone, infecting this bone, osteomyelitis. So this bone forms a part of the skull base. Okay, among the entire skull base, this bone also forms a small part of the skull base. So this is also called as skull base osteomyelitis, right? So most commonly, again, you see in uncontrolled diabetics and immunocompromised, severe pain, mostly nocturnal, granulation tissue formation, you will see. As the offending organism grows into the tissue tries to seal it off by forming a granulation tissue. This is a natural tissue response to protect you. So granulation tissue will be seen here. And apart from that, this is a bacterial infection. You will see purulent discharge also. Sometimes the bone is getting damaged, so you can see sometimes blood stained discharge also. So you have to, whenever you are suspecting Pseudomonas, the proof is, because this is a life-threatening condition. So you should have a medico-legal proof for you. So better collect the specimen, send it for culture sensitivity, CBP, ESR, and also go for HRCT temporal bone, because how far the organism has spreaded, whether it is still extracranial or spreaded intracranially or spreaded into the labyrinth or spreaded into the antrum, mastoid or middle ear, or where it has spreaded, you don't know. So get a CT scan done and see the extension of the organism growth, damage, extent of the necrosis you have to Notice. And now, treatment is again anti-pseudomonal antibiotics, analgesics. For 6 weeks, you need to give. Every week, the patient has to come for a regular checkup, and you have to see whether the condition is improving or not. So you will go for the prognostic scans that you do here are gallium scan and technetium scan. So week by week, when the patient comes for regular follow-up, in the prognostic scans, you should see the amount of soft tissue involved or amount of bony tissue involved should be reducing. Or if these are not available, go for ESR, which should be reducing week by week. And in these two, if in the exam all these three are given and the question is asked which is the best prognostic marker, always choose gallium scan. This is the most reliable marker of all three. The complications again, facial palsy, SNHL, intracranial extension. So diabetic came with excruciating ear pain, bloodstained ear discharge, facial nerve involvement. So this is very clearly necrotizing otitis externa. And following a trauma, so this is the finding you are seeing. Already the blood is called clotted, so you should not disturb the clot, isn't it? So if you disturb the clot, again fresh bleed may start. So when there is no active bleed, no packing is needed, and the eardrum is normal, and always there's a stained only the stained blood clots are present, so nothing to do, just keep the ear dry and give oral medications, that's it. Okay, now coming to the tympanic membrane, so you know it is having 3 layers: outer squamosal, ectodermal, middle fibrous, mesodermal, all these things you know. Apart from that, you know there are 2 parts in the tympanic membrane: a large pars tensa below and a small pars flaccida above. Pars tensa is having 3 layers, and so it is very strong and tense. The middle layer is present here. In pars flaccida, the middle fibrous layer is absent, so only 2 layers are present, so that's why it is weak and loose. And the annulus, which is formed by the peripheral thickening of the middle fibrous layer. So if middle fibrous layer is present, annulus will be present. If middle fibrous layer is absent, the peripheral thickening of the middle fibrous layer called as annulus will be absent here. Okay, now coming to the perforations, central and subtotal, you know, these are seen in safe type of CSOM, whereas marginal and attic, you know, these are seen in unsafe type of CSOM. Coming to the staging methods, if the tympanic membrane is retracted such that the handle of malleus becomes more prominent, it is grade 1. If the retraction still extends further inside and it touches the incus and stapes, now that becomes grade 2. And if it still goes inside, what happened? If it still goes inside and touches the promontory, that is grade 3. And if still completely drapes the entire middle ear, now that is grade 4. Stage 1, stage 2, stage 3, complete obliteration is grade 4. So the tympanic membrane is present like this normally, slightly dented inwards, type 1. Gone still much inside and touching incus tape is grade 2. Gone much inside, even much deeper inside, touching the promontory, grade 3. So completely draping the middle ear walls. So no middle ear cavity is left over. So your external aortic canal is directly communicating with this space. Okay, so that is grade 4, atelectasis. Your middle ear is collapsed. No middle ear cavity. See the middle ear cavity here. And is there any middle ear cavity here? No middle ear cavity. Collapse of the middle ear. That is atelectasis. Hope you got it. Okay. Understood? No? Grade 1, grade 2, grade 3, complete is grade 4. Very simple. Okay. Anatomy. Now coming to toss staging, in the pars flaccida area, a slight dip is grade 1 and touching the neck of the malleus, which is present behind the pars flaccida. So that is type 2. And if it is going into the Prusak space, type 3. Type 4 is nothing but type 3 plus scutum erosion. This bone is getting eroded. See, slight dip here is grade 1. Touching the neck of malleus is grade 2. Going into the Prusak space is grade 3. Also eroding the scutum is grade 4. 1, 2, 3, 4. Easy, no? इसमें कुछ नहीं है. Toss is for pars flaccida, isn't it? Nothing is there. Just you think that something is there. Okay. Now coming to meningitis bullosa, multiple bullar swellings you see on the surface of the tympanic membrane between outer and middle layers. Mycoplasma, viral infections may cause this. So there is surrounding inflammation. So pain is there. It is become bulbous, okay, bulged. It cannot vibrate properly. So hardness of hearing and block sensation will be there. The treatment is antibiotics and NSAIDs you can give. Meningitis granulosa, iatrogenic, and what happens? Small reddish granulation areas occur on the surface of the tympanic membrane. So that you see, and a purulent discharge you will see. So painless otorrhea. The Most important thing you need to remember here is painless otorrhea. So painless otorrhea you see in meningitis granulosa, topical antibiotic corticosteroid, your ciprofloxacin, most commonly available everywhere. Ciprofloxacin, antibiotic, dexamethasone, corticosteroid. So that itself will be sufficient. Okay, right? Even if you go to a shop and ask for randomly for ear drops, that guy will give this only. Now coming to the tubercular otitis media, mycobacterium, is the extrapulmonary form, Again here, painless. See, notice this, meningitis granulosa, painless, TB otitis media, painless. These two are painless conditions. Please remember this. So you will see the moment you see multiple central perforations, you should suspect TB otitis media. There are multiple painless, pale granulation areas are present. So you see these pale granulations in TB very often everywhere, and discharge. So treatment is ADT. After 6 months, you go for meringoplasty. Now, tympanic membrane rupture is related to which level of blast injury? Hollow viscous injury, like your tympanic membrane, bowel, all these are level 1 injuries, right? Okay, hollow viscous injuries, right? Level 1. Because in the middle ear, there is nothing, isn't it? कुछ नहीं है ना middle ear में, सिर्फ खाली हवा है. Okay, right? So it's a hollow organ, right? So tympanic membrane rupture occurs at the level 1, right? Now coming to the ossicles, malleus and incus develop from first arch and stapes develops from second arch, and the foot plate is an exception which develops from the otic capsule, okay, as a part of the inner ear. So malleus incus from first arch, stapes from second arch, foot plate as a part of otic capsule. Which of the following middle ear structure is a derivative of neural crest cells? So neural crest cells means it is a neural ectoderm. The ectoderm differentiates, it goes inside and differentiates itself as a neural ectoderm. Your nervous system is ectodermal in origin, isn't it or not? So from that, the inner sensory structures of the ear. What are the sensory structures of the ear? Inner ear, vestibule, cochlea, all these are sensory structures, detecting hearing, detecting balance, sensory structures. So they are developed from otic sac, right, isn't it? So foot plate of stapes develops as a part of the inner ear, right? So I told you in the lab 2 class also, as of now, forget this diagram. Once you clear the FMGE, once you come to the NEET and INSET preparation, then you can go through that diagram, okay? Now coming to the middle ear, there are 6 walls in the middle ear. It's a cube-like room-like structure, and the roof is made up of a small plate of bone that is called as tegment. The floor is also made up of a small plate of bone. So 2 walls are over. Now you are left with other walls. In the anterior wall, the most important opening will be the Eustachian tube opening. So the Eustachian tube will be opening most commonly in the anterior wall. So anterior wall, most important structure you need to remember is Eustachian tube. That Eustachian tube goes towards the nasopharynx lateral wall, right? Now other one is tensor tympani origin will be there above. Now coming to the lateral wall, you have tympanic membrane and the scutum above. So this is the tympanic membrane, okay, and the lateral wall. If this is the middle ear, this is the lateral wall. So tympanic membrane below and scutum above. So these two are the structures on the lateral wall. Now 4 walls are over, right? Now you are left with posterior wall. If you look towards the posterior wall, there is a bony bulge called as pyramid. And on that, what happens? On that pyramid, the stapedius muscle arises and it attaches to the stapes bone. Okay, this is the stapes. See the anterior crude of the stapes. See the posterior crude of the stapes. Okay, and this is attached to incus. How the incus is going up. See the 2 crura. I am seeing from here. My endoscope is here. I am seeing this one. See the 2 crura. Anterior crura, posterior crura. See, I am seeing from here. I can see the incus long process coming from up down. This one. See, I can see the incus long process coming from above down. Okay, isn't it? I can see the handle of malleus. From here, when I am seeing inside, I can see the handle of malleus. See the handle of malleus. Isn't it? Right? So this is your oval window. Into the oval window, stapes is getting fixed. To the stapes, attached is your stapedius muscle that is arising from the pyramid from the posterior wall. Right? Okay. Now, so you can see the pyramid. This is the pyramid. Right? This is your oval window. Right? Now, so forget about the facial nerve. As of now, we'll come to the facial nerve course. We'll discuss it. Now coming to the medial wall, the most important wall of all. On the medial wall, this is medial wall means, see, for middle ear, if this is the medial wall, For inner ear, the same is the lateral wall. Common partition, no? So now see the coiling of the cochlea. This is your apical coil. This is your middle coil. This is your basal coil. Now the basal coil is forming a bulge on the medial wall of the middle ear or the lateral wall of the inner ear. This bulge is called as promontory. This bulge is called as promontory. Now, postero-superior to the, see the promontory, to the promontory, postero-superior is your oval window. Postero-superior is oval window. To the promontory, postero-inferior is your round window. Postero-inferior is your round window. Right? Okay. Understood? So this is your promontory, oval window, round window, and so this is the facial nerve. See the facial nerve running here. See the facial canal. Can you notice a bony canal? A cylindrical bony canal running like this horizontally. So that is, this is oval window. Above the oval window, facial nerve canal. Above the oval window, facial nerve canal is running. Okay. Now, take a deeper look. Now this is your promontory. This is your promontory, right? From the promontory towards the pyramid, a bony ridge is present that is called as ponticulus. From the promontory towards the pyramid, a bony ridge is present that is called as ponticulus. And from the round window, see this is your round window, promontory, oval window, round window. From the round window towards the posterior wall, another bony ridge is running that is subiculum. See this is round window, this is posterior wall. From the round window towards the posterior wall, another bony elevation is running that is subiculum. In between ponticulus and subiculum, the central present chamber is called as, the depression, the darkest, deepest area, hidden area that is called as sinus tympani. In between the subiculum and the ponticulus, this area is called as sinus tympani. This is the residual site of cholesteatoma in microscopic, not endoscopic. This is an endoscopic picture. So you are able to see very clearly. But in microscope, where we see from here, the microscope will be kept here. Microscope cannot be inserted into the ear. An endoscope can pass into the ear, but microscope will be kept here. From here, if you see inside, from this area, if you see inside, this area is not that better visible. So chances are there, if you are doing microscopic ear surgery, chances are there that you may you may not be able to see the cholesteatoma here. You may not be able to remove the cholesteatoma here. So a residual cholesteatoma, leftover cholesteatoma can be present even after surgery that may lead to recurrence of the problem again. Now coming to the facial nerve course. So on the medial wall, you have on the medial wall, above the oval window, you have the horizontal part of the facial or tympanic segment of the facial nerve. And on the posterior wall, so the facial nerve will be running vertically, obliquely downward. This is called as mastoid segment. And coming to the ganglion that is formed here is called as geniculate ganglion. On entering into the middle ear, immediately after entering into the middle ear, see the facial nerve will be coming from cranium, isn't it? It's a motor nerve. Motor nerve means from the center to periphery. So it is coming from the inner ear side, brain, cranium, okay, CP angle, internal auditory canal, running above the inner ear and entering into the middle ear. The moment it enters into the middle ear on the medial wall, it forms a geniculate ganglion. Now from there, it runs horizontally backwards. That is horizontal segment of the facial nerve. After touching the posterior wall, it runs vertically downwards. On the posterior wall. You call it as vertical or mastoid segment. Now, see the oval window here. And above that it is running, and see the pyramid where the stapedius is arising. Anterior to the pyramid it is running, this should come here actually. Posterior to the pyramid it will be running. Posterior, the pyramid will be projecting into the middle ear, and the facial nerve will be running in the bone behind. So behind the pyramid, the facial nerve will be running. So I was unable to draw the curvy part like that. So I just drawn it straight line. Okay. And here at the superior, posterior, medial. This is the medial wall. This is the posterior wall, and that is the superior wall. Medial, superior, posterior. At that junction, you have the lateral semicircular canal, right? And processes cochlear reformis, a hook-like projection will be present over here, right? So processes cochleariform is oval window, pyramid, and lateral semicircular canal. All these four help in identifying the location of the facial nerve. So to the oval window, this is lying superior. To the lateral semicircular canal, the facial nerve is running anterior-inferior. To the pyramid, the facial nerve is running posterior. So based on these landmarks, if I am able to identify either pyramid or oval window or lateral semicircular canal, I can come to know where the facial nerve is running. So during middle ear surgeries, once I identify the facial nerve, I will be cautious enough not to damage the facial nerve during middle ear surgeries. So these are the landmarks which help in identifying the facial nerve course. Now coming to the next one. So from the geniculate ganglion, what happens? There are three branches. There are three branches of the facial nerve. The first branch arises from the geniculate ganglion, that is called as greater superficial petrosal nerve, which is supplying the lacrimation. The second branch is arising into the pyramid, that is called as nerve to stapedius, supplying the stapedius muscle. And the third branch is again back entering into the middle ear, that is called as chorda tympani, supplying the anterior two-third part of the tongue taste sensation. Now, these three are the branches of facial nerve. Now, coming to the facial nerve. So you have understood the facial nerve course now. Now, if there is a lesion in the translabyrinthine, in the inner ear segment, okay, in the inner ear segment, there is a lesion. Now, what happens if there is a lesion here in the inner ear side? Now, what happens? See, the GSPN cannot conduct the impulses. The nerve to stapedius cannot conduct the impulses. The chorda tympani cannot conduct the impulses because the lesion is compressing the facial nerve, not allowing the nerve impulse to travel through. Now, what happens? This cannot function, this cannot function, this cannot function. Lacrimation is absent, stapedial reflex is absent, taste is absent, right? Now, if there is a lesion in the horizontal tympanic segment, now see the GSPN is able to function normally because the lesion is distal to its origin. So this can function normally, isn't it? Right? But see the nerve to stapedius? No. See the chorda tympani? No. So if a lesion is on the horizontal or tympanic segment, only lacrimation, skimmer test is positive, whereas stapedial reflex and taste sensation are absent. Now come to the vertical part. If a lesion is on the vertical segment, now what happens? The nerve to stapedius can function and also your GSPN can function. So lacrimation is present, stapedial reflex is present, but taste is absent. Now, if the lesion is much more distal after exiting from the middle ear, the lesion is much more distal, parotid lesions or anything. Now, what happens? Here, all three will be present. So, based on the results given by these three tests, skimmer test, impedance, and electrogustometry. So, based on the results obtained, varying results obtained by these three tests, you can identify the location of the lesion of the facial nerve. So, based on these diagnostic tests, the topography of the lesion is understood. So, these tests are also called as topo-diagnostic tests for identifying facial nerve lesion. Hope you are able to understand. Very easy, no? इसमें कुछ है क्या? Isn't it? Nothing is there, no? Now coming to the facial nerve course and what is facial recess? Now I have told you the facial nerve is coming on the medial wall. The facial nerve is running horizontally. On the posterior wall, it is running vertically. And laterally, it is giving rise to branch to this chorda tympani. So I will put it this way, posterior view. So this is posterior wall. This is medial wall. Okay. Now, where is this horizontal segment coming? This is running like this on the medial wall horizontally. Are you able to understand this diagram? First time, first comers, newcomers. Now, as soon as facial nerve touches the posterior wall, it runs obliquely, vertically downwards. As it crosses the middle ear, it gives rise to chorda tympani branch, which again re-enters the middle ear. This cavity is the middle ear cavity, isn't it? Now, on the wall, medial wall, this is running horizontally. As it touches posterior wall, it is running vertically, obliquely downwards. As it exits the middle ear, from there the chorda tympani arises. The chorda tympani re-enters the middle ear. Now, in between the facial nerve medially and the chorda tympani laterally, you have a triangular space area that is called as facial recess. This is between the facial nerve and the chorda tympani nerve. So I will put it this way down. Between the facial nerve, not make you confuse. This is your chorda tympani now. Hope you understood now. So this is the area. This is superior view. I am seeing from above. When I am seeing from above, facial is running here, chorda tympani is running here vertically. So when I take a cross section, I can see only cross section of the nerve, not the nerve path like this. Understood? This is posterior view. When I am seeing from behind, now I can see the triangular space very clearly in between them. This area is facial recess. Hope you understood the facial recess, right? Now coming to the tuning fork test, what is the significance of facial recess? For cochlear implantation, this facial recess area is utilized. First, we do a mastoidectomy, and through that mastoid, we will send the cochlear implant electrode through the facial recess, through the round window, into the scala tympani. Okay. Now coming to tuning fork test. So in a normal person, Rini positive, Weber central. If there is right conductive hearing loss, Rini negative, Rini positive, because this is normal. Now Weber will lateralize towards the affected ear. Okay. Now, if there is left conductive hearing loss, now Rini negative, Rini positive, Weber will be lateralized towards the left ear. Now coming to the sensory neural hearing loss, if there is right SNHL, when you do Rini positive, this is normal, positive, but Weber will lateralize to opposite normal ear. Patient is complaining of hearing loss in this ear. Weber is lateralizing towards opposite ear, means this ear has got SNHL. Right? Now, left SNHL, Rini positive. Now, left SNHL, Weber will go towards opposite normal right ear. Understood? This is tuning fork test. इसमें है क्या? Okay. Now, if there is a lesion in the pinna, external auditory canal, tympanic membrane, middle ear, till this level, it will cause conductive hearing loss. If there is a lesion in the sensory organ, what is the sensory organ of hearing? Cochlea. If there is a lesion in the neural part, what is the neural part of the hearing? Cochlear nerve. If there is a problem in the sensory part or neural part, you get sensory neural hearing loss. Sensory neural hearing loss. Simple. Okay. Now coming to the tuning fork test, sometimes there will be unilateral severe SNHL where you get a little bit different test. False negative. The Rini won't be true negative, you get false negative. That is due to transcranial transmission of the transcranial. See, whenever I'm doing Rini air conduction test. So whenever I'm doing Rini air conduction test like this, the air is going only into this cochlea. The air is going only into this cochlea. This cochlea is not at all functioning at all, completely gone. Now, will the patient hear this sound? No. So air conduction won't be there. Now, when I'm doing bone conduction, the tuning fork is touching the skull. Now, the entire skull vibrates. This cochlea is not picking up that vibration signal. The opposite cochlea will pick up that signal. The opposite, see, when I'm doing the bone conduction, the opposite cochlea will pick up that signal and the patient will tell that he is hearing. So, bone conduction, patient says hearing. Air conduction, patient does not hear. So you think that Rini is negative. Now, when Rini is negative, for Rini negative, you think it is conductive hearing loss. And when you do the confirmatory Weber test, Weber should lateralize towards the affected ear if it is conductive loss. But this side it is SNHL. What happens? The Weber will go towards the opposite normal ear, confirming this as SNHL. So Rini negative, which you have got earlier, is not a true negative, that is false negative. This happens when unilateral severe, if the SNHL is one-sided severe, one side completely not functioning, other side absolutely normal. So in that scenarios, unilateral severe SNHL, you get Rini false negative due to, okay, sorry. Just a second. Now, yeah, Weber, Rini and Weber are basic. Rini and Weber must and should be done. Okay. Okay. So this is the interpretations of right severe or left severe. Okay. लास्ट स्लाइड नीड फोटो ना, किसका फोटो? मैराथन में भी लास्ट स्लाइड वालों, इसमें लिखने का कुछ नहीं है, मैं सब कुछ मैंने लिख के रखा है ऑलरेडी, इजंट इट? इसमें लिखने का कुछ नहीं है. Tuning fork test. So this is, there's a formula of 15 I have devised. Okay, a formula of 15. Now there are various frequencies tuning forks available. For you take a 256 hertz tuning fork, and so for that 256 hertz tuning fork, RIN is coming negative. But for 512 and 1024, it is positive. So only for one tuning fork, RIN is negative. 1 into 15, 15 plus 15, 30. Now, two tuning forks, 256 and 512, RIN negative, 1024 positive. Now, two tuning forks negative, 2 into 15, 30 plus 15, 45. Three tuning forks negative, 3 into 15, 45 plus 15, 60. So the approximate amount of hearing loss you can estimate by doing these three tuning fork tests. Okay. पीडीएफ भेज रहे हो ना, स्क्रीनशॉट की जरूरत क्या है? पूरा पीडीएफ आपके पास है ना? Now coming to the whisper, so if I am whispering, it is 30 decibels. If I am normally conversating, it is 60 decibels. And if I am shouting loud, it will be 90 decibels. So even the machines, factory machines, 120 decibels sound they'll make. So that causes discomfort in the ear, right? Okay, so the severity of hearing loss is classified like this. Less than 25 decibels of hearing loss, you won't consider it as a hearing loss. If I get an audiometry done, my audiometry shows that I am having 20 decibels of hearing loss. That does not mean I am having hearing loss. I can be taken as a normal person. But if my audiogram shows 30 decibels of hearing loss, now I come under mild category. If the hearing loss ranges from 25 to 40 decibels, mild, 41 to 60, moderate, 61 to 80, severe, more than 80, profound or deaf. Very simple classification, no? Very easy. 20, all 20 they have done. Very easy, isn't it? Now, a middle-aged man presents with hearing impairment. On tuning fork testing, Rini is positive in both ears. Weber lateralizes to the left ear. Now, the patient is presenting with hearing loss. Now, for example, if you do not understand what to say, Rini positive, right? Weber is lateralizing towards left. So you don't understand what to. Now come to the options. Now, conductive loss in left ear. अगर conductive loss है तो रिनी क्या होना चाहिए? Negative. So Rini should be negative if conductive loss is there. So you can eliminate these two options. Now you are having only these two options left. For example, you take this option, sensory neural hearing loss in left ear. So if there is SNHL in left ear, Rini will be positive. This ear normal, Rini positive. Now Weber will lateralize towards opposite normal ear. Weber should lateralize towards right side. But what the question is telling? Left ear. Now take this option. Now sensory neural hearing loss in right ear. Rini will be positive in SNHL. Rini will be positive normal. So both sides Rini positive. Now if this side has got SNHL, Rini will lateralize towards the opposite normal ear, towards left side. Now this option fits perfectly to the description given. So this is D option is right. Easy, no? Easy or not? Now coming to pure tone audiometry, I have told you a simple shortcut. If you are getting both bone conduction and air conduction line, both lines within the normal range, up to 25 decibels can be taken as normal, isn't it? So within the 25 decibels range, within this range, you are getting all the two curves, okay, near to each other without any gap. That is normal. If there is a gap, one line normal, air conduction line abnormal, bone conduction line normal, and there is a gap, air bone gap between them, that is conductive hearing loss. And two lines near to each other, both in the abnormal range. See, up to 25 is normal. Both are in the abnormal, somewhere in between 30 to 40, both are lying. Not much gap is there in between. So this is SNHL. Both in the abnormal range without any gap. Now mix these two. If both are in the abnormal range, you take it as SNHL. See, both are in the abnormal range. See, 25 is the normal here. So both are in the abnormal range, around 40 to 16 between they are there. Now, both are having a gap, which is a hallmark of conductive loss. There is a gap. So these two features mixed, it causes mixed hearing loss. This is seen in mixed hearing loss. So one thing, two lines in the upper part of the audiogram near to each other, normal. One line normal, one line abnormal, conductive hearing loss. Both lines abnormal near to each other, that is SNHL. Both lines abnormal and also having a gap, that is mixed. Understood? Easy, no? Normal, conductive hearing loss, sensory neural hearing loss, mixed. Why? Why means you have to go to lab 1. Now coming to pure tone audiometry, if it is left conductive hearing loss, see, remember, the right side ear is always denoted in red color. In entire audiology, this phenomena is followed. Okay? Okay. Now, left conductive loss. So you can see the blue lines, both blue lines. So left side here is this indicating bone conduction. One line is normal, one line is abnormal. There is a gap between them. So this is left conductive. Now see, these are in red color. So right side. Now one is in the normal range. See 25. This is the 25, right? One is in the normal range, other one in the abnormal. There is a gap. So this is right conductive. Now see the left SNHL. Now don't just worry that there is no line given. In fact, they have given the symbols. If you connect these symbols, you will get another line here. If you connect to those symbols, the only thing is they didn't connect the symbols, but they have done that test. Okay. So now you can see right side, see if this is 25, almost, okay, they are in the normal range only. Left side, if you can see, both are in the abnormal near to each other. Okay, that is left SNHN. The reverse, this is right SNHN. Hope you understood the audiogram patterns, isn't it? Now coming to the noise-induced hearing loss, where 4000 hertz dip you will see. This is seen in factory workers. Otosclerosis, you see a dip at 2000 hertz on bone conduction curve, that is called as Carhart's notch. And in Meniere's disease, lower frequencies are worst affected. Okay, high amount of hearing loss will be there at lower frequencies. Whereas if you take at higher frequencies, normal, minimal hearing loss will be there. So you get a ascending audiogram. So that is seen in Meniere's disease. The reverse happens in presbycusis, whereas high frequencies are worst affected, whereas low frequencies are less affected. So you get a downsloping. This is seen in age-related. Presbycusis means age-related. Seen in presbycusis, downsloping curve, descending curve. And the treatment for presbycusis is just hearing aid only, nothing else, right? Interpret the audiogram in the image displayed below. Now, if you see this audiogram, both sides, see, first of all, right side, see, one is normal, one is abnormal, there is a gap. Now here, also, you can see one is 25, this is 25, right? One is normal, one is abnormal, there is a gap. Right side, left side, there is a, both are showing conductive hearing loss. So conductive loss in both ears will be there, isn't it? Understood? Now this is conductive loss in left ear, isn't it? Blue color. This is conductive loss in, this is left conductive hearing loss. This is left SNHL. This is right SNHL, isn't it? Identify the audiogram displayed in the image of a factory worker. Nothing. This is noise-induced hearing loss. This is noise-induced hearing loss. What is this? Downsloping, presbycusis. Upsloping, ascending, Meniere's. Dip at 2000 hertz, conductive hearing loss, otosclerosis. A patient having high frequency hearing loss and it worsens in noisy surroundings. What is the, so high Meniere's, you should have low frequency. Acoustic neuroma, you will have middle frequency. And otosclerosis, paracusis is seen. Patient hears better in noisy surroundings, but the question says worsens in noisy surroundings. High frequency hearing loss, presbycusis should be the answer. Understood how to interpret and get the answer right? Impedance. So A is normal. AS, you need to go for sclerosis. D means discontinuity. Even the curve will be discontinuous. And B means flat curve. Most commonly seen clinical conditions in children OME and in adults CSOM. These two are the most common things you notice in your regular clinical practice. And C means retracted tympanic membrane, negative pressure. So here you can see the depressed amplitude, that is type AS curve. So normal means it will be present like this. This is A type and AD will be going like this and B will be going like this and C will be coming like this. Simple. Okay, just practice this 2 to 3 times, you'll get that. Okay, now coming to the otosclerosis, deposition of extra bony tissue at the anterior area of stapes footplate in oval window. So in the footplate area, extra bone, spongy bone deposition occurs. Now when that extra bone gets deposited, the footplate, the stapes gets fixed in that. Now earlier the stapes was freely moving in the oval window. Now due to the extra bone and fixation, it is unable to move properly. Now that causes conductive hearing loss. Most commonly seen in females, and it increases during pregnancy. The most common site anterior to the footplate area, that you call it as fistula antifenestrum. Mainly hearing problem, because the stapes is not vibrating as earlier, it is fixed now. So what happens due to that? Hardness of hearing will be there. So that is the most common complaint the patient will give, and paracusis, of course. Okay. Now otoscopy shows normal. Why otoscopy should be normal? Whenever you are doing otoscopy, you are seeing only, with the otoscope will help you see only this part, isn't it? It will help you see the external auditory canal as well as tympanic membrane. Now, where is the problem? The problem is here. Extra bone is getting deposited in the footplate area. Now, what you are seeing, tympanic membrane, you are seeing on otoscopy. So obviously, you will see a normal tympanic membrane only most of the times. Sometimes in 10 to 15% of the cases, if active otosclerotic process is going on, increased blood supply, increased vascularity, so reddish color may be there. When I am seeing with the help of otoscope, through the normal tympanic membrane, a reddish hue on the promontory, I will be able to notice. A reddish hue over the promontory, I will be able to notice through the normal tympanic membrane. That is called as Schwartz sign. And so the patient is complaining of hardness of hearing. I will do tuning fork test. And obviously otosclerosis will cause conductive hearing loss, because this is a middle ear condition. So conductive hearing loss, I will get conductive pattern, Rini negative, Weber towards same side. And so to confirm my findings, I will send the patient for pure-tone audiometry. Now, pure-tone audiometry will confirm the conductive hearing loss. It will also tell me how much amount of hearing loss is there, mild, moderate, severe, how much it has happened, and it will show me Carhart's notch sometimes. Don't think that Carhart's notch is seen in every case of otosclerosis. No, it's not like that. Only few times, only 15 to 20% of the cases you will see Carhart's notch. Okay. Now coming to the impedance is specific AS type you will see. Okay. So the moment you are seeing AS type, the moment you are seeing conductive hearing loss, the moment you are seeing normal tympanic membrane, all these should point you towards otosclerosis. That's how you clinically diagnose otosclerosis. Now, the treatment for that, the next part, the treatment is purely surgical. Stepidotomy is better than stepidectomy. And if the patient is not fit for surgery, then go for hearing aid. Now, what is this stepidotomy? What is this stepidectomy? Otomy, opening. Where I am doing the opening? I am doing an opening in the stapes footplate. See, the stapes footplate is present here. I didn't remove the stapes footplate, whereas I have removed the other part of the stapes, suprastructure of the stapes, above structure of the stapes, the two crura, the posterior crura and the anterior crura and the head and neck, all these parts I have removed. Now, incus is separate, stapes footplate is separate. In that footplate, I will make a small opening, and into that opening, I will insert this piston. So I will insert this piston. To the incus, I will crimp this part. I will crimp this part to the incus. I will take the support of the incus, I will crimp this. Now, whenever the sound is coming and striking on the tympanic membrane, the malleus, incus, and now the prosthesis will vibrate in the otomy, in the stepidotomy. The prosthesis will vibrate freely. All the sound energy hitting, all the vibrations are sent into the cochlea. Now the patient will regain the normal hearing. Earlier what happened? Step is fixed. Stapes is not moving, sound is coming here and it is not moving. The inner energy is dampened, didn't pass to the cochlea properly. Now what is happening? The entire sound, whichever we are sending, is passing through the piston into the cochlea easily. Now the patient will hear much better. Okay. No. You are not removing the extra bone, for your kind information. Stepidectomy. Okay, stepidectomy means even this footplate is also removed and the prosthesis is kept like that, and the prosthesis may go here and there and may get dislocated. Also, this part will keep on irritating the perilymph and the saccule here, causing giddiness to the patient. So chances of, if I remove the foot plate, if I go for stapedectomy, if I remove the foot plate, chances of dislocation of the piston are very high. Okay, chances of giddiness are very high. Understood? Okay, so always stepidotomy is better than stapedectomy. At that time, stepidotomy was not that famous. Stapedectomy was most of the people doing. But nowadays, if the question comes, now you need to go for stepidotomy only. Okay, so a primipara is evaluated for hearing impairment worsened during her pregnancy. The moment you see this line is otosclerosis. Renin negative in both ears means bilateral, and Weber laterals to right side means right side more than left side. So tympanic membranes are appearing normal. Carhart's notch. So treatment of choice is always stepidotomy. Okay. Now see, this is stapedectomy. See the piston taking the help of the incus, long process. The piston is placed like this, but this is a free space. No, entire foot plate is removed. No, the piston may fall like this. Piston may fall like that. Okay, it is free to move here. See, the foot plate is kept here in stepidotomy. Now, through the small opening, exactly I have fitted the prosthesis taking the help of the incus. Now, this will not move. So that's why stepidotomy is better than stapedectomy. Okay. Is that clear? If not, pregnancy. But still, audiometry shows a dip in bone conduction at 2000 Hz. Tympanic membrane appear normal. Again, this shows otosclerosis only. Even if this line is not given also, this shows otosclerosis only. So from the options, if you see, if this is tympanoplasty, see, tympanoplasty is done for what? CSOM. Now CSOM means perforation should be there. Now perforation is there. How can the tympanic membrane appear normal? On otoscopy, tympanic membrane should not appear normal if it is CSOM. So tympanoplasty cannot be an option here. Now, if you do it in a highly sterile environment, that does not cause any infection. Okay, a pregnant woman presented with hearing loss. So this should be otosclerosis. Otosclerosis means ossicular fixation, intact tympanic membrane will be there. Now coming to the audiogram of a 30-year-old female. So, okay, now open your eyes widely and see the other wave clearly here. Okay. Okay. So at the audiogram of a 30-year-old female, now see at 2000 Hertz, a dip is there. A conductive airborne gap is present in between. Conductive hearing loss is there. So this is otosclerosis, right? Okay. This is otosclerosis. This is Meniere's disease. This is your noise-induced hearing loss, and this is your presbycusis. So you are able to differentiate everything very clearly now. Remember, from audiometry, definitely you will get a question. No doubt. Tuning folk test, one question. Audiometry, one question. See the last 4 to 5 years trends. You are having a lot of questions from audiometry and tuning folk test. Be careful here. Okay. Now coming to the glomus tumor. Is a vascular tumor, paraganglioma, and two types, glomus tympanicum, which tympanicum means tympanum, middle ear, glomus. So the glomus is arising from the tympanum, from the middle ear only. So this is confined to the middle ear only. Okay, it does not spread to any other areas. It is confined to the middle ear. But the other form, glomus jugular, this is arising from the jugular bulb below the floor of the middle ear. Jugular bulb is present. So from there the tumor is arising. So from there the tumor is arising. It is not shown here. This is tympanicum only. Now it arises from jugular bulb, erodes the floor of the middle ear and enters into the middle ear. So this is invasive. This is invading, eroding the floors, okay, and invading inside, isn't it? So this is very dangerous one. Okay, this is not so dangerous, but this is dangerous one. This is not so dangerous, but this is dangerous one. It has the capacity to keep on growing, invading, going into the mastoid and going into the cochlea and going and pushing the internal carotid artery, going into the vestibule. So it has the capability to erode all the bony walls and keep on extending intracranially also sometimes. So main presentation is pulsatile tinnitus because this is a vascular tumor. So whenever the blood is flowing through, the transmitted pulsations will come here, and always with every pulse rate and with every pulse, the tumor will be beating inside. So the patient will be constantly hearing the tinnitus sounds. Pulsatile tinnitus will be there. Okay, as the tumor is filling the middle ear, so the middle ear impedance is gone. So now the patient will be having hardness of hearing. isn't it? Now, on otoscopy, when I put an otoscope from here and see, I can see a small reddish tumor that is arising from below above. That you call it as rising sun sign and brown sign or pulsation sign. If I put a seagull speculum here, increase the pressure, that will push the tympanic membrane further inside. Now the middle ear will become a tight, airtight cavity. Now what happens? Due to that pressure, the tumor immediately vigorously pulsates first and then blanches. So the patients, whenever I increase the pressure with a seagull speculum, now what happened? Pressure increases, then first immediately pulsatile tinnitus will increase and then the tinnitus will blanch. Okay, so that's what you see on brown sign or pulsation sign. Now, what is this aquino sign? Simple, compress the same side ipsilateral carotid artery, the same side blood supply is reduced, the glomus shrinkens and the tinnitus reduces. Okay, that is aquino sign. And on imaging, if I send the patient for imaging, if I send these two patients for imaging, see in between the jugular and as well as the internal carotid, there is a spinous bony process that you call it as carotico-jugular spine. Carotico-jugular spine. This is the carotico-jugular spine. Now, on the affected side, when the tumor is growing, it completely erodes that carotico-jugular spine. So here, if I see the spine will be normal because the tumor here cannot erode the bone here. So in glomus tympanicum, Phelps sign is not seen. Erosion of the spine is not seen. This is seen in jugular only. Hope you are understanding. The imaging of choice, whenever it is vascular, you are suspecting a vascular tumor, always go for contrast enhancement. Wherever in your entire body, you are suspecting vascular tumor, you suggest contrast enhancement. That's very important, right? Okay, so treatment is again surgical excision. So before that, this is a vascular tumor. You have to reduce the blood supply. So you can pre-embolization can be done of the feeder vessel and then reduce the blood supply so that blood loss can be decreased during surgery. A female presents with conductive hearing loss and in otoscopy, a red and bulgy mass behind intact tympanic membrane. You know the diagnosis, it is glomus tumor. Okay, what is serous otitis media? Plain middle ear. Okay, this is your glomus tumor. This is your serous otitis media. Okay, serous fluid is filled in the middle ear. Tympanic membrane is normal. Here, this is chronic otitis media where perforation and purulent discharge will be there. And this is otosclerosis where tympanic membrane is completely normal. A 70-year-old present with neck nodes. Examination of left ear reveals a dull tympanic membrane, and type B curve is obtained. Deafness, tinnitus are noted. Most probable. For example, if this is a case of CSOM, in CSOM, what you should see? Perforation you should see. But what the question is telling, tympanic membrane is dull. Okay. So examination of left ear should reveal perforated eardrum if this is a case of CSOM, isn't it? So dull tympanic membrane means it cannot be CSOM. So first option eliminated. Okay, now come to the glomus tumor. If it had been glomus tumor, which is a benign tumor, where come these neck nodes will arise? In a benign tumor, you can't expect any neck nodes to come. And moreover, in the glomus tumor, the tympanic membrane is normal. Tympanic membrane is normal in the glomus tumor. Tympanic membrane is not affected, isn't it? So deafness you can notice. Conductive hearing loss may be there. Tinnitus, pulsatile tinnitus is there. Type B you can obtain. But neck nodes are a negative for glomus. Dull tympanic membrane is a negative for glomus. Now come to nasopharyngeal carcinoma. Neck nodes is a carcinoma. Yes, possibility. Due to nasopharyngeal carcinoma, Eustachian tube blocked serous otitis media. So in serous otitis media, you will see dull tympanic membrane. So conductive hearing loss that will cause deafness and tinnitus sometimes you can see. Also, serous otitis media causes type B curve to be obtained. So nasopharyngeal carcinoma fits better in all of this. Okay. If it is sensory neural hearing loss, so this is not at all related to middle ear. If middle ear is normal, you should get A type of curve. SNHL means cochlea and retrocochlear lesion should be there. So means middle ear should be normal. अगर middle ear normal है, तो impedance A type होगा and tympanic membrane should be normal. And in SNHL, why come lymph node, neck nodes will be there. You understood how to eliminate and get the answer right? Elimination. Understood? Okay. So this is serous otitis media. Okay. And this is your glomus tumor. And this is your CSOM. Hope you understood now. Always elimination is the best method for answering an MCQ. Remember that. Before opting for an option, or if you are directly going to a correct answer, just check the question completely once and see every point is matching with the option. Okay, then you go. A 35-year-old woman presents to you with complaints of difficulty in hearing in the right ear, which is slowly progressive. She has tinnitus, which is pulsatile in nature, and reddish mass was seen, and tympanic membrane, audible bruit is present, and auscultation, which is rhinitis is negative. Which of the following? Now again, this is a glomus tumor. Now coming to the Eustachian tube. So it develops from the first pouch. We have studied this already. Now coming to the anatomy. So it is 36 mm anterior, outer 1/3 bony, inner 2/3 cartilage. You all know that. So it opens in the middle ear on the anterior wall and it opens into the nasopharynx on the lateral wall, 1 centimeter behind the inferior turbinate. So you can see this Eustachian tube opening. So if you see this Eustachian tube opening, okay, in your nasal cavity. So this is your inferior turbinate. This is your middle turbinate, superior turbinate. So 1 centimeter behind that, here you will see the Eustachian tube opening, which is connected to your middle ear. Okay. So here is a tympanic membrane, external auditory canal, pinna, isn't it? Right. So this is how this thing is present. So, and where this Eustachian tube is opening into the nasopharynx, the posterior wall forms an elevation. The posterior wall of the Eustachian tube forms an elevation called as torus tubarius, and behind that immediately there is a depression called as fossa of Rosenmuller. That is the most common site for carcinoma nasopharynx. That's why when a tumor forms here and infiltrates this area, the Eustachian tube gets blocked. Now once the Eustachian tube gets blocked, retrograde serous fluid collection, serous otitis media, conductive hearing loss, type B audiogram you will be getting. Understood? Okay. Now this is your posterior pharyngeal wall. Now coming to the length of the infant is almost half that of the adult, and almost the infant Eustachian tube is straight and the lumen is wider. So what happens? This short, straight, and wide Eustachian tube is responsible for the repeated ear infections from URTI. So the tube is very short, straight and wide, isn't it? The tube is very short, straight and wide. Okay. Whereas in adults, it is long, angled and narrow. Isn't it? So from here to here, from the nasopharynx to middle ear, the infection can spread easily. From here to here, it takes a little bit difficulty. Okay. So in children, that's why the URTI, and from there URTI are most common. And so what happens? The middle ear infections will be more common. Whenever winter comes, you can see in your clinics, the parent will be bringing the child with complaint of ear pain, but the parent will not complain of ear pain. So the reason is that in the Eustachian tube is short, straight and wide in the children. Okay. Now coming, okay. Now coming to the otitis media. Now coming to the ASOM. Just a second. Let me have a bit of water. Hope you are able to follow the class now. After the year, we'll take break. 1 hour में year हो जाएगा. After the year, year के बाद break after the year only. Now coming to ASOM, acute suppurative otitis media. The name itself is telling you everything. It is acute in onset. Whenever there is acute infection, acute thing, what happens? Sudden changes. So pain will be there. This is suppurative, means bacteria are causing suppuration. Pus production is caused by bacteria. Otitis media, middle ear is affected. Acute suppurative otitis media. Pain is there. Pus production is there in the middle ear. Understood? Now, what is the sequence? What are the stages? Stage 1 is tubal occlusion. Now, whenever the Eustachian tube gets obstructed, why the tubal occlusion should occur? What happens? What is the lining in the inside? Endodermal mucosal lining is there. Now, in children, upper respiratory tract infections are more. Whenever there is a upper respiratory tract infection, the mucosa edema, okay, the mucosa will become thick, edematous. Now, when the surrounding mucosa gets thick and edematous, what happens to the lumen? Reduces, isn't it? The central lumen reduces. The central lumen reduces when the surrounding layer thickens. When the surrounding layer all around the tube thickens, what happens? The central lumen reduces. Now that's what tubal occlusion. Now when the tube gets occluded, what happens? Whatever the air that has been present before in the middle ear, slowly it is getting absorbed into the surrounding vasculature. Once the entire air is absorbed, tube is blocked, no further ventilation, no air present inside means vacuum. Vacuum means negative pressure. So due to this negative pressure, what happens? The negative pressure starts pulling everything towards its side, inside. But all these are bony margins. They cannot move. This is the membranous part. Now this starts moving inward. Now this is forcibly pulled inward, retracted tympanic membrane you will see. So hyperemic eustachian tube means tubal block causes negative pressure buildup in the middle ear that retracts the tympanic membrane inside. So due to this negative pressure inside, complete block, everything negative blocked vacuum inside, you feel ear block due to pulling of the tympanic membrane, active pulling of the tympanic membrane inside, retraction, it causes mild earache. Now, in the next stage, pre-suppuration stage, that means before suppuration, before pus production, as the negative pressure increases, as the mucosal inflammation spreads from the, see, the first it started in the URT, upper respiratory tract, nasopharynx. Then it spread to the eustachian tube. It blocked the eustachian tube. Now the same inflammatory infection, bacteria, is spreading inside into the middle ear. Now the middle ear mucosa, everywhere, it also gets inflamed completely. Now the tympanic membrane will also get inflamed. The inflamed tympanic membrane, in inflammation, what happens? Blood vessels will dilate. Inflammation means redness. The redness is coming from where? More blood supply. Why more? How more blood supply will be able to come? When the capillaries engorge, veins or arteries, capillaries dilate. When the capillaries dilate, they will become more prominently visible. Normally, normal sized capillaries are not visible. Now, when they engorge, filled with more blood, the reddish color is imparted and that the reddish color will be coming. Now, the earlier present vessels are now present more prominently reddish in color. Normal blood supply to the eardrum will be like this. The main artery will be coming along the handle of malleus. From the tip, it will be giving multiple branches to the periphery in a radial manner, like the spokes of a wheel. Normally, they are not visible. During times of inflammation, due to the engorgement or dilatation of the blood vessels, they will be visible. They will be visible in their regular anatomical configuration, that is cartwheel appearance. So you will see a cartwheel congested reddish tympanic membrane in pre-suppuration. So as the tympanic membrane retraction is still increasing, the earache still much increases due to the increasing inflammation, spreading inflammation from here and here everywhere. Now the bacteria starts producing the pus inside. Now the pus in the middle ear will push the tympanic membrane outward. Now if you see this tympanic membrane, it will be bulging. It was red. Now, apart from that, it is bulging outside, and that bulge is due to the pus forming in the middle ear. The pus is cream in color. You can see the creamish color through the intact tympanic membrane. So the red and bulging tympanic membrane you can see, and if you do not treat it properly, at the weakest point, due to the increasing pressure by the pus inside, severe pain will be there. At the weakest point, if it is not treated within time, it perforates the weakest area, mostly in the anterior-inferior quadrant. It perforates, a small pinhole perforation occurs, and all the pus starts draining out from inside. All the pus goes outside. Once all the pus comes outside, the inside pressure is relieved, pain will be reduced, but the pain reduced, but discharge started. So pain followed by discharge is the typical characteristic of ASOM. First, the child will be complaining of pain. then later discharge starts. And when discharge starts, pain won't be there. Most of the parents bring their children in discharge stage because when something starts coming out of the ear, they get worried. When the child complains of pain, this guy will go to the nearest pharmacy, get some painkiller and give it. But your NSAID painkiller or any random ear drops won't decrease the infection here. And moreover, you are installing the ear drops here. But actually, the problem is completely here. You have to give nasal decongestants. Natural airflow ventilation should increase. The congestions, the surrounding nasopharyngeal congestion should reduce. And that reduced congestion spreads inside. Now, proper ventilation takes place. Now, all the pus gets drained out. Now, the middle ear becomes normal slowly. So, nasal decongestants play a very important role in this ASOM condition. But see, the parent is, as the child is complaining of ear pain, the parent is giving only ear drops. What is that? Okay. The most apt example, there is a fire accident in your home. What you are doing? You are pouring water in your neighbor's home. So that does not make any sense. Okay. Absolute senseless. Yeah. Now, so if the child has been treated promptly, now what happens? The complete congestion, the reddishness reduces, becomes normal. So this is a resolution phase. Okay. Now coming to the OME. Okay. So what is the treatment option here? Antibiotics, nasal decongestants, analgesics, and antihistaminics to reduce the mucosal edema. And if it is recurring or if it is repeated, go for myringotomy. Okay. Now, coming to the OME, otitis media with effusion. So this is nothing but the same. So sterile serous fluid will get collected in the middle ear. Here in ASOM, it was completely infective. What are the most common causative organisms for ASOM? Streptococcus and Haemophilus. If you have to select one, Haemophilus. In ENT, everywhere it is streptococcus, right? Everywhere. And Haemophilus, right? Okay. The same in acute epiglottitis also, you see. See, it is residing in your throat. It can go down and infect the epiglottis. It can come up through the Eustachian tube into the middle ear and can cause ASOM. Okay. Yeah, most of the times children have a very high rate of healing capacity. So it heals. Definitely the perforations heal most of the time. Even before it healed completely, another episode of ASOM can and you didn't give medicine properly and that perforation is constantly staying for longer durations like that. Now it becomes CSOM, permanent perforation, non-healing perforation. Now coming to the OME, sterile serous fluid collection. Here this is not infective in origin. In fact, this is mechanical, obstructive in origin. Now what happens? The Eustachian tube gets obstructed by the adenoid hypertrophy due to common cold or everywhere viral infections or whatever infections. Sometimes your adenoid tissue hypertrophies. If the organism is not spreading inside, just it is causing adenoid hypertrophy. Now the adenoid hypertrophies or due to some allergic stimulation, adenoid gets hypertrophied. It blocks due to some congenital genetic tendencies, the lymphoid tissue hypertrophy, adenoid tissue hypertrophy occurs. It blocks the Eustachian tube. That mechanical blockage of the Eustachian tube. Another reason is nasopharyngeal carcinoma. Now the nasopharyngeal carcinoma grows here on the posterior wall, the fossa of Rosenmuller, and it pushes the wall inside and it blocks the Eustachian tube. Now normally the Eustachian tube is draining all the secretions of the middle ear. You know the middle ear mucosa is having a mucus cells and serous cells. Mucinous secretions, serous secretions will be present over here. All these secretions will be making sure it is washing your middle ear regularly. See, whenever you are bathing, your water will flow till here only. It cannot pass behind this. This area is cleaned by the body itself by its regular natural secretions. And because this is exposed to outside, no? From the nose, outside air is entering into, no? Outside air is entering into the middle ear, no? Through the Eustachian tube. Outside air has got many things in it, isn't it? So many things are there inside it, isn't it? Which you can't see. So, ये सब अंदर जाके अगर if they are getting accumulated there or causing any damage, your middle ear can't stay healthy for longer durations. So to keep itself protected from the outside air and all other particles, your mucous serous glands will be secreting all the secretions. So those secretions should go out, should not stay stagnant. A stagnant secretion will attract bacterial infection. So all these will be drained out through the Eustachian tube. One of the functions of the Eustachian tube is drainage of middle ear secretions. Understood? So if this gets blocked, the natural mucous serous secretions, everything will get settled here only. Okay. If the mucus part is more, it looks like a glue. Okay. So you call this also as glue ear. Okay, you call this also as secretory otitis media. If the serous secretions are more, the fluid will be thin, not thick mucus, like very thin, watery. You call this as serous otitis media. Okay, so multiple names are there for this, right? So now, as there is fluid filling in the middle ear due to the obstruction of the eustachian tube by the adenoid or nasopharyngeal carcinoma. Now, what happens? All the fluid gets accumulated here. Now, the sound is coming. Whenever the sound comes here, it strikes on the tympanic membrane that the middle ear is not air filled, now water filled. So now the impedance is gone here. Now the hearing capacity is lost. So the middle ear problems will cause conductive hearing loss. So otoscopy will show you multiple air fluid levels. Okay. Earlier air was there. Fluid is slowly filling inside. So air and fluid mixed together, you will be seeing in the middle ear. Presentation is just hardness of hearing, problem with the hearing problem. And pure tone audiometry, obviously, tuning fork test will tell you conductive hearing loss. But remember, adenoid is most commonly seen in children. So the serous otitis media is most commonly seen in children. And in children, if you do tuning fork test or if you do pure tone audiometry, they may not tell you the proper result, proper finding. You put tuning fork here, he says he's hearing here, he's hearing there, he's hearing there, he's hearing something is somewhere else. So whatever he wants, he will tell. You can't trust the Okay, you can't trust the results. I mean, the whatever the children tell you, you can't trust on that. So usually tuning fork test and pure tone audiometry are not considered here. You better go for impedance. If the fluid is there in the middle ear, it will show you B type, flat tympanogram you will get. So this is the most reliable investigation. Impedance is objective. Here, the child need not give any response. You fix the probe here. The probe will change vary the pressures and it will calculate the mobility of the tympanic membrane. So it is a device operated, completely operated by the device itself. You can even sedate the child and do the impedance audiometry. You will get the B type in serous otitis media. Now the treatment is you have to treat the root cause, adenoidectomy, and if recurrent, okay, you can go, okay. So along with adenoidectomy, you can go for myringotomy and grommet insertion. Give a radial incision in the anterior-inferior quadrant, and in the anterior-inferior quadrant, insert the grommet or ventilation tube. Now you have removed the adenoid hypertrophy. This will improve the ventilation. Okay, most of the times we will stop with adenoidectomy only. We won't go for grommet most of the times, but some surgeons are fond of grommets. So some people will insert because the blockage may not go immediately, their concept. So they will insert a grommet here. From outside through the grommet, the tube will be ventilating the middle ear. So many days. Recurrent means 3 months, 6 months, 1 year, 2 years. Okay, the serous fluid was there here, so it takes some time to all of this thing to clear off immediately. So meanwhile, this grommet ventilation tube, if you insert here, this will be ventilating, and this ventilation will clear off everything, and everything normalizes within 3-4 months, and this grommet will fall off naturally due to migration mechanism. Okay, I don't prefer grommet, never. I won't prefer grommet at all. Why unnecessarily? Okay. Why you want to give unnecessarily? Okay. Rather go for adenoidectomy. What happens, grommet, most of the times grommet should come outside. But what facilities the company, the preparing manufacturing company is having, what kind of quality material they are using. Okay. What kind of, okay, some thousands of grommets, any company, means any product you take, in 1,000, at least 1 to 2 defective products will be there. If your time is bad, If you get that grommet, you have inserted that. This may not fall off this side. Sometimes this will fall off into the middle ear. Now that becomes a foreign body. Now to remove that foreign body, see if it has fallen here directly with an otoscope, I can see that and I can remove that directly. Now if it has fallen into the middle ear, to remove that, I have to enter the middle ear, means I have to open up this, means I have to do a surgery again. Okay, so that becomes a big headache. Removing is easy only. Okay, you I can do a surgery and I can remove. But what about the parents, counseling the parents? What they will tell you? Okay, you didn't insert it properly. That's why instead of coming out, it went inside. You have inserted in reverse. Okay, you didn't study properly. You don't know anything. Okay, so that will be the okay. नहीं ग्रामेट 1 मिनट की काम है उसमें होता क्या ग्रामेट कॉस्ट इज ऑल्सो जस्ट 600 रुपीज उसमें होता क्या ओके वाई टू गो फॉर वॉट एवर इज द कॉस्ट डोंट वरी अबाउट द कॉस्ट बट वाई टू अननेसेसरली कॉम्प्लिकेट अनलेस until it is indicated okay A 5-year-old child brought with recurrent ear infections. Otoscopy shows a dull retracted with fluid inside. Okay, so that is your otitis media with effusion. Latest MCQ. Very easy questions are okay. You see a child with delayed speech development and otoscopic appearance. Okay, even if it is not shown, also you can. Okay, so acute suppurative otitis media. Where is that? Okay, okay, here it is given. Okay, Acha. Come here. The same question. You see a child with delayed speech development. Okay, so this is the image given. So this is your serous otitis media, right? So this is acute suppurative otitis media, cartwheel sign, ASOM you can see. This is CSOM where permanent perforation and discharge both you can see. And this is glomus tumor, you know that reddish tumor inside intact tympanic membrane. Okay, hope you are able to differentiate each and everything on otoscopy. So if image based questions are also increasing recently. So even if an image based question from the year comes also, hopefully it should be easy for you, right? Now coming to the cholesteatoma, remember 15 marks are there from ENT. It's easy to score. 15 by 15 you can score very easily. So those who are stranded in the 140s, so this ENT helps you come out of that safe. Okay, okay, that target. Okay, come into your target zone, isn't it? Right. So now coming to the cholesteatoma. Oh, sure. Most welcome. Now coming to the cholesteatoma. What is this cholesteatoma? Cholesterol containing oma means tumor. So it is not cholesterol containing tumor. That is a misnomer. Earlier people thought that it is a cholesterol containing tumor, but it is not so. Later on it was found that it is not a tumor and there is no cholesterol in that. But the term continued as such. So that is cholesteatoma. Okay. Now coming to the normal anatomy. If you see the normal anatomy, you know the outer ectodermal pouching, that is first cleft lined by ectoderm forming the squamous epithelium. Inner endodermal mucosal pouching. So endodermal inner layer is mucosal layer. You know that. In the middle, दोनों के बीच में middle fibrous layer will come. In the pars flaccida, it is not present. Middle layer is not present. Middle fibrous layer is not present. Now what happens? Sometimes don't know what happens to that. Okay. Sometimes, okay, it itself, okay, for sightseeing purpose, the squamous epithelium will go into the, okay, middle ear. Okay, will go into the middle ear. Okay. Itching होता है ज़्यादा. Okay. So it goes into a place where it is not supposed to stay. Now, so the squamous layer goes into the middle ear and most commonly it happens in the pars flaccida weakest area. Okay. Now what happens? Slowly, okay, it keeps on expanding itself. I told you this is a keratinizing type of squamous epithelium. This squamous epithelium has the capacity to produce keratin. Now it's producing keratin here also, but due to the narrowing of the neck of the retraction pocket, see, this is retraction. This is forming like a pocket. So this is retraction pocket. Now the keratin is forming here as usual. This is unable to come out through the narrow neck. Now whatever the keratin has been secreted, it got filled in the retraction pocket. Okay. Now this is called as retraction pocket. See, the keratin filled squamous epithelium lined sac surrounded by endodermal mucosal fibrous tissue, fibrous matrix and the middle fibrous matrix and the endodermal tissue. This is called as cholesteatoma sac. Okay, a pocket lined by squamous layer filled with keratin. This is cholesteatoma sac surrounded by fibrous matrix. That is cholesteatoma sac. This has got the ability to digest the bone whichever it comes in contact with. Okay, so that's why it is dangerous. So ultimately, it is described in single sentence: wrong skin at wrong place. Now, what is this wrong skin? Squamous epithelium. This squamous epithelium is the wrong skin, and what is this wrong place? Middle ear is the wrong place. Okay, in middle ear, this is not supposed to stay. Now, this comes. So the wrong skin in the wrong place is the cholesteatoma. Okay, congenital. Now coming to the types of the cholesteatoma, congenital and acquired are the two types. Now coming to the congenital type, see this what happens here. The epidermal cells somehow which are supposed to stay outside, okay, when they are traveling during the embryogenesis, some epidermal cells or ectodermal cells are left over inside in the middle ear. They are forming, they are coming like this and they are left over here. They actually wanted to come out, but they are a little bit late, delayed. So as they are delayed, what happens? By the time they come here, tympanic membrane formation already completed. Now, when the tympanic membrane formation already completed, these epidermal, ectodermal cells are blocked here. They do not have any way out. So they are lifetime late. Okay, they are lifetime late. Yesterday NEET exam, if you see 1 minute they went late and they are left out at the gate. Okay, now they have lost a chance. Okay, it may change their life, even lifetime delay. Okay, now yeah, so there is no other option for the authorities also. They have to maintain transparency. So it's now coming to the clinical features. Now the tympanic membrane has formed normally. It's just that some ectodermal cells are lying there, not doing anything, just silently sitting over there. Okay. Now there won't be any active clinical features and no clinical features are there. Then how do you diagnose it? How will the patient come to you? If you have to diagnose it, the patient has to come to you. Agar no clinical features are there, patient will come to you. No, patient will come with some other problem. Now, accidentally, incidentally, you will notice this. Now, when you see the tympanic membrane, most commonly in the anterior superior quadrant, through the normal tympanic membrane, inside the middle ear, anterior superior quadrant, you will see this cotton wool like of mass in the anterior superior quadrant. So that is your congenital cholesteatoma. Okay. Now coming to the acquired, there are again two types, primary and secondary. The primary is described by Whitmack's retraction pocket theory. This one is nothing but your retraction pocket theory. Whitmack's retraction pocket theory. Okay. Right. Now the second one is here. This is explained by Haberman's epithelial invasion theory. Here, why it is called as secondary means a pre-existing perforation is already present. A pre-existing perforation is already present. Through this perforation, the squamous epithelium went inside. Okay, understood? Now it started depositing keratin inside and caused damage to the middle ear structures. Understood? Now coming to CSOM. So what are the two clinical features of CSOM? Permanent perforation. Margins are epithelialized, isn't it? What do you mean by epithelialized margins? See, this is the margin of the perforation. This is the margin of the perforation. Now, this margin is covered by what? Epithelium. This margin is covered by epithelium. That is what you call it as epithelialized margins. See this picture carefully. You have that CSI picture. You notice these margins clearly here. Can you see the thickening of the margin here? The margin of the perforation, can you see the thickening of the margin of the perforation? So this you call it as epithelialized, thickened margins. Once the margins are epithelialized, thickened, there is no chance for the layer to grow and close this perforation. So while doing myringoplasty, ear surgery, we remove this thickened margin first. We remove this thickened margin first and then place a graft behind that as a support From behind, we will place a graft as a support. So taking that graft as a support, the new layer will grow on that. So if you see, this is a thick epithelialized margins. The epithelium will grow inward and touch with the join with the mucosal. Now, no chance that mucosal layer will grow. No chance that epithelial layer will grow like this because already it has grown like that. Now, obviously, middle layer once damaged will not grow forever, isn't it? Middle layer does not grow forever. A healed perforation will have only two layers, as you know. The middle layer is absent in a healed perforation. Okay, so that's why during myringoplasty, what you will do? What you will do during myringoplasty? We will remove the margins and from under the annulus, what we'll do? We will place a graft like this. We'll place a graft like this. Where is the middle ear? This is your middle ear. Okay. Where is the mucosal layer? Mucosal layer is here like this. Okay. Now, slowly what happens? Taking this graft as a support, bed, a vascular bed. This is connected to the posterior wall, this graft. Now the vascularity will start developing. Angiogenesis occurs in this biological tissue. Okay, temporalis fascia is taken and placed there. So the vascularity will increase and there will be vascular bed will be formed over here. New blood vessels, angiogenesis will start. New blood vessels will form here. More blood supply. So taking this support as a vascular bed, the new epithelium will regrow and they both will join to each other. Now this layer is completed and inside also taking this vascular bed as a support, new layer will form and they will form another new layer there. Over a period of time, this graft dissolutes later. And after 6 months or 1 year, if you see, this will be healed like that. That is the idea behind myringoplasty. Most of the idiots out there practicing in their early stages think that you place a graft like this, everything is closed. Okay, so this does not work unless you remove the margins. These margins needs to be cut. These margins need to be cut. Okay, some idiots don't know this concept. Just take a graft and they will put it like this. They think that they have closed that. Is it that easy? For that, the patient needs to come to you. For that, you call it as a surgery. Isn't it so? Okay, right? So that is what your myringoplasty, tympanoplasty is doing here. Okay. Types of CSOM. So safe type and unsafe type, also called as safe type, also called as tubotympanic. So this is tube and this is tympanum. Tubotympanic. The diseases in the middle ear, the CSOM that is caused due to the tubal diseases. So why the tube should get diseased? Due to the respiratory, upper respiratory, nasal infections or nasopharyngeal infections. Okay, so nasal means sinusitis. Mostly sinusitis patients will have this. Okay, CSOM. So in those patients, if you are going for CSOM surgery, if it is a tubotympanic type of disease, better look for any nasal pathologies first. If there are any nasal pathologies, first do nose correction. Do nose surgery, correct the nose first, and then go for ear surgery next. Otherwise, if without addressing the nose issue, if you go for ear directly, again, it may recur and again, it may be a problem later on. Okay. Understood. So tubotympanic. Now, unsafe is also called as atticoantral. See, the retraction pocket is going into the attic. From the attic through the additus into the antrum of the mastoid it is going. Attic to antrum it is going. So it is called as atticoantral disease. Now, coming to this, here the middle ear mucosa, the complete nasal mucosa, Eustachian tube mucosa, middle ear mucosa, first pouch, the endodermal mucosal lining is getting infected here. So this is the disease is related to mucosal disease. Here squamosal, the squamous layer is going inside and causing the disease. So this is squamosal disease. Now, central subtotal, these type of perforations you most commonly see here. Marginal attic you see most commonly here. Discharge will be profuse mucoid. Why the mucosa is getting infected here? In the mucosa, I told you middle ear is rich in mucus and serous glands. So when the mucosa is getting inflamed, edematous, what happens? The glands will get edematous, inflamed. So they start secreting more discharge and mucus glands will secrete mucoid discharge. So profuse mucoid discharge you will see. Here, squamosal disease, the squamous layer is damaging the bones whichever it is coming. So when the bone is getting damaged, that foul smelling stinky discharge, osteomyelitis you see in ortho cases, that mucopurulent blood stained foul smelling discharge, and as the bone, very small pieces of ossicles, bones are getting damaged, scanty discharge you will see here. Okay, so that is how you see these two types of discharges in CSOMs, right? Now coming to the treatment is purely surgical. So whatever is the problem, mucosal, squamosal disease, atticoantral or tubotympanic or safe type, unsafe type, whatever is the disease present. Okay, primary cholesteatoma, secondary cholesteatoma, retraction pocket is there, whatever it is, the treatment is purely surgical. Okay. Yeah, this is cholesteatoma only. Atticoantral. Cholesteatoma is a form of atticoantral disease. There is no difference. Cholesteatoma is not different from CSOM. Please remember this. Okay. Please remember this. Cholesteatoma is not different from CSOM. The atticoantral part is nothing but your cholesteatoma only. Okay. Unsafe one. Cholesteatoma is highly unsafe. Why? Because it is damaging the bones. When it is going upward, it can damage the cranial, skull base bone. Okay, that upper tegment, middle ear, up full roof. Once the roof is damaged, it can go into the cranium and damage all the cranial structures. It can go into the inner ear and damage all the inner ear structures. Permanent sensory neural. That's why it is unsafe disease. Okay, that's why the reason it is called as unsafe disease. Now, myringoplasty. When you will go for myringoplasty? Only tympanic membrane perforation, middle ear is normal, behind mastoid is normal. So I will go for only myringoplasty. All the ossicles are normal. So when everything is normal, I won't unnecessarily touch them. Okay, I don't have that much itching. So I will only clear whatever the problem is. So my job here is to only give the solution to the only problem present. I don't want to unnecessarily disturb the normal God-given parts. Okay. If the God-given parts are damaged, then I am here to repair it. Okay. When they are normal, I don't want to disturb them unnecessarily. Understood? Now, so that is what the principle you should follow in your surgeries. Okay. No, you are operating means you are recorrecting a pathology, isn't it? Not a physiology. You cannot, if it is physiology, means it is normal. Once it becomes a pathology, you have to correct it. Okay, you have to bring it to normal physiology, isn't it? Now coming to myringoplasty plus ossiculoplasty. So if perforation is there and ossicular necrosis is there, now you go for, along with myringoplasty, you will go for ossiculoplasty. As I am doing some correction in the tympanum, middle ear, it can be considered as tympanoplasty. Okay. Now, when you will go for mastoidectomy, now see this middle ear. How is the middle ear mucosa? Completely diseased. See the reddish inflamed middle ear mucosa. See the mucosa here, middle ear appearance here through the tympanic membrane perforation. See the middle ear completely normal. This is your normal appearance. This is your abnormal appearance. And see, there is some tissue. See, this is the promontory round window, isn't it? Means this is your posterior superior oval window area. Posterior superior part is connected to the mastoid behind. So here some tissue is growing and this tissue has been blocking the ventilation towards the mastoid part. So that means the mastoid might have got infected also. So in that cases, I will go for mastoidectomy. If the middle ear appearance is normal, simple funda, if the middle ear appearance is normal, don't go for mastoidectomy. If the middle ear mucosal appearance is abnormal or some granulation tissue or some abnormal growth tissue is there, go for mastoidectomy. Understood? Clear? Now coming to the meringoplasty, I already told you temporalis fascia is the most common and best results are obtained for this. The next one is tragal perichondrium. Now, what is underlay? What is overlay? Two types of meringoplasties are present. Underlay, see this annulus, peripheral thickened part of the middle fibrous layer. Under this annulus, I will place the graft, that is underlay. Over this, okay, annulus, just I will separate the squamous layer, and in between squamous and annulus I won't separate the annulus, so over that I will place that is overlay. Idiots will place overlay, so that is overaction. Okay, they think they are clever most, okay, most clever of all. Okay, so the all the idiots who are doing this, okay, this much difficult, elevating the annulus, placing underlay, supporting it with this gel foam bed, ab gel bed, all these people since doing from ages, they all are idiots. Now this newcomers will come, they place the graft like this over this, and directly they will think that they have done a surgery. Okay. So always underlay is better, even though hectic, tiring, and taking more time and needs more skill, but the results are evenly better, equally better. Okay. Now by default, most of the ENT surgeons, okay, will go for underlay only. Okay. Right. Now, coming to the ossiculoplasty, there are two types of ossicular replacement prosthesis. One is partial ossicular replacement prosthesis that replaces ossicles partially. Another one is total ossicular replacement prosthesis that replaces ossicles totally. Now, most common ossicle to get necrosed always is the Lingus long process. The reason is incus has not got any muscular attachment. No muscle attachment, no vascularity, means less vascularity. If muscle is attached, muscle has got more vascular. So more vascularity means less chances of necrosis. Less vascularity means more chances of necrosis. If you take the malleus, the tensor tympani muscle attaches to the malleus. If you take the stapedius muscle attaches to the stapes. But बीच में जो incus है, to that incus no muscle is attached. So comparatively less vascularity. Also the long process of the incus is long and tender. So that long and slender anatomy, the thin, long and slender anatomy, so easily it can get necrosed. Okay. So how to remember easily? दोनों के बीच में फंस गया तो सबसे पहले खत्म हो गया, और ऐसा आप याद रख सकते, you can remember in that way. Now apart from the incus long process, the next most common ossicle after incus is gone, now it's the turn of the, now when it comes to malleus and stapes, the stapes is the second bone to get necrosed. 99% of the clinical cases you will see these two only. Of that 99%, 90% you will see these cases only. If I get 100 cases of ossicular necrosis cases, 90 cases I will see this case, and 9 cases I will see this case, this also, and in only at least that one case I may see entire ossicular necrosis or, okay. So usually we consider if incus only gone, partial ossicular necrosis, incus and stapes suprastructure gone, we take it as total ossicular necrosis. So that's why in this case I place a PORP, in this case I place a TOP. This is considered as TOP, this is considered as a POP. Whatever you are using, PORP or TORP or whatever you are using, the ultimate idea is whatever the sound waves are coming from outside, they are striking on the tympanic membrane is vibrating. All these vibrations should be transferred to the cochlea inside. Means there should be a continuous medium in between from external ear to the inner ear. The middle ear should act as a bridge. There should be a continuous conduit or some continuous medium, solid medium for the sound waves to travel into the inner ear. Okay, so that is the ideology in the middle ear surgery. Okay, in the hearing reconstruction surgeries, whatever you do, this is the idea. You have to maintain the continuity. That's it. That is the idea. So if you don't want to use this artificial prosthesis, take the tragal cartilage, take the conchal cartilage, whichever as per your wish, and shape them, and you can place it directly. Okay. Yeah, we'll take a break. 2 hours over, no? So we'll take that. After mastectomy, we'll take a break. So what is this mastectomy? I told you whenever you are finding middle ear mucosa abnormal, go for mastectomy. Now, mastectomy, if I see from superior view, see my external auditory canal is anterior. Behind that external auditory canal, behind this external auditory canal, mastoid is there. From above, I am seeing my external auditory canal is running from outside to inside. Behind that, the mastoid is running from outside to inside. Okay, understood? The superior view. Understood the superior view, right? And if I go along the external auditory canal inside, the tympanic membrane will be there, and inside middle ear will be there. And if I go to the mastoid, through the mastoid, if I go inside, that will land in the antrum inside, which is behind the middle ear. Okay, and attic part of the middle ear, epitympanum. Attic is connected to the antrum through auditors. You know that, right? Okay. So what is mastoidectomy? So mastoid is made up of multiple honeycombed air cells. The bone is like a honeycomb. So some thick bone you will see here first. Okay. And multiple honeycombed air cell pattern you will see. Understood? Okay. And what do you mean by antrum? Largest mastoid air cell is antrum. Isn't it? Right? Now, normally, if the middle ear is normal, which is anterior-inferiorly connected to Eustachian tube into the nasopharynx, whenever I am taking the air through the nasopharynx, Eustachian tube, middle ear into the mastoid, the ventilation is happening into complete mastoid. Till the mastoid tip, the ventilation is happening. This ventilation can happen only when all these structures are normally getting ventilated. When the eustachian tube is normal, middle ear is normal, auditors is normal, antrum is normal, all these air cells are normal, the ventilation can happen into this complete and everything stays healthy. Everything stays healthy when the ventilation is happening. Now, if there is any tubal block, middle ear disease, okay, CSOM is there. Now, sometimes the ventilation path is affected or the discharge from there repeatedly, the mucopurulent discharge repeatedly came into the antrum, infected the mastoid air cells. The mucosal lining here also is getting completely affected. Now, in that cases, you will go for mastoidectomy. Now, before going for mastoid, see, from outside, I can't directly see the mastoid. What is there? Skin is there. So if I have to reach the mastoid to remove that, first I have to give an incision. So what is the incision you take here? That is called as Wildy's postoral incision. In the postauricular groove, you will take an incision here in a curved fashion all along the mastoid from top to bottom. So that is Wildy's incision. Now once I take the middle Wildy's incision, once I give an incision here, this side one skin flap, this side pinna flap. Okay, this side pinna flap will be there. So pinna flap will be pulled to this side and this side will be pulled like this. So there is a retractor. We have got a mastoid retractor. That retractor will keep both the skin flaps open like this. We don't need two assistants to keep on pulling them both sides. The self-retaining Mollison's mastoid retractor is there. That will keep this both open, skin open, and directly under the skin, the other tissues will be exposed. Now, see the skin, when I have incised the skin and when I have retracted them, now in front of me, subcutaneous tissue and the periosteum is there. Now, I will give an incision and I will separate the periosteum also. Now, directly in front of me, mastoid is there. I take a drill, okay. See, this is the cartilaginous part of the external artery canal, behind which the soft tissue is there. This is the bony part of the external artery canal, behind which bony mastoid is there. This is your pinna. Okay. Now, see the skin covering everywhere on the pinna, isn't it? Now, I have incised the skin. I have separated the subcutaneous tissue. I have come onto the surface of the mastoid. Now, I start drilling the mastoid from here. Now, I start drilling the mastoid from here with a bone drill. I'll take a bone drill and start drilling the mastoid. Now, I keep on going inside. Now I keep on going drilling. So at which point along this entire mastoid, where I should drill the bone, at which point I should start? That is, first I should be able to identify the McEwen's triangle. What is this McEwen's triangle? See, this is external artery canal, mastoid part behind. Now you draw a line along the postero-superior wall of the external auditory canal. So this is the external artery canal, postero-superior wall. This is the postero-superior external artery canal. So this is a postero-superior wall. You draw a line over the postero-superior wall here and draw a tangent. So this is your superior temporal line. A superior temporal bony ridge will be present and you draw a tangent to the postero-superior wall line here. So this is the postero-superior line. A superior temporal line will be there. And to this Posterior wall line, you draw a tangent like this. So you get a triangular area that is called as McEwen's triangle. Here, spine of Henle is also present. Now I identify the McEwen's triangle and I keep on drilling inside. See how much length inside I should drill inside. What is the length of the bony external artery canal? 1.6 centimeters. So the same 1.6 or 1.5 approximate. Okay, 1 millimeter does not make much difference. So 1.5 centimeters, if I drill inside, I will land in the antrum. Now I have drilled means what I have done here, I have removed all these air cells and I have made it into a common cavity. I have made it into a common cavity. I have removed everything here. I have made into a common cavity. Now, there is no point of any obstruction now. Whatever the ventilation is happening from the Eustachian tube, everything gets ventilated. Entire mastoid now gets ventilated properly. So no chance of further mastoid disease here. No chance of any pathology forming here later on. Hope you understood the idea behind mastoidectomy. Okay, understood? So this is the retractor that we use. Okay, right? Now canal wall up and canal wall down mastoidectomy. Okay, so you take a break and come. It is 2 hours now. From now onwards, we have been given till 3 o'clock, right? 10 to 3 is the ENT part, right? Okay, isn't it? So that's why I'm going a little bit slow, isn't it? Yeah, 5 hours have been allotted to us. 10 to 2, 2 p.m. Even no problem. We can complete it, no problem. So go fast, take a 10 minutes break and exactly 12 now. At 12:10 we will start. No problem. By 2 o'clock we can complete. Don't worry. Don't worry. Even before only I'll complete. Don't worry. Okay, 10 minutes break. So hope you all are back now. Okay, 1 minute extra only I have given. Now, yeah, canal wall up and canal wall down. So with respect to mastoid, if I'm talking about a canal wall means, see this is your canal, superior wall, anterior wall, inferior wall, and posterior wall. So if with respect to mastoidectomy, I am talking about canal wall means it should be posterior canal wall. During the mastoidectomy, if I am not removing this wall, that is canal wall up, and during mastoidectomy, if I am removing this wall, if I am downing this wall, that is canal wall down. Now, so this is canal wall up and canal wall down. Hope you understood. Okay. Now, if you see in a superior view, after canal wall up mastoidectomy, see this partition wall between the canal and mastoid. I am not removing that. So everything will be like your normal only. Only this mastoid inner bone, that whichever has got infected, I have removed everything here. Okay. And I am suturing the skin from above, closing from outside as usual. Normal. So this canal will be normal, and I am placing a graft also to close the perforation here. Post surgery, this ear will look as normal ear only. Okay, here graft will be there. Canal wall I didn't remove, but here I have removed the canal wall. Now when I have removed the canal wall, placing the graft also becomes difficult. Okay, so here when I put an endoscope or otoscope inside and see, I will see a very huge large cavity inside. Okay, so one big cavity I'll be seeing from inside, but this will be like that of a normal ear only. Okay, so usually this is done in safe CSOM, this is done in unsafe CSOM. You are seeing some cholesteatoma, so better you go for unsafe type. Now here recurrences will be more, here recurrences will be less. Why here recurrences will be less? Even for example, if any cholesteatoma or anything, some infection has occurred here or middle ear or antrum anywhere. Now, in my OP cabin itself, the patient comes to me. In the OP, I will see him in OPD basis. Now, when I put the scope inside, directly it is in front of me. I can directly remove it outside. Whatever is there here everywhere, whatever is the issue, I can directly remove it outside. But here, if there is any recurrence here, again, I have to open the graft, open the tympanic membrane, means I have to go into the middle ear. I have again I have to do the surgery here. Okay, so for an unsafe CSOM, means for an unsafe type, I don't want any recurrence to occur. So I will better go for canal wall down, which do not have any recurrences. For a safe type, even if recurrence also happens also, there won't be any tissue because it is safe type. It is not damaging any other surrounding structures. This unsafe type is damaging the surrounding structures. I don't want any recurrences, so I will go for canal wall down. Hope you understood. Swimming is contraindicated. Whenever this patient goes into the water, water comes and touches the lateral semicircular canal, stimulates it, and immediately giddiness will come and patient will disorient, and by the time he recognizes, he will be drowned. Okay. Now, migration mechanism is lost. Why the posterior wall is lost? So the air which is coming and see the air which is coming and ventilating along the walls. From the center air will come inside and from the periphery it will ventilate outward. Now here that is lost. That ventilation mechanism is lost. The migration mechanism is lost. So it leads to accumulation of all the keratin here itself within the cavity. So this accumulated keratin needs to be removed every 6 months. So the patient needs regular follow. So every 6 months he has to come. Whatever the keratin debris accumulated inside, he has to get it removed. Here, the original migration mechanism, the new cells are formed here. Old cells are pushed outward. Also, the air is coming in the center and flowing through the peripheries. Now, it is adding up to the migration mechanism. So this here everything now anatomy is normal. Here anatomy is distorted. So here even if the air comes inside, so not narrow space is there, broad space is there. So no proper ventilation mechanisms are there. Here, it is like a normal ear. The migration mechanism is going outside. So this part of the keratin will be going outside. But here, this part of the keratin may come out, but whatever is present, everything is exteriorized, keratinized. Now all the keratin will be forming over here only and getting accumulated. So every now and then, every 6 months, lifetime, throughout the entire life, every 6 months, this patient has to come, remove this debris and go. Now coming to the Wolstein's types of tympanoplasty, simple anatomy. So you know the anatomy, you know the Wolstein type. So if you are placing the graft on the malleus, type 1. Now go inside, next to the malleus, incus is there. If you are placing the graft on the incus, type 2. Now still go inside. If you are placing the graft on the stapes, type 3, Miringo, Stepidio, Pexi, columella tympanoplasty, and still go inside. You are placing the graft on the foot plate, that is type 4. Okay, or cavum minor cavity is there. And if you are placing the graft on the lateral semicircular canal by making a fenestration, that is called as fenestration tympanoplasty. Why? Because here stapes is present, but it is fixed. It is not moving. So no point in putting a graft here if stapes is not moving. So you make an alternate opening here and put that there, graft there. Now the sound will go through the lateral canal into the cochlea. That's how it is done. So malleus, incus, stapes, foot plate, lateral semicircular canal. Malleus, incus, stapes, foot plate, lateral semicircular canal. 1, 2, 3, 4, 5. Okay. It's in sequence, same sequence. Okay. Now coming to complications of CSOM mastocytitis, the most common complication of CSOM, group A beta hemolytic streptococcus, the most common lighthouse sign. What is this lighthouse sign? See, through the perforation, the pus will be pulsating outward. In a pulsatile fashion, the pus will be coming outward. That is lighthouse sign. Coming to the reservoir sign, so the pus will be collecting. As soon as you remove it, new pus will come and collecting it. As soon as you remove it, another new pus will be coming and collecting. That is reservoir sign. Sagging of posterior meatal wall. See the posterior meatal wall. This is the canal. Okay. External artery canal. See the posterior wall, how it is completely protruding into the lumen of the external artery canal. So this is, you can see the pulsatile fashion also. So this is sagging of posterior meatal wall. If it is acute conservative, if it is chronic, you go for mastectomy. Now coming, in which condition is the reservoir sign seen along with mastocytitis? It is acute mastocytitis. Okay. Now coming to the various abscesses in relation to the mastocytitis, post-auricular abscess is the most common one. So you can see the post-auricular abscess here. See this side pinna and see this side pinna. On the left side pinna, you can see if the abscess is there, see how it is pushing the pinna. The pinna is pushed downwards, forwards, outwards, downwards, forwards, outwards. Because the abscess is here, it will push the pinna downwards, outwards, forwards. Now, post-auricular is the most common abscess you see. Along the zygomatic line, if the abscess occurs, that is zygomatic abscess along the zygomatic plane. Now, coming to the vagal abscess, below the tip of the mastoid, if the this is the mastoid, this is the tip of the mastoid. If the pus drains through the mastoid and from the tip it gets collected in the area below the mastoid, now that is called as vagal abscess. So to this area, anteriorly if you see angle of mandible is there, posteriorly if you see, what is the muscle running from the mastoid tip to the clavicle? Sternocleido. What is this muscle? Sternocleidomastoid. It has two heads arising from sternum and clavicle, sternocleido, and it is going towards mastoid, sternocleidomastoid. This is the sternocleidomastoid muscle. Now, posteriorly, this muscle will be there to the vagal abscess, anteriorly angle of mandible, medially digastric muscle will be there. So these are the borders of vagal abscess. Citelli abscess if it occurs in the occipital area, and Luke's abscess if it occurs within the inside the meatus. Okay, so this is battle sign seen in only trauma cases. All these are abscesses, infective history, battle sign, trauma history, not infective. Due to middle cranial fossa fracture, the mastoid ecchymosis will be there. Abscesses formed in this area. This is 2. Area 2 is zygomatic. This is vagal. This is post-auricular. This is Citelli, isn't it? Labyrinthitis. So now, if this labyrinthitis occurred due to CSOM, in CSOM already patient has got conductive hearing loss. Now, this infection has spreaded into the inner ear, means sensory neural hearing loss. So, patient already having conductive, now due to labyrinthitis, SNHL, both will be there. So, the patient will land in mixed loss. So, apart from that, what is there in the inner ear? What is there in the inner ear? Your vestibule and semicircular canals, they will cause, okay, vertigo. Okay, so treat the CSOM properly. This will subside, and it can be reversible if treated early. Okay, SNHL can be reversible if treated early. If treated late, it can lead to permanent SNHL. Okay. Now coming to perilimb fistula presentation, recent onset giddiness in a known case of CSOM. Now what happens when there is a, for example, some cholesteatoma is going inside. Okay, so this cholesteatoma is going inside and eroded this wall. This disease passed everything, eroded this wall of the lateral semicircular canal. Now inside this wall, bony wall, what is there? Perilymph is present in the inner ear. That perilymph is directly getting associated, exposed to the middle ear. So that's why this is called as perilymph fistula. Now, so what is this fistula test? Giddiness on pressing the tragus or seagulization. So whenever I press the tragus, the air column here is pushed inside through the perforation. The air pressure is exerted on the fistula here. If the bone is intact here, this pressure will not be exerted in the fluid, perilymph. If the bone is deficient, the pressure increased here will go and hit the perilymph directly. It will cause movement of the perilymph that will cause giddiness to the patient. So giddiness on pressing the tragus or seagulization. True positive means inside disease is present. And on fistula test, I am getting fistula test positive. So perilymph fistula. False positive, also called as Hennepert sign. Here, what happens? Meniere's disease, what happens? See, the black one is the normal saccule. The red one is the distended saccule. In Meniere's disease, what happens? The entire membranous labyrinth bulges. Now, when the saccule bulges, it lies near to the foot plate. Now, when I increase the pressure from here, what happens? The tympanic membrane moves inward. All the ossicular chain moves inward, and the inward moved foot plate touches the saccule. Okay, if the saccule is normal size, the foot plate will not touch that. If the saccule is distended and lying against to the foot plate, it may disturb that. Now when the saccule is disturbed, it causes vertigo. So on pressing the tragus, on seagulization, due to stimulation of the saccule, giddiness is occurring. On pressing the tragus, giddiness occurring. So this is fistula test positive. But is there any real fistula? No. So disease is absent. Fistula is absent, but fistula test is positive. You see in Venus. Now in syphilis, what happens? The stapes foot plate is attached to the oval window with the help of a ligament. In syphilis, the ligaments in your body are hyperstretchable. So if the foot plate is moving like this initially, due to hyperstretchability of the ligament, the foot plate will be moving with a large amplitude. Now when you put more pressure from outside, that will push the foot plate much deeper inside. Now, the saccule is normal in syphilis. In Meniere's, the saccule is enlarged, but in syphilis, saccule is normal. Now, the foot plate will go inside and touch the saccule due to hyperstretchability here. Now, this touches the saccule and causes the giddiness. Now, on seagulization, on pressing the tragus, there is giddiness. On pressing the tragus. So, fistula test is positive, but disease is absent. The perilymph fistula is not there. So in Meniere's and syphilis, you see this Hennebert's false positive fistula sign. True negative means you and me. I don't have fistula. On pressing the tragus also, I don't get any giddiness. So that is normal. False negative. Now, disease is present, but the test is negative. See, this is even dangerous. What happens? The labyrinth itself is dead here. If the labyrinth itself is not functioning, whatever you do, you hit it or beat it or okay, whatever you do, the labyrinth itself is dead. No response, no giddiness. Okay, fine. झूठ है ये. क्या झूठ है इसमें? Now coming to the caloric test, also called as Fitzgerald-Hallberg bithermal caloric test. Remember, whenever it comes to caloric test, remember the word cause. Cold opposite, warm same. If you pour cold water, okay, nystagmus occurs opposite side. If you pour warm water, nystagmus occurs towards same side. This is cause. In you and me, this normal pattern is observed. Cause is normal. Cause is normal. If this cause pattern you are not getting, then there is something abnormal inside. Okay, so what is the cold water used here? 30 degrees, warm water 44 degrees Celsius, right? Position will be supine with 30 degree elevated. So cause is seen normally. If cause is not seen, that is abnormal. Petrositis. So the infection spreads from the middle ear towards the inner ear towards the petrous apex. from the middle ear. See, this is from the skull base side, skull side, cranium side we are seeing. So this entire thing is a skull base. Now see from the middle ear towards the ear, towards the petrous apex. So the infection spreads towards the petrous apex here. The infection spreads towards the petrous apex here. Now, near the petrous apex, abducens nerve is running. Now, when this gets infected, diplopia will be there. And you have this trigeminal Meckel's ganglion at the near the petrous apex. Now, this is a sensory ganglion. When this gets infected, pain will be there. And this ganglion is exactly retroorbital, behind the orbit. So deep-seated retroorbital pain, diplopia, and already this is a middle ear disease. So discharge will be there. So discharge, deep-seated retroorbital pain, and diplopia, all these three together are called as Grade-Negos triad, that is seen in petrositis. A patient complaint of ear discharge retroorbital pain is diagnosis. What is that? Petrositis. Now, what is the meningitis? So, apart from all other common meningitis, increased intracranial pressure features, you know, Karnick sign and Brudzinski's neck sign you need to know. On a flexed hip, if you try to extend the knee, it causes pain. If you try to flex the neck, what happens? Knees will automatically flex. Okay, that is Brudzinski's sign. Okay, fine. Now coming to the sigmoid sinus thrombosis, where is the sigmoid sinus running? Behind the mastoid. Now, what happened in the CSOM? First, middle ear affected, then it went behind and it affected the mastoid. Then it came still behind and affected the sigmoid sinus. Then your sigmoid sinus thrombosis occurred. See, from the middle ear into the mastoid, the infection entered, and through the mastoid is draining into the sigmoid sinus through mastoid emissary vein. Okay, now the infection through the mastoid emissary vein spreads into the sigmoid sinus. As soon as the wall of the vein sinus is got infected by this bacteria coming from here, immediately the wall of the vein responds and forms a thrombus to contain the infection. So it forms a thrombus. Now this is sigmoid sinus, and a thrombus is forming inside. That is sigmoid sinus thrombosis. Now where is the erythema forming? Erythema is forming posterior to the, this is mastoid, posterior to the mastoid, thrombus is forming, veins are superficial. So here in this region, the overlying skin is getting reddish erythematous over the posterior mastoid. That you call it as Griesinger sign. And picket fence fever, what happens? So sometimes after a large thrombus forms over a period of time, small pieces of thrombus will dislodge and go into the central circulation. They will go into the central circulation. Whenever this thrombus goes into the circulation, fever will spike. Now that is called as irregular. You never know when a thrombus goes, dislodges. So that called as picket fence fever. Investigation of choice. This is a vascular tumor. So always go for contrast and you will see a delta sign. Wherever that thrombus is present, there the contrast will not fill. Contrast will fill where the blood is present. Where blood is not present, clot is present, thrombus is present, the contrast will not fill in that. Treatment, drug of choice for this infection, central venous sinus thrombosis, is vancomycin. Add with an anticoagulant to dissolve the thrombus. Give for 6 weeks. And if after 6 weeks, repeat this imaging test and see whether delta sign is there or not. And if it is dissolved, the thrombus is not there, go for surgical canal wall down mastoidectomy. If the thrombus is not dissolved, again repeat the same sequence. So this is how the treatment is done. Now coming to the temporal lobe abscess. Now the infection has spreaded, eroded this bone and comes to lie here, extradural abscess. Eroded the dura also here, comes to lie under the dura, subdural abscess. Even gone into the cerebrum, that is cerebral abscess. So which lobe of the brain is present here? Temporal lobe. So most common cerebral lobe getting affected in CSOM is temporal lobe abscess. So whenever the brain is getting affected, CNS symptoms like irritability, confusion, seizures, homonymous hemianopia, photophobia. Apart from the regular constitutional symptoms, specific CNS symptoms arising means you should suspect something intracranial, intracerebral extension. Get a scan done and you will see a space occupying lesion abscess here. Coming to the inner ear. So we are very much delayed. Within half an hour, we have to complete the ear. Now coming to the inner ear. The inner ear, membranous labyrinth is developing from otic sac or otic vesicle, and otic capsule forms the bony labyrinth. So you know that. So the parts of the otic vesicle, okay, whatever the otic sac is present, it divides into two sacs, pars superior and pars inferior. From the pars superior, see, this is your inner ear. This is arranged anterior-inferior to posterior-superior arrangement. Anterior-inferior lying structures are cochlea and saccule. Superior lying structures are utricle and semicircular canals. Okay. Now, from the pars superior, the utricle and semicircular canals, these two structures of superiorly lying two structures will develop from pars superior. Inferiorly lying two structures, cochlea and saccule, will develop from pars inferior. Okay, so that is what you need to remember. Now coming to the anatomy, you have a bony labyrinth outside. Exactly in the same shape inside, you have a membranous labyrinth inside. So if you take the cochlea, you have a bony cochlea outside. Inside that, exactly in the same shape, you have a membranous cochlea inside. So this is the purple one is the bony. The bluish one is the membranous labyrinth. A tube inside a tube, the same coiling will be there. 2.5 to 2.75 turns will be there. And once it comes to the bony vestibule where oval window and round window, bony vestibule, this is your bony vestibule where oval window and round window are there. In this bony vestibule inside, saccule and utricle, two sacs. The inside membranous cochlea is opening into saccule. This is connected to utricle. To this utricle, membranous semicircular ducts are connected. So this is your vestibule, bony, outside and inside, membranous saccule connected to the cochlea, membranous utricle connected to semicircular canals is present, and the utricle is connected to semicircular canals. You know, the vestibule is connected to semicircular canals, bony canals, membranous canals. Now, from the utricle and saccule, endolymphatic duct forms. At the periphery, it dilates to form a sac called as endolymphatic sac. Inside the membranous cochlea, stria vascularis is present. It produces endolymph, and endolymph circulates everywhere in the membranous labyrinth, and through the endolymphatic sac, it gets excreted outward. Amount of endolymph formed here in the stria vascularis is equal to the amount of endolymph excreted outside through the endolymphatic sac. This will be equal always. Production is equal to excretion. So amount of endolymph inside will always remain constant throughout your lifetime. Okay. So that homeostasis is maintained everywhere. So endolymph is rich in potassium, perilymph is rich in sodium. Remember that. Now coming to the anatomy, if you take the cross section of the cochlea, it is divided into three chambers. Scala media, the membranous cochlea is forming the scala media, separated from scala vestibuli by rhinous membrane, separated from scala tympanic by basilar membrane. On the basilar membrane, your organ of Corti is lying. Now, one more thing you already know, the basal coil of the cochlea is concerned with hearing high frequencies, and the apical coil of the cochlea is concerned with hearing low frequencies. Human cochlea has the range of hearing from 20 Hertz to 20,000 Hertz. So 20, 100, 500, 1000, 2000, 4000, 8000, 10,000, 20,000. So that's how all the frequencies will be heard in this cochlea like that. Just take a piano and coil it like a cochlea. That is your cochlea. Okay. Now coming to the this organ of Corti, you have got outer hair cells and inner hair cells. Outer hair cells are arranged in 3 to 4 rows. Inner hair cells are arranged in single row. Okay. Coming to otoacoustic emissions produced by outer hair cells, first screening test for hearing in newborns. So the screening protocol is immediately at birth, you will do otoacoustic emissions, and if it is passed, then the child is fine. If it is refer, then repeat at 3 months. If it is present, then the child is fine. If it is still absent, then confirmatory BERA at 6 months of age you need to do. So this is the hearing screening protocol in newborns. Hearing screening protocol in newborns. At birth, OAE. If failed, repeat at 3 months. If still failed, confirmatory BERA at 6 months. So this is the standard protocol you need to follow. In the case of ototoxicity induced by diuretics, which specific structure within the cochlea is most susceptible to damage? Remember, most of the times, outer hair cells are worse affected compared to inner hair cells. Or how to remember? These are outside, so easily affected. Inner or inside, so safely located. Okay. सब्जेक्टिव ऑब्जेक्टिव मैंने बोल दिया ऑलरेडी, आपने क्लास नहीं सुना रहा. For newborn hearing screening purpose, which test is most commonly used? So first test used is otoacoustic emissions. Okay. You ask your colleagues, they will tell you. I told that. Okay. Coming to ototoxicity. Remember, subjective, objective. If you are doing pure tone audiometry, what you will do? You will give sounds to the patient and patient has to tell you whether he is hearing or not. So that is subjective. You do impedance audiometry means you put a machine will tell you what kind of impedance is there. That is objective. Here, patient has nothing to tell. Otoacoustic emissions, you put the probe inside. Okay, that will tell you whether otoacoustic emissions are there or not. Machine itself will check. Beta, you connect the electrodes, give a sound. On the screen, you get a graph. So the machine itself is telling you, no need for the patient to tell anything. That is objective. So in children, in infants, newborns, can you do any subjective test? Is it possible that an infant can tell you that he is hearing or he is not hearing? That is not possible. So in infant, whatever test you are doing, it should be objective only. You cannot do a subjective in an infant. So screening protocol, newborn hearing screening protocol, otoacoustic emissions, where are we are doing means both should be objective only, cannot be subjective. Now coming to the, what happened? Okay, sorry, diuretics will be damaging the stria vascularis. Sorry, we'll come to that. Diuretics, outer hair cells are damaged by, yeah, I'm sorry. Stria vascularis is damaged by diuretics and antimalarials. So normally, in case, नॉर्मली ओटोटॉक्सिसिटी में जो ज्यादा सबसे कॉमन स्ट्रक्चर डैमेज होता है कि आउटर फॉर एग्जांपल पेशेंट इज वर्किंग इन ए फैक्ट्री so which part of the cochlea is most sensitive to loud sound induced damage means outer hair cells. Okay. Outer hair cells are damaged by what? Your neoplastic drugs and your very widely used aminoglycosides. Okay. So coming to ototoxicity, cochleotoxic, stria vascularis damaging diuretics and diuretics and antimalarials, outer hair cells damaging are aminoglycosides and neoplastic drugs. Coming to vestibulotoxic, GST is the mnemonic, gentamicin, streptomycin, tobramycin. Okay, GST is the mnemonic for vestibulotoxic. The usage of these drugs will cause more giddiness than hearing loss. So they are vestibulotoxic. Now coming to the sense organs in this inner ear. So coming to the vestibule, saccule, utricle are present. In the saccule and utricle, you have the structure called as macula. These are the sensory structures. And if you enlarge the macula, it will be looking like this. So this macula has got various hair cells, stereocilia, and otoconia, calcium carbonate crystals are present here. During sudden idiopathic or trauma, the stones will get dislodged and go into the semicircular canal. They will disturb the crista cupula there and cause giddiness. That is BPPV. These otoconia are responsible for BPPV. Okay. And now coming to the macula and utricle, they are horizontally arranged. So if you see the macula and utricle, they are horizontally arranged. Now, as these are horizontally arranged in the macula, in the utricle, the macula are arranged horizontally. Now, this is responsible for detecting horizontal linear accelerations. I am moving in a vehicle forward, I am moving in a vehicle backward. These movements are detected by macula in the utricle. And in the saccule, the macula are arranged vertically. I am going up in a lift, I am going down in a lift. Vertical linear movements are detected by saccule, macula in the saccule. And now coming to the semicircular canals. So in the semicircular canals, three semicircular canals, you can see the three cupula crista complexes. The crista is the main sensory structure. Cupula is a jelly-like matrix present over the crista. Now, this is cupula, hair cells, crista. Now see, whenever you are moving linearly, what happens to the macula? See the macula, what happens to the macula? It also bends in the same way. That's how it will detect. The hair cells will bend. So that's how it will detect the linear accelerations. And now coming to the angular acceleration. When I am moving angularly like this, okay, I'm rotating my head. Angular movements are there. Now at that point, okay, this cupula will get stimulated. Semicircular canals will get stimulated and the cupula will get deflected accordingly. So that will stimulate the hair cells and the impulse reaches the brain. So that's how the movement is detected here in angular. So semicircular canals will detect, cupula crista will detect angular accelerations, macula will detect horizontal linear and vertical linear accelerations, macula will detect. Okay. Now coming to this function of utricle and saccule, linear accelerations. High frequency sounds are heard at basal coil of the cochlea. Low frequency sounds are heard at apical coil of the cochlea. Angular acceleration is detected by crista, semicircular canals. Hope you understood, right? Now, nerve supply of the inner ear. See, this is the same embryology slide I have kept here. Now, pars superior is supplied by superior vestibular, pars inferior is supplied by inferior vestibular. Very simple. Now, there is an exception. The posterior semicircular canal, if you see the posterior semicircular canal, the crista cupula here is lying very near to the saccule. Now, this is an exception. This is supplied by a branch from inferior vestibular nerve to the saccule, one branch goes, and to the posterior semicircular canal, another branch comes. So, this is an exception. Whereas lateral canal, superior canal, utricle, they are supplied by superior. You know the cochlea, it has got its function entirely different. So cochlea has got its own cochlear now. Okay. Now coming to the internal auditory canal. So what is this internal auditory canal? Now all the nerves from the inner ear, the nerves are going inside. No, which nerves? From the cochlea, cochlear nerve, from the saccule and posterior canal, inferior vestibular nerve, from the superior canal, lateral canal and utricle, superior nerve. Now, superior vestibular nerve, inferior vestibular nerve, cochlear nerve, all these three nerves from here have to go inside. They are entering into a bony canal. Same in the plane of external auditory canal, internal auditory canal will be present. So, from the cochlea, which is located anterior-inferiorly, the nerve will go into the anterior-inferior quadrant. Okay, the nerve will go into the anterior-inferior quadrant. Now you go to the posterior. In the posterior, you have superior vestibular nerve, inferior vestibular nerve. Now postero-superior quadrant is occupied by superior vestibular nerve. Postero-inferior quadrant is occupied by inferior vestibular nerve. So all these three quadrants are occupied. The leftover anterosuperior quadrant is occupied by facial nerve. The facial nerve is coming from inside and running and entering the middle ear and going medial wall, posterior wall, exiting here, giving chorda tympanic, coming to the parotid and coming as a 5 terminal branches. Isn't it? Understood? So this facial is running in the anterosuperior quadrant here. The vertical partition is Bill's bar, horizontal partition is falciform crest. Hope you understood this, no? Hope you understood this. Cochlea, no? Saccule, no? Utricle, no? Okay, right. From the anterior-inferior area to the anterior-inferior quadrant, isn't it? From the postero-superior area to the postero-superior quadrant, isn't it? From the postero-inferior area to the postero-inferior quadrant, isn't it? These three inside, these two will join common vestibular and cochlear will join to form the vestibulocochlear that will be coming from outside. Now, where is this facial running? Facial is running, okay, running through the anterior superior quadrant here into the middle ear, running like this, and it is entering into the middle ear. Okay, it is coming and entering into the middle ear, medial wall, posterior wall, coming to the mastoid tip and turning to a parotid, and in the parotid giving 5 terminal branches. ऑलरेडी स्लो जा रहा है ना डॉक्टर साहब. ओके, आज भी हम बहुत टाइम ले रहे हैं. नेक्स्ट क्लास की विच फैकल्टीज विच सब्जेक्ट इज देयर नेक्स्ट आफ्टर मी? माइक्रो. एट व्हाट टाइम? व्हाट्स द टाइम गिवन फॉर माइक्रो? क्या टाइम दिया था माइक्रो को? 3 o'clock. Oh, okay. Now coming to the auditory pathway. Now you have crossed the internal auditory canal. Now where is this auditory nerve going? Ultimately कहाँ जाना है? Cochlear nucleus, olivary complex superior, lateral lemniscus, okay, inferior colliculus, medial geniculate body, auditory cortex. Eighth nerve, cochlear nucleus, olivary complex superior, lateral lemniscus, inferior colliculus, medial geniculate body, auditory complex. What is the mnemonic? Ecolema. Understood? Okay. So your cochlear nerve through the internal auditory canal, first reaching the cochlear nucleus. So along the various nuclei, it is ultimately ending in the auditory cortex. Okay, and area number 41. So that is auditory pathway. What is Bera? You are checking. What you are checking for here? See, if you take your ear, how to know whether entire ear is working normal or not? Okay, how to know whether entire ear is working normal or not? If you put an otoscope, you will see this part, and you can tell whether this area is normal or not. Am I right? So an otoscopy will tell you whether this is normal or not. If you do an impedance audiometry, you will come to know middle ear. A type normal, AS means otosclerosis, AD means oscular discontinuity, B type means fluid or CSOM, C type means retracted negative middle ear pressure. If you do an otoacoustic emissions, so whether outer hair cells are functioning or not, you can come to know whether cochlea is functioning normal or not. And if you do a Bera, now you can tell me, so what is the Bera checking here? Whether this nerve is functioning normal or not, Bera will be telling you this. Understood? So this is how you have to do all these tests. And if all these are normal, everything is normal. The patient is hearing normally. Okay, so Bera is an objective test. You put two electrodes here and give a sound stimulus. Now the sound will go inside through which nerve? Cochlear nerve. When the sound is going through the ecolema, at every structure, each wave peak will occur. So at proximal part of eighth nerve, distal part of eighth nerve, cochlear nucleus, olivary complex superior, lateral lemniscus, inferior colliculus, medial gen. So at every area, you will get a peak. If you see finally, wave 5 will be more prominently coming. Wave 5 is most prominent, and this is related to lateral lemniscus, isn't it? Now, so you have to remember this mnemonic E coli. Okay, 1, 2, 3, 4, 5, 6 waves. Okay, all waves. Wave 1, wave 2, wave 3, wave 4, wave 5, wave 6. All these are corresponding to their structures. Now, time taken for that wave to travel from wave 1 to wave 2, I mean place 1 to place 2, is 1 millisecond. 1 millisecond, 1 millisecond, 1 millisecond, 1 millisecond. If the time is being taken more here, means there is a problem here in between. So there is a problem here in between. Understood? So wave 1, wave 2. So if the time is taken more for the wave, the current impulse, nerve impulse to travel from here to here, means there is some block here, some problem here. So with the help of Bera waves, I will come to know in which area the problem is there. Okay. Depending on the latencies obtained, I can see which structure is damaged inside. Which of the following is true about Bera? Bera can be used for screening of hearing loss. Obviously, I told you in the screening protocol, first you do otocompensation. If they are failed, then Bera is the confirmatory test. Okay, it is an invasive. No, you are not invading any space. Just putting electrodes and giving a sound clip. It can be used for assessing SNHL. See, it can tell you whether hearing loss is there or not. See, whenever I am giving a sound from here, it is traveling through all these structures to here. So that means, for example, if there is any problem here, now when I give the sound from here, due to the problem here, the sound has gone here and it didn't reach here. Now I will get abnormal Bera. Now the Bera, see if Bera is abnormal, I can't conformably tell that the problem is in the neural part only, SNHL only, isn't it? So Bera cannot tell you whether it is conductive loss or SNHL loss. Bera can tell you whether hearing loss is there or not. It is an objective investigation. That's why you are able to do in an infant. Okay. Meanies disease, it is an increased endolymph will be there. So due to that, so increased reproduction or decreased excretion or both will be there. So hair cells are affected, that cause SNHL, and macula and crista are affected. So that causes giddiness, vertigo, roaring tinnitus, oral fullness. Otoscopy will be normal because it is problem is here. Otoscopy will be normal. Tuning fork test, patient is complaining of hearing loss. So tuning fork test will tell you SNHL pattern, and on pure tone audiogram, you will get an ascending audiogram. Lower frequencies are worst affected. The moment you are getting a ascending audiogram, you suspect Meniere's and you send the patient for investigation of choice, electrocochleography. SP by AP should be more than 30%. The treatment is more fluid is coming here. Okay, so you have to decrease the fluid, diuretics. Giddiness is the main problem, and vestibular sedatives can be given. And if the patient is not getting improved, you have to go for endolymphatic sac decompression. Only this endolymphatic sac is decompressed, so extra pressure fluid is drained outside. So pressure inside becomes normalized, so symptoms will reduce. If even this is also not useful, then definitive treatment is by labyrinthectomy. Donaldson's line helps in identifying endolymphatic sac during ELS decompression surgery. So in definitive treatment means labyrinthectomy means you are completely destroying the labyrinth. So when you are completely destroying the labyrinth, not only the giddiness is going, patient is also losing his hearing. So to get relief from vertigo, patient has to lose hearing also. A 35-year-old male presented to clinic with complaints of vertigo, ear pressure, fullness, decreased hearing, roaring tinnitus. So the treatment is the disease is Meniere's disease. A 50-year-old male, vertigo, tinnitus, fluctuating hearing loss. See the ascending audiogram, that is Meniere's disease. Acoustic neuroma, another names vestibular schwannoma, neuruloma, 8 tumor. Most common CP angle tumor. Most common site of origin is inferior vestibular nerve, and most of these patients will present with unilateral SNHL with tinnitus. Meniere's disease patients will present with giddiness, severe giddiness, and these patients will present with hearing problem with the tinnitus inside. Okay, so otoscopy will be normal because the tumor is here. Otoscopy will be normal, and so patient is complaining of SNHL. Do tuning fork, it will give you SNHL, and get a pure tone audiometry. Middle frequencies will be affected more, not lower frequencies, not higher frequencies. When middle frequencies are affected more, you get the curve as trough shaped or banana shaped or cookie bite shaped. Okay, and the moment you are getting a cookie bite shaped, suspect acoustic neuroma, and say investigation of choice will be gadolinium in MRI, where ice cream cone appearance is seen. And treatment is surgical excision because the tumor, so you surgically excise it, or if the patient is not willing or not fit, go for radiotherapy. These are radiosensitive. According to the nerve getting compressed, if the fifth nerve gets compressed first, that will cause corneal sensation decreased. And if the seventh nerve gets compressed in the middle pole, now what happens? Hitzel-Bergersen, hypoesthesia of the posterior meatal wall. And if the ninth and 10th cranial nerves gets compressed, so dysphagia and hoarseness may arise. Okay, and once you excise the tumor, send it for histopathology, you will see Antony A, cell-rich Antony A, cell-poor Antony B, and within the Antony A, sometimes cell-poor areas, Verroque bodies can be seen in the Antony A pattern. Now coming to the cochlear versus retrocochlear, here you have to remove recruitment is a feature of cochlear, CC score is high in cochlear. Stapedial reflex, because stapedial reflex, one of the pathways eighth nerve is affected, so stapedial reflex will be absent. Bera, I already told you, in Bera you are checking this nerve, so this nerve neuroma is there, so Bera will be abnormal. Nerve is getting decayed, nerve is getting problem, so tone decay will be high. So only thing you need to remember is recruitment and the CC score, are these two are related to cochlear. That's why I have given them in a different color for your better identification. And speech audiometry or speech discrimination score is very poor. See, or retrocochlear nerve lesion, when the lesion is on the nerve, the patient will tell you that I am hearing the sound, but I am unable to understand what it is. That is the problem given by this nerve lesions. Okay, remember that. Now BPPV, it is paroxysmal, means short episodes, few seconds. Positional means it occurs on positional change only. So most common cause of peripheral vertigo. If you are unable to diagnose a patient, treat it as BPPV. So causes of BPPV is mostly idiopathic, trauma, presentation. So, few seconds vertigo, position change. So what is the problem here? The otoconia which are present in the utricle go into the canal and disturb. Most commonly they enter into posterior canal. And the diagnosis is by Dix-Hallpike and the treatment is by Eplis. 45 degrees, now 30 degrees. So what happens during this maneuver? The stone which has entered inside the canal is going back into its parent place. Okay, utricle. Okay. Okay, now 90 degrees. Okay, Now still it is going. And another 90 degrees. See this, another 90 degrees. So 45, 30, 90, 90 is the sequence of positions you do in Epley's manual. Okay. So what do you mean by intractable BPPV? Intractable means even after doing repeated Epley's also, no improvement in the patient condition. You call it as intractable. Now for that, you cut the nerve that is supplying the posterior canal. So the branch of inferior vestibular nerve that is separately supplying the posterior canal is called as singular nerve. Cutting that nerve is called as singular neurectomy. Which of the following is responsible for balance and equilibrium? Ideally, both should be the answer. If you have to choose the best, go for better, go for this. And congenital hearing disorders, this is purely theoretical. Skip is dysplasia. I have given the color coding, go through that. Okay, so cochlear and saccule dysplasia, Alexander's means here the basal coil is affected, and Wing-Siebenmann's dysplasia, entire membranous labyrinth is affected. And coming to the Mitchell's aplasia, easy to remember, aplasia means everything completely gone. So complete cochlea is gone, not developed. Mondin is only 1.5 tons of cochlea affected. So only basal coil is present, whereas apical 1.5 tons is lost. And other Torches infections can cause congenital hearing disorders. And coming to the Bell's palsy element type idiopathic, so all these features, loss of wrinkles, okay, unable to close the Bell's phenomena, epiphora, absence of nasolabial fold, and drooping of the angle of mouth. So all these things you can see. Corticosteroids are the drug of choice, and if started early, the prognosis will be better. So a patient is presenting with Bell's palsy means same side upper and lower part will be affected. And coming to the temporal bone fractures, both longitudinal and transverse fractures will be there. In longitudinal, mostly middle ear will be affected. In transverse fractures, inner ear will be affected. So conductive hearing loss occurs here. Sensory neural hearing loss occurs here. Okay. Hemotympanum occurs here. Giddiness will be seen here. Tinnitus will be seen here. Facial palsy will be seen here. Now coming to the syndromic hearing loss, in Waardenburg, you will see apart from SNHL, you will see P-baldism. In Usher syndrome, apart from SNHL, you will see retinitis pigmentosa. In Pendant syndrome, apart from SNHL, you will see goiter. All these syndromes are associated with hearing loss. So this is called a syndromic hearing loss, where apart from SNHL, you will see other features as well. Now coming to the hearing aids, you know the basic parts are microphone, amplifier, and speaker. Okay, so there are, what are the various types of so I'm not going into the details of the hearing aids. You know that, not much important, not at this time. So behind the ear type, RAC type are best choice, you know. Okay, and in the canal, okay, and completely in the canal. So you know that in the canal means here, in the canal, I am putting the hearing aid here, right? Completely in the canal means I'm putting the hearing aid here. Okay, cosmetically, this is much better, but acoustically, this is much better. You know that I'm not going into much details. What is this bone anchored hearing aid? See, all these hearing aids where you are putting, you are utilizing the air conduction route. If this air conduction route is not available for utilization, so where congenital EAC atresia. So EAC didn't form at all. CSOM, repeated ear discharge episodes are there. Or canal wall down mastoid, huge cavity is there. So in that cases, I cannot utilize this air conduction route. In that cases, I will utilize the bone conduction route. So I will fit a hearing aid directly to the bone here. I will utilize the bone conduction route. So अगर आगे से नहीं होगा, so पीछे से डालना पड़ेगा, that is hearing aid fit करना पड़ेगा. So you utilize the bone conduction route if air conduction route is not available. That is called as bone anchored hearing aid. Okay, it is anchored, the hearing aid is anchored to the bone anchored hearing aid. Okay. Now coming to the cochlear implant. So what are the parts of a cochlear implant? It has got external and internal. Now once you see the external, so this is actually the microphone will be there, battery will be there inside, digital processor, speech processor will be there here. Okay. Now this is connected to a external transmitter. This microphone receives the sound is processed and sent to the external transmitter. Now this is your external transmitter outside. Inside you will already implant this inner receiver stimulator. So a same type of coil inside will be there exactly opposite to that. That is internal receiver stimulator. Now this receives the sound from here and through the cochlear electrode, Through the facial recess, round window, scala tympani, the cochlea is inserted, the implant is inserted, electrode is inserted. So the electrical impulses are sent through this electrical electrode into the cochlea like this. And one more electrode, grounding reference earthing electrode will be there. So this is buried into the temporalis muscle. So these are the parts of the cochlear implant. The criteria is, see, from here the sound is taken and sent into the cochlea. From here onwards, the sound should be carried inside by the auditory nerve. So auditory nerve should be functioning. So you should confirm that auditory nerve is functioning before going for cochlear implantation. And severe SNHL, for mild and moderate, if you put a hearing aid, the mild and moderate hearing loss can be overcome. But for severe SNHL, your conventional hearing aids will not give that much amplification. So in that cases, you need go for this one, cochlear implant. Even any case of SNHL, first you will give hearing aid trial for 6 months. For 6 months, you give hearing aid trial, and if after 6 months also the child is not improving, failed hearing aid trial, then only you go for cochlear implant. So cochlear implant is a final resort. And see for the if you insert a cochlear implant, the cochlear nerve has to be functional. If this cochlear nerve, this auditory nerve is also not functioning, like auditory neuropathy or bilateral schwannoma, so what happened? You will place an implant directly bypassing this area. Directly you will place the implant electrode on the brainstem. That is brainstem implant, auditory brainstem implant. Okay, so lateral is of fourth ventricle, you will place it. Now coming to the vestibulo-ocular reflex. So the vestibule is connected to the extraocular muscles. Now I will tell you, whenever I am seeing towards right side, my right vestibule will get stimulated, left vestibule will get inhibited. Now, when the right vestibule stimulates, this side lateral rectus, this side medial rectus will get activated. So my eyes will also turn towards this side. Now, when left side stimulates, when I'm turning my head towards left side, left vestibule stimulates, right vestibule inhibits. When left vestibule stimulates, left side lateral rectus, right side medial rectus, this will stimulate and my eyes will move towards this side. So that is how vestibular ocular reflex is connected. Now, if one side, for left side, the labyrinth is not functioning. Now, when I move my head towards left side, normally what should happen? Left side should excite, but that is not happening. Left side is not exciting. Now, if left vestibule excites, my eyes will move towards left, but my eyes are lagging towards right side now because this is not getting excited. Left hypoactive, no? Understood? Now, when I move my head towards right side vestibule is normal, right side vestibule is exciting, my eyes will normally move towards right side. So when left hypoactive labyrinth is there, on left head rotation, right saccade, on right head rotation, normal. You understood this? A young lady presented to ENT OPD with history of sudden onset hearing loss, tinnitus and dizziness following an episode of acute otitis media 2 weeks. So 2 weeks back, middle ear infection was there. Now she started having sudden hearing loss, tinnitus, dizziness means inner ear. That middle ear infection now spread to inner ear. Now, Rini was positive. So, Rini positive means it should have been SNHL. Now, she refused the treatment then. Now, currently came with even worsened. That SNHL which was present earlier now converted to severe SNHL. So, in severe SNHL, you will get false negative. That is what the question. Battle sign means mastoid ecchymosis. Okay. Now, investigation of choice for ear bleed due to fall. So, ear, CT temporal bone. Now, coming to the nose. So, parts of external nose. What are the parts of external nose? Upper 1/3 is formed by nasal bones. Lower 2/3 are formed by cartilages. Upper lateral, lower lateral. And coming to rhinophyma, potato tumor, also called as hypertrophy of the sebaceous glands at the tip of the nose. Surgical excision can be done. And the vestibule, the anterior hairline portion is called as vestibule. And here, the same thing. Again, the pilosebaceous units are present. If they are infected, so if you are doing like this constantly, if they are infected, that will cause furunculosis. If entire skin of the vestibule gets involved, you call it as vestibulitis. Treatment is again same, antibiotic, same like this. And now coming to the lateral nasal wall, you have 3 turbinates and 3 meatai, one by one. You know that. So if you take a turbinate structure actually, so it has a piece of bone. It has any turbinate if you take, inside bone will be there. On that bone, vascular sinusoids will be present. Over that, mucosal covering will be there. So inferior turbinate is a separate piece of bone. This is normal inferior turbinate. This is the septum. Normal airway space should be present in between. But during episodes of nasal inflammatory conditions, the turbinate gets enlarged. Whenever there is inflammation, blood supply increases. When the blood supply increases, what is the turbinate made up of? Vascular sinusoids. So the vascular sinusoids will increase in size. When they increase in size, the turbinate size increases. Understood? So this causes nose block. And coming to the inferior meatus, into the inferior meatus, the nasolacrimal duct will open. What is this lacrimal apparatus? From the lacrimal gland, the tear secretions will be coming onto your conjunctiva, and at the medial canthus, the upper and lower lacrimal puncta are present. Whenever you are blinking, that will act as a natural pump mechanism and will push the tear secretions into the puncta. From there, they will enter into the canaliculi, lacrimal, superior canaliculus, inferior canaliculus. From there, common canaliculus. From there to the lacrimal sac. From there to the nasolacrimal duct, and then into the inferior meatus. From the inferior meatus into the nasopharynx, esophagus, stomach, and in the stomach acids destroyed. Okay, so this is how your normal lacrimal drainage system works. Now, okay. Now, see, whenever there is a block in the proximal block means near to the first in the starting point of the lacrimal drainage system, lacrimal apparatus. In the starting point of the lacrimal apparatus, proximal block is there in the canaliculi. What happens when I do a Bowman's probe test? It comes to a soft stop because the tumor is soft and my probe when I'm passing here comes to stop softly. So soft stop means proximal block here. And if there is a block distally in the nasolacrimal duct, when I pass the probe, the Bowman's probe will touch the bone here. Okay, so my probe will be going and touching the bone here. So that causes hard stop. I feel something hard inside. So that means this is completely clear. So there is distal obstruction. Okay, so in distal block, Bowman's probe is hard stop. In proximal block, Bowman's probe soft stop. So if you are getting soft stop, proximal block, then external surgery should be done. External, you have to cut and remove the tumor there. If a distal block, hard stop is there, you have to go for endoscopic endonasal dacryocystorhinostomy. In DCR, what you are doing, you are giving, as the block is here, you are bypassing that directly from the lacrimal sac, you are, okay, making a way into the nasal cavity. Dacryocyst rhinostomy, lacrimal sac, nose, common opening, joined to each other. Dacryocysto-rhinostomy. Okay. Now, lacrimal sac is present on medial wall. Lacrimal gland is present on roof. Okay, middle turbinate. You know there are three parts. First part sagittal, second part coronal, third part axial. And coming to the middle meatus. So if you take the superior view of the middle meatus, so this is the first part. When I'm seeing from anterior, so I can put the scope into the nose from anterior only. When I'm seeing from anterior, I can see the anterior part of the middle turbinate. And lateral wall, say, I will be seeing the uncinate process here. And in between the uncinate process and middle turbinate, there is a bulla. And bulla is the largest ethmoid layer cell. Between bulla and uncinate process, there is a gap that is called as hiatus semilunaris. And through the hiatus, if I come inside, I will land in a 3D space that is called as ethmoidal infundibulum, into which your maxillary sinus will be opening. Okay, so these are the structures in the middle meatus. And coming to the most common site of obstruction by a nasal polyp from the maxillary sinus is obviously middle meatus, right? Now coming to concha bullosa, this is pneumatization of the middle turbinate. This is normal middle turbinate, is pneumatization of the middle turbinate. Agar nasal means anterior most ethmoidal layer cell, which impedes the drainage of frontal sinus, causes frontal sinusitis. Pneumatization of the floor of the orbit causes Haller cell formation, lies near to infraorbital nerve. Posterior ethmoid pneumatization extension onto the sphenoid bone. The star shape is sphenoid bone. Above that arrow is shown as onodicel. So the posterior ethmoids will extend posteriorly onto the sphenoid and form an air cell formation that is called as onodicel, which lies near to the optic nerve. Okay. So now coming to the frontal drainage depends on the attachment of the uncinate process. From below, the uncinate is arising commonly from the inferior turbinate only. This is your inferior turbinate. Inferior turbinate. So everywhere the origin of the uncinate process is common. From inferior turbinate. Below attachment of the uncinate process is common. It's the only above attachment that varies everywhere. So if you see the uncinate is attaching above to the lamina papyracea laterally, the frontal sinus is draining medially into the nasal cavity. If the uncinate process is attaching medially to the cribriform plate or the middle turbinate, the frontal is draining medially into the maxillary sinus. Now the attachment of the uncinate decides the drainage pattern of the frontal sinus. Now if the uncinate process is attached to the cribriform plate or it is attached to the middle turbinate, the frontal sinusitis can ultimately lead to maxillary sinusitis also. So that is the significance of uncinate attachment. So uncinate decides the frontal drainage. Okay, frontal drainage depends on the uncinate attachment above, not below. Tip of the uncinate attached superiorly. Recent last year question, 1 year back, same question. Tip of uncinate attached superiorly to. See, superiorly it can attach to middle turbinate, not middle meatus. Meatus means it's an empty space. How can one structure go and attach to empty space? So this is absolute meaningless. Inferior turbinate may there is no attachments to inferior turbinate. Inferior turbinate, tip of uncinate is attached inferiorly, below to the inferior turbinate, isn't it? Okay, ethmoidal bulla, no, for the bulla is ethmoidal air cell, to the bulla this never attaches. Okay. Now coming to the superior turbinate, it's a part of ethmoid bone. You know, inferior turbinate is a separate bone. Middle and superior are parts of ethmoid bone, right? And coming to the endoscopic, at this video you know very well. Now coming to the septal anatomy, perpendicular plate of the ethmoid, vomer are the bones forming the septum posteriorly, and septal cartilage will be anteroinferiorly. This is quadrilateral cartilage. Four sides are there. Quadrilateral cartilage you call it as. And coming to the septal trauma, if the blow is from the front, it causes a Jarzavi fracture. If the blow is from below, Chavalet fracture. If the blow is from the side, C-shaped fracture will occur. Now coming to the closer reduction of nasal bone fracture, see, whenever there is a fractured nasal bone, edema will be there. You need to wait for the edema to reduce for 5 to 7 days. Then only you need to go for closer reduction of the nasal bones. Okay. For bone fracture, you use Walsham forceps. For septal fracture, you use Asch forceps. Now coming to this, so CT shows a displaced nasal fracture. Ideal time is 5 to 7 days following surgery. Okay, following injury. Now coming to the ethmoidal neuralgia, in the area of the middle turbinate, the septum deformed into a spur-like deformity that impinges on the middle turbinate, and the anterior ethmoidal nerve supplying in the anterolateral, this area gets irritated. Pain will be there in the anterior area of the nose. So that is called as Sludder's or ethmoidal neuralgia. You have to remove the spur, that is by septoplasty. Sludder's neuralgia, compression of anterior ethmoidal by septal spur in the region of middle turbinate. Now coming to the Cortis test, whichever side patient is complaining of nose block, pull the cheek away, the airflow improves on that side. That is Cortis test. And septal hematoma, whenever there is a trauma, same like pinna hematoma, septal hematoma, on either side of the septum, the blood gets accumulated between cartilage and its perichondrium. So what happens here? So the presentation will be on either side, you will see red soft fluctuant swellings you will see on either side. And treatment is you have to incise, drain the fluid and pack it up. Incision and drainage followed by packing. Coming to the abscess, if you do not drain the hematoma properly, and so slowly bacteria can set in and can form an abscess. Okay, so bacterial infiltration is there, so pus will form and fever will come apart from pain and nose block. Now treatment is again incision and drainage followed by packing. Septal perforation, again it's a complication. So in SMR surgeries you can notice, not in septoplasty, in SMR done for deviated nasal septum you can have this. Your favorite cocaine abuse as well. Granulomatous, various granulomatous diseases can cause this septal perforations. Remember, in syphilis, bony septal perforations will cause. In remaining all else, you will have cartilaginous perforation. If the hole is small, whistling will be the sound. If the perforation is large, epistaxis and crusting can occur. So treatment is by septal buttons. Small can be converted to large if buttons are not taken up by the this one, and large perforations are there. You need to go for mucosal advancement flap technique. A 6-year-old boy fell from the bed, developed swelling in the nose, difficulty breathing, smooth rounded swellings on either side. Okay, through the nerves, soft and fluctuate swellings. So this is septal hematoma. Incision and drainage you need to do, isn't it? Bony septal perforation, bony syphilis always. Okay, bony syphilis always. Blood supply of septum, anterior ethmoidal, posterior ethmoidal, both are branches of the branch of internal carotid artery. Sphenopalatine artery, greater palatine artery, branches of maxillary, and superior labial branch of facial artery, both are branches of external carotid artery. ICA, ECA, both are branches of CCA. Sphenopalatine is called as artery epistaxis because 70% of the nasal cavity is supplied by the sphenopalatine all along from posterior to anterior. This is supplied. 70% of the nose is supplied by this artery. So if bleed is there from the nose, 70% chances are there that it can be from the sphenopalatine artery. Now coming to the little's area, anterior ethmoidal artery, superior labial official, greater palatin, sphenopalatine. All these four will join in the anterior-inferior part of the septum. So except the posterior ethmoidal, all four other arteries will join to form this Little's area or Kieselbach's plexus. So this is the most common site of epistaxis. Most common cause is nose picking. So which is true with respect to Little's area? Kieselbach's is present in the Little's area, correct? It is situated in the anterior-inferior, most common site of epistaxis. Anastomosis of four major arteries will occur here. What is Woodruff's plexus? This is a venous plexus. I have drawn it in blue color. This is a Kieselbach's is an arterial plexus. I have drawn it in red color. Now, this is the septum. This is the lateral wall. Anterior-inferior part of septum is your arterial Kieselbach's plexus. Posterior-inferior part of lateral wall is your Woodruff's plexus. So mostly this causes posterior epistaxis, mostly seen in uncontrolled hypertension cases. Now coming to the treatment of epistaxis, first Trotter's method, and then if you are able to see the area from where the bleed is coming, cauterize that particular area, and if still not reducing, then go for packing. First put an anterior pack. If still not reducing, then go for posterior packing, and if still not reducing, then go for ligation techniques. Sphenopalatine artery is ligated first. If bleeding still not reduces, go for its parent artery, maxillary. If not reduces, then go for its parent artery, external carotid artery, and if still not reducing, then go for anterior ethmoidal artery. Now coming to atrophic rhinitis, these are the causes, infective Klebsiella, vitamin deficiency, estrogen deficiency, and what happens here? Atrophy of blood vessels. Turbinate are filled with blood sinusoids. So the blood vessels are atrophied, blood sinusoids are gone. So turbinates completely become small in size. So turbinate resorption will occur. Wide, roomy nasal cavities will be there. Atrophy of nerves will be there. Anosmia, because olfactory nerves are lost. Anosmia. Then the airflow, the sensation of airflow is lost. Okay, so nose block. Even though wide roomy nasal cavities are there, patient complains of nose block. And pseudostratified. So when the air is constantly flowing through, okay, the friction of the air causes the epithelium to completely get damaged, and that friction will cause this conversion of the natural nasal epithelial lining to squamous epithelial lining. So when the squamous epithelial lining has done, what is that normal ciliated epithelium? When the cilia are present, the ciliary mechanism is present. It is clearing all the dust particles that you are inhaling in your air. Now that ciliary mechanism is lost. Whatever is coming from outside, it is getting deposited within the nose, forming huge crust. Okay, piles of crust inside. So crusting will be there inside, and so inside this, okay, all the foul material, Klebsiella will cause infection, foul greenish discharge. This will cause a foul smell. So for patient is unable to smell due to anosmia, atrophy of nerves, anosmia, patient is unable to smell her own foul smell. So that is called as merciful anosmia. Now treatment is nasal dosing with all these various solutions present. Surgery is by Young's operation. A patient presents with foul smell from nose and nasal obstruction, greenish crusting you are seeing, that is atrophic rhinitis. Allergic rhinitis means it is IgE mediated type 1 hypersensitivity. Sneezing, watering, itching will be there. Most common, sneezing, watering, itching, sneezing, watering, itching, sneezing, watering, itching. These will be the most common complaints given by the patient. When you put an endoscope inside and see, the mucosa will be very pale in appearance. See the pinkish, it is not at all pinkish, complete whitish, see, and mulberry type cobblestone sometimes you can see. Other features is, so the patient is completely itching, watering is there. So there will be allergic salute will be there. So due to that, transverse nasal creases will form, and not only the nose, allergic, always eye will be itching. So because the conjunctiva is getting exposed to the same allergen, so again itching will be there. Due to that, allergic shiners will form, denim organ lines will form. So these are the things. Now on investigating, serum IgE and eosinophils will be elevated here if it is allergic rhinitis. If it is non-allergic rhinitis, you are seeing these symptoms, but you are getting these normal, then that becomes non-allergic rhinitis. Allergic rhinitis is named as allergic only when IgE eosinophils are elevated. So treatment is, see, whenever the antigen comes and sits on the antibody, the mast cell degranulates and forms all these mediators. Now histamine is one of the mediator causing these symptoms. You give antihistamines, the symptoms will reduce. So you give this alpha adrenergics, phenylephrine, you give corticosteroids, you give mast cell stabilizers. So you give anticholinergics, leukotriene receptor antagonists, and anti-IgE antibody. Okay, omalizumab. All these can be given. Topical steroids, topical steroids, corticosteroid, fluticasone sprays can be given. All these form treatment options for allergic rhinitis. Okay, best treatment is always avoidance of allergen. Any treatment you give is temporary only. Permanent solution is by avoidance of allergen only. So remember important things: sneezing, itching, watering. Okay. Elevated IgE, elevated eosinophils. Best treatment is avoidance of allergen. If among the medicines you have to select one, select the topical one. These all are systemic tablets. This is topical fluticasone, topical nasal spray. So that is the best among the medications. Vasomotor rhinitis, same, but see, this IgE and eosinophils are normal. This is called as non-allergic rhinitis. The reason is autonomic imbalance, parasympathetic overactivity, glandular secretions more, that secretions will be more. Okay, so treatment is VDN neurectomy is done in vasomotor rhinitis. Coming to rhinoscleroma, so there are three stages. Atrophic stage is similar to that of atrophic rhinitis. All crusting will be there inside. Second stage is granulomatous. Rubbery nodules will form first. Okay, rubbery nodules will form first. You call it as woody or hebranose. These rubbery nodules fibrose and gets hardened, toughened. Now nodules harden. That is called as tapir nose or stenosed nose. Due to the formation of these nodules, the nasal cavity is stenosed completely, blocked completely. Treatment is antibiotics like streptomycin, tetracycline, rifampicin, and for these nodules you have to surgically excise, send for HPE, and you will see these mucoid cells and Russell bodies. Now coming to rhinosporidiosis, it is a protozoan. So where cattle are also taking bath in the same pond, if this person is also taking bath, it can come. Coastal areas it is seen most commonly. Strawberry-like mass protruding from the nose with epistaxis is the presentation. You have to surgically excise that and give dapsone. HP will show you multiple sporangia containing endospores inside. Now coming to the inverted papilloma, HPV is the cause of papilloma, human papilloma virus. Inverted. Why inverted? The growth is inverted. Old cells are pushed outward. New cells are formed into the stroma. So ultimately, new cells will be at the center. Old cells will be at the periphery. If a tumor normally grows, old cell should be at the center, new cell should come out. Okay, this is normal pattern. If the growth is inverted, the older cells are pushed outward, newer cells are grown at the base. So that's why the growth is inverted, caused by HPV, human papilloma virus. This is inverted papilloma. Elderly males, it is most commonly seen. Most common site is middle meatus, mostly unilateral, benign and locally invasive. It may grow into the local structure, orbits. So that causes proptosis if it goes into the orbit, and treatment is medial maxillectomy. Completely remove the origin site also to avoid the recurrence. A patient presents with complaints of unilateral nasal obstruction and bleeding, diagnosis of inverted papilloma is made. True statement is benign and locally invasive. A patient presents with chronic sinusitis, nasal crusting, saddle nose deformity. Now come to allergic rhinitis. In allergic rhinitis, sneezing, watering, itching will be there. Okay, this is rhinitis. Sinusitis are not involved. Okay, nasal crusting is there. In rhinitis, overflow, discharge will be there, no crusting. And in allergic rhinitis, this saddle nose deformity is not seen, isn't it? Nasal polyposis. Remember, polyp is a small grayish mass that is forming from the sinuses. So that is just a nasal polyp will cause nose block, and it is due to chronic sinusitis. Okay, there is no crusting or anything here. Rhinoscleroma. In the first stage, similar to atrophic rhinitis, you can see this, but there is no saddle nose deformity. Extra growth will occur, but the septum is stable. In granulomatous diseases, there is septal destruction causing saddle nose deformity. So, whichever option says granulomatous diseases, you can choose that. Okay. Coming to the maxillary sinus, the cavity is also called as antrum of Highmore. This is most commonly infected because the drainage has to go against to the gravity. Okay, and the floor of the sinus, you can see it's below the level of the floor of the nasal cavity. So it acts as a sump collecting all the discharges and accumulated discharge for longer duration, infection, and so the maxillary sinusitis. Okay, so this is the first sinus that develops. And coming to the ethmoid, it is like a bunch of grapes, honeycomb like appearance will be there. Anterior and posteriorly it is separated by ground lamella, second part of the middle terminate. Anterior ethmoids are small in size, more in number. Posterior ethmoids are less in number, large in size. Anterior ethmoids drain into middle meatus. Posterior ethmoids drain into superior meatus. Frontal sinus is common for some, okay, unique masses. Osteoma, pyocele, mucocele, all these are seen in frontal sinus. right? Mucosal is a slowly expansion lesion occurs due to trauma. So due to that slow expansion of the tumor, the orbit changes its axis. So if a proptosis occurs, it occurs in a non-axially, not in the exact orbit. Okay, it changes its axis. So non-axial proptosis will occur if the eyeball bulges out. Now, drainage of sphenoid is the least common sinus, and this drains into sphenoethmoidal recess. Now, anterior ethmoidal sinus drains into middle meatus, you know that, right? Sinusitis syndromes. See, cartilaginous and Young's sinusitis and bronchiectasis are common in both. In cartilaginous, situs inversus. See the dextrocardia that is there in cartilaginous. In Young syndrome, it is Young. Infertility due to agiospermia will be there. Now, coming to fungal sinusitis, most common is Aspergillus fumigatus. The various forms of fungal sinusitis are mycetoma, fungal ball in the maxillary sinus. Within the maxillary sinus, a fungal ball will be sitting inside. A greenish colored mass will be sitting inside the maxillary sinus. This is localized, non-invasive. Okay. Allergic fungal. You've gone to Young surgery. That is, Young surgery is for atrophic rhinitis. Coming to allergic fungal. See, the moment you see allergy, allergy is always related to ethmoid. Allergy is always related to ethmoid. Infective is also always related to maxillary. Remember this blind funda. Okay. So ethmoid sinus is most common, right? And then invasive fungal sinusitis. So aspergillosis is most common, not mucormycosis. Mucormycosis, in fact, least common when it comes to invasive fungal sinusitis also. Charcot Leiden crystals, eosinophilic mucin. These are seen in allergic fungal rhinosinusitis. So investigation of choice will be CTPNS always. For nose condition, CTPNS is the investigation of choice. Double density, see hyper whitish hyperdensities you can see within the hypodense mass, double density sign. Mucormycosis, also called as black fungus, seen in immunocompromised, pain in nose phase, angioinvasion. It invades the blood vessels, damages the blood vessels, so no blood supply, so necrosis of the tissue will occur. So that's why it is dangerous. So it keeps on invading, just like your Pseudomonas, even more dangerous than your Pseudomonas. Black eschars in the nasal cavity you will see. So they can spread to palate, they can spread to orbit, they can spread to cranium. And so on MRI, you can see due to the necrosis, no blood supply. So turbinate becomes black turbinate sign you can see. So investigation of choice is contrast MRI. So whenever you are suspecting, you are seeing a black eschar, patient comes with pain in face, pain in nose. On examination, you are seeing blackish eschar. Take that, send it for biopsy, and immediately you start amphotericin B. Also send the patient for CTPNS or MRI. Why MRI? Because to see the extension, how far it has extended. Why amphotericin B? It's the most potent antifungal against mucormycosis. Okay. Which of the following is most commonly seen in the maxillary sinus? Aspergillosis is the most common sign, isn't it? Elderly diabetic treated with steroids and remdesivir now presented with black, foul-smelling discharge, blackish, necrotic mass, eroding septum, hard palate, again, mucormycosis. Diabetic patient presented with facial pain, black eschar, diagnosed mucormycosis. So steps of this, you need to go through the lab 2 again. Okay, you need to go through the lab 2, or if you want, first comers, if you want. See, whenever I'm doing first I will remove the uncinectomy. Then the maxillary ostium is exposed. I will widen the maxillary ostium, that is called as middle meatal anthrostomy. Then I will do the bullectomy. I will remove the bulla. Then I will remove all the other anterior ethmoidal air cells. I will pierce the ground lamella. Then I will remove all the other posterior ethmoidal air cell. Uncinectomy, middle meatal anthrostomy, bullectomy, anterior ethmoidectomy, piercing ground lamella, posterior ethmoidectomy. Uncinectomy, middle meatal anthrostomy, bullectomy, anterior ethmoidectomy, piercing the ground lamella, posterior ethmoidectomy. Now I am left with sphenoid. I will do a sphenoidotomy. Opening of the sphenoid, I'll widen it, and I'll do a frontotomy. Opening of the frontal sinus, I'll widen it. Okay, so these are the steps of FES. Hopefully you understood that. Uncinectomy, middle meatal anthrostomy, bullectomy, anterior ethmoidectomy, piercing ground lamella, posterior ethmoidectomy, sphenoid, frontotomy. Okay. Now coming to the polyposis. Maxillary, I told you, infective. Ethmoid, I told you, allergic. So when allergy is causing means allergy will be equal to, see if dust is causing allergy, it will be equal to both sides. So this allergic will be bilateral. Ethmoids will be bilateral. Infective can be to any one side. So antrochoinal can be unilateral. Okay. So this is unilateral. This is bilateral. Trilobed. Antro, this is forming in the antrum and coming towards the choanus. Antro, one in the antrum, one in the anterochoana, another one in the posterior choana. Trilobed structure. Antrochoanal. Antrochoanal. Okay, this is bunch of grapes like appearance. So this is of less recurrence. Allergy. So allergy you can't treat permanently. So recurrence will be more. Both of them, surgical excision is the treatment of choice. Now coming to Waters view, it is for maxillary sinus. Rhesus view for ethmoid. Caldwell's view for frontal. Submento vertical. Sphenoid. For sphenoid also you will do peer review. This is nothing but Waters view with open mouth. So these are all the views you use for sinuses. Towns view is done for skull fractures. Okay, and Sculler's view is done for mastoid. Okay, so the image shows what is this? This is Towns view, right? This is Waters view. See, the X-ray plate is placed anteriorly. Here, the X-ray plate is placed posteriorly. Okay. Malignancy, most common set maxillary, and hardwood dust will cause Carpenter's carcinoma. So the treatment is by total maxillectomy and radiotherapy. Weber-Ferguson incision is taken to do maxillectomy. On-Grens line from medial canthus to angle of mandible. You draw a line. Tumors above this line in the maxillary sinus are lying near to orbit and cranium, so they are dangerous, poor prognosis. Tumors below this line are lying near to mandible, so even if mandible is damaged, you can go for surgical excision and fibular reconstruction. So these are not much dangerous. Okay, better prognosis. What surgery is being done? See, the surgery here, entire maxilla is removed. Okay, so this is total maxillectomy. Weber-Ferguson incision is taken here. Okay, now coming to the various incisions. So this is for your rhinoplasty, Caldwell loop. So you open the lip and go under sublabially, open the anterior wall of the maxilla. So this is how you approach the maxilla in earlier days. Nowadays, endoscopics have come. This is mid-facial degloving. In JNA like that, you will go for that. Blowout fractures. If there is a blowout fracture, the floor of the orbit gets fractured and orbital contents will herniate into the maxillary sinus. Hanging drop sign or tear drop sign you will see. So this is the previous year MCQ. So this is blowout fracture. So this is diplopia because the inferior rectus is getting trapped. So the eye cannot go inferiorly. So diplopia will be there. Epistaxis, restricted eye movements will be there. And coming to the CSF rhinorrhea, trauma is the most common cause, iatrogenic sometimes and idiopathic even sometimes, hypothyroidism. Unilateral watery rhinorrhea that increases on bending forwards. When you bend forward, intracranial pressure rises and more CSF will be leaking out. So what that is one side. Whenever patient comes with the unilateral watery rhinorrhea, this is more dangerous. Now reservoir side, so paranasal sinuses will be collecting the discharge, and when you bend or move here and there, then from the openings, the sinus openings, the CSF will come out. And double ring sign or halo sign or target sign seen in traumatic CSF rhinorrhea where blood is also there. So concentric peripheral rings of CSF and blood will be seen. So that is ring sign, target sign, halo sign. Handkerchief means on a handkerchief, if you place a mucus, nasal mucus, it will stiffen. If you place CSF, it will not stiffen. Beta 2 transferrin is specific for CSF. High glucose levels are present in CSF. HRCT stenography, they will show you the exact site of the defect, is helpful for surgery, and treatment is bed rest, elevate the head end of the bed, antibiotics, diuretics. Why stool softness? Because straining can cause, okay, increased intracranial pressure and more CSF leak. So you need to give stool softness, avoidance of nose blowing, sneezing and stretching, all this. All of the following are initial management options of CSF rhinorrhea except, so on bed rest, okay, head end elevated with bed rest. Steroids followed by face is done in chronic sinusitis, okay. Inflammation, you will use steroids, okay, sprays, fluticasone sprays. And if it is not improving, you go for functional endoscopic sinus surgery, FES, okay, that is done in sinusitis, not for CSF, not at all related, isn't it? HRCT to know the site of defect, antibiotics, acetazolamide is a diuretic, reduces the fluid load, so reduces CSF leak. Now coming to the larynx. So how many cartilages are there? 9 cartilages, 3 paid and 3 unpaid. So your thyroid cartilage has got 2 ala, 2 superior cornu, 2 inferior cornu. Biggest shield-like cartilage, and the cricoid has the only complete ring-shaped structure. Anterior thin cricoid arch, posterior broad cricoid lamina. As you go from anterior to posterior, it enlarges in size, isn't it? Only ring-shaped. And coming to the epiglottis, it is a leaf-shaped cartilage arising from behind the thyroid, isn't it? This is a leaf-shaped cartilage. And once you come to the paired cartilages, arytenoid sitting on the cricoid lamina on either side, pyramidal shaped. It has got an anterior vocal process to which vocal cord is attached, a posterior muscular process to which muscles are attached, right? Okay. So coming to the pre-epiglottic space. So if you take the epiglottis, anterior to the epiglottis, in between the thyroid membrane and hyoepiglottic ligament, there is a space called as pre-epiglottic space or space of Boyer. So what is now coming to the ossification process? So what you do is you draw a line. So first draw our diagram. Hopefully you remember our diagram. Thyroid cartilage, cricoid cartilage, arytenoid cartilage, corniculate cuneiform, epiglottis. Now I will draw a line such that this line divides cartilages into upper 3 and lower 3. Now what are the upper 3? Epiglottis, cuneiform, corniculate. These 3 are elastic. They do not ossify. Now come to the lower ones, thyroid, cricoid and arytenoid. These are hyaline. They do ossify. Okay. Now this was your PYQ actually. In 2020, the PYQ was there from this ossification. Now coming to the aryepiglottic fold. What is arytenoids. Where are the arytenoids here? Posteriorly. Where is epiglottis? Anteriorly. From anterior to posterior. Okay, from epiglottis to arytenoid, from arytenoid to epiglottis, from arytenoid to epiglottis, on anterior to posterior, on either sides, on both sides, a mucosal fold will enclose these structures and will form an entry into the central structure that is called as larynx. Okay, so this forms the entrance of the larynx. This mucosal fold is called as aryepiglottic fold. Inside, it extends down below to certain level that is called as completely. Okay, I'll show you the. Okay, I'll show you this thing. So this is your epiglottis, right? Where is your, from where this epiglottis is arising? Thyroid cartilage. Below the thyroid, cricoid is present. Here you have got your cricoid lamina. On the cricoid lamina, your arytenoids are sitting. This is your vocal cord, right? Now, where is your aryepiglottic fold? It is covering the epiglottis and arytenoids on either side. And this is forming a lower thickened border. Understood? क्या हो गया? What happened here? मैं ऐसे तो मत बोलना सबके सामने. Now come to this aryepiglottic fold. It is covering arytenoids posteriorly and epiglottis anteriorly. Okay, so see, this is your aryepiglottic fold covering on either side, and in the center it is enclosing a lumen, laryngeal lumen. Now the lower border is thickened to form false vocal cord. The lower border is thickened to form false vocal cord, and you have the true vocal cord as usual. This is your true vocal cord. So hope you understood this diagram. Now coming to the endoscopic view, remember always endoscopy means always I can introduce the endoscope from here and I can see from superior view only. Larynx can be viewed from superior view only, isn't it? Now when you are seeing from superior view, see this is the epiglottis anteriorly, epiglottis anteriorly. On either side, the aryepiglottic fold is running backwards. This is your arytenoid prominence. This is your arytenoid prominence. Aryepiglottic fold is running posteriorly. The lower border of the aryepiglottic fold is thickened to form the false vocal cord. The lower border of the aryepiglottic fold is thickened to form the false vocal cord. Down below, the whitish squamous epithelium line structures are present. Those are called true vocal cords. So this greenish one is, this is the true vocal cord here. In between these two, the space is present. In between false vocal cord and true vocal cord, there is a space present through which I can enter inside. That space is called as vestibule or ventricle. You understood? So if this is the epiglottis, this is the base of the tongue. See the epiglottis and the base of the tongue. In between the base of the tongue and the epiglottis, you have a depression called as vallicula. You have a depression called as vallicula in between them. Okay, understood? You are hopefully understood the structures. Now, lateral to the aryepiglottic fold on either side, you have a depression-like areas called as piriform fossa. These are the piriform fossa. Now, see, this is your arytenoid. Arytenoid is sitting down on the cricoid. Okay, cricoid cartilage, isn't it? If this is arytenoid is sitting on which cartilage down below? Cricoid cartilage. Where is the cricoid? You can't see from here. It is down below, no? Your arytenoid is overcoming. Now this cricoid, so that cricoid is there down there. Behind that, the area is called as post-cricoid area. So this piriform fossa, post-cricoid area, posterior pharyngeal wall, all these three together are parts of hypopharynx. Okay. You want to see when the patient is talking, vocal cords are coming here, isn't it? Now when the patient is breathing, they are moving away. They abduct while breathing, they adduct while phonate. That is the point you need to remember. Okay. Whenever you want to talk, vocal cords come near and vibrate. Whenever you want to breathe, they should go away. Okay. Unless they go away, there won't be space for you to breathe. No. So whenever you breathe, they have to go away. So whenever you talk, they will come near each other and phonate. So phonation, voice production is possible only during expiration, not during inspiration. You can do it. You can check it. Okay. Now coming to the laryngocele. So this is the coronal view of the larynx. So this is the false vocal cord, true vocal cord in between the vestibule or ventricle. Through that laterally, if I come, I will enter into a sac-like structure called as saccule. Okay. So this is called as saccule, called as oil can of the larynx, which is rich in mucus and serous glands of the larynx. Okay, and these mucus and serous secretions will be staining the surface of the vocal cord, okay, and will be reducing the frictional heat during the vocal cord vibrations. Okay, so what is this laryngocele? Air-filled cystic dilatation of the saccule. So in professional wind instrument blowers, due to the variation in the air pressures will keep on varying and the saccule will keep on dilating. Now the saccule becomes filled with more air and it becomes more dilated, and that will form a swelling towards outside. So whenever I press that swelling, the air will go into the larynx, that will make a hissing sound. It is called as Bryce sign, and diagnosis is by laryngoscopy, video laryngoscopy. See the bulge of the aryepiglottic fold on one side, see on the normal side. See air-filled sacs areas you will see in the larynx on CT scan. So that indicates laryngocele. Treatment is surgical excision. Now coming to the barium swallow. So whenever you do barium swallow, see whenever you swallow liquids, all the liquids will first come into the vallicula. From either side, they will go into the piriform fossa. Then they will go into the esophagus. The esophagus opens at that time. No fluid should go into the larynx. Into the airway, the fluid should not go. So whatever the fluid that comes, it flows in this manner. It flows in this manner and your esophagus opens up and it will go into that area. So barium swallow is the investigation of choice for esophageal disorders. Whenever you give barium swallow, first they will fill in the vallicula anteriorly. Then they will drain towards piriform fossa posteriorly, postero-inferiorly, antero-superiorly vallicula, postero-inferiorly. So vallicula above, the black arrow is that of vallicula and the white arrow is that of piriform fossa. Remember this, okay? Muscles of larynx. So your posterior cricoid is the only abductor that moves the vocal cords away. So it is called as safety muscle, because when the vocal cords move away only, then only you are able to breathe. So it is safety muscle of the larynx. Lateral cricoid is an adductor. It is moving both the vocal cords near to each other. Interarytenoid, transverse interarytenoid is pulling both the arytenoids near to each other. So this is, see when this muscle contracts, both the arytenoids will come near to each other. Now what is happening to the vocal cords? They are coming near to each other. So, okay, adduction. Now what is this thyroarytenoid? between thyroid and arytenoid. They are running parallel to the vocal cord, and these muscles when contract also, they will adduct as well as tense. The vocalis also helps in tension action. Cricothyroid is the powerful tensor of the vocal cord. If you are having any confusion in remembering, remember for tensor, cricothyroid, for abductor, posterior cricoarytenoid. Remember these two, and remaining all will be adductors. Okay. Are you able to follow? Yes or no? Yes, very good. Okay, so cricothyroid is a powerful tensor of the vocal cord. Now come to the nerve supply of the larynx. Vagus nerve supplies the larynx. The branches of vagus nerve are recurrent laryngeal nerve and superior laryngeal nerve. The superior laryngeal nerve is again divided into internal and external branch. See, if you take the vagal nerve which is coming here, see the nerve that is lying superior to the larynx. This is larynx and this is the nerve. This branch of the vagus is lying superior to the larynx. So this is superior laryngeal nerve. Now, as it approached the larynx, now it has divided into internal branch going inside and an external branch coming outside the larynx. So, superior laryngeal nerve, external branch and internal branch. Now, you can see another branch running downwards and again recurring back again to supply the larynx. As this is going, see, this is the level of the larynx. Okay, this is going below the level of the larynx, recurring back to supply the larynx. This is called as recurrent laryngeal nerve. If you compare the right recurrent laryngeal nerve and the left recurrent laryngeal nerve, the course of the left recurrent laryngeal nerve is much longer when compared to that of the right one, because the right one is hooking around the subclavian artery, which is in the neck only. So right subclavian comes till the neck level only. But if you see the left side RLN, it goes down into the mediastinum till the aorta level. It rotates around the aorta. So it is going into the mediastinum, still down below. So as this is having longer course, this is more prone to injury. For example, cardiac hypertrophy is there down below. When cardiac hypertrophy is there, it compresses the left recurrent but not right. So the left side vocal palsy, hoarseness of voice will be there. So when left side vocal cord will not move, hoarseness of voice will be there. So cardiac is causing voice problem. This is cardiovocal syndrome, Ortner syndrome, cardiovocal syndrome you call it as. Okay. And coming to nerve supply of hypopharynx, the hypopharyngeal nerve supply also follows the same pattern. Now you understood. Come to the motor supply. The motor supply is that the recurrent laryngeal nerve supplies all intrinsic muscles except cricothyroid. Except cricothyroid, all other muscles are supplied by RLN. Only cricothyroid, which is a tensor, is supplied by SLN. Your cricothyroid is a muscle of fourth pharyngeal arch. SLN is a branch of, is a traumatic nerve of fourth arch. All intrinsic muscles except cricothyroid develop from sixth arch. RLN is the traumatic nerve for sixth arch. Okay. Now come to sensory supply. See, the internal branch of superior laryngeal nerve is entering from above inside the larynx, above the level of the vocal cords. If this is the level of the vocal cord, above the level of the vocal cord inside the larynx, IBSLN is supplying the sensory sensation. From below, down below, RLN is entering inside the larynx. Below the level of the vocal cord, RLN is supplying the below vocal cord level. This is sensory supply. The same sensory supply is followed by hypopharynx as well. Now, at the till the level of the vocal cord, if you take the piriform fossa, they are lying above the level of the vocal cord. They are supplied by IBSLN. Post-cricoid area, okay, that is lying below the level of the vocal cord, that is supplied by RLN. Fishbone stuck in piriform sinus during removal, which is prone to injury. So piriform fossa is above the level of vocal cord. So injury will cause, okay, injury to ILN, internal laryngeal nerve. Okay. Professional singer finds difficulty in raising the pitch of her voice. I told you cricothyroid is a tensor. So when you stretch a rope tightly, it vibrates with high frequency. So a tensely stretched, a tensely taut vocal cord will vibrate with high frequency, will produce high frequency sounds. So cricothyroid helps in producing high frequency tones. Singers, when they try to raise the pitch of their voice, so they will be the cricothyroid will come into action. So if the professional singer is finding difficulty in raising the pitch of the voice, the tensor muscle is gone. Tensor muscle, cricothyroid is supplied by external branch of superior laryngeal nerve. A patient presents with neck swelling that moves with deglutition. So what is that moving with deglutition? Thyroid. Undergoes surgical excision. Post-operatively, she is unable to raise the pitch of the voice. The surgeon not only cut the thyroid, also cut the recurrent, the EBSLN. So the answer is EBSLN here, which gives sensory supply to the larynx above the glottis, internal branch of SLN, above the glottis, right? Now coming to vocal cord palsies, if it is unilateral, if the examiner is mentioning as unilateral vocal cord palsy, it is unilateral RLN plus SLN. If the examiner is mentioning as bilateral vocal cord palsy, it is bilateral RLN palsy. 99% of the cases of vocal cord palsy will be these two only. Okay, so that's why these two are most commonly taught. So in unilateral vocal cord palsy, paralyzed vocal cord is in intermediate position. Now what is happening on one side? RLN, SLN means entire vagal supply to the larynx on one side is lost. So that side vocal cord will go into cadaveric position. Complete nerve supply is lost, no? So cadaveric position, that is 3.5 mm away from the midline. So normal vocal cord is normal. The paralyzed vocal cord is fixed in cadaveric position. Right? Now, when both vocal cords are paralyzed, both sides only RLN. Now, what happens? See, when both RLN and SLN are paralyzed, the vocal cord is lying in cadaveric position. Now, when only RLN is paralyzed, SLN is intact. SLN is supplying cricothyroid muscle. It is a tensor. Due to the tensing action, the vocal cord is pulled a little bit nearby into the paramedian position. Both gone, cadaver. Only RLN gone, SLN is normal. Now, SLN, due to its tensing action, will pull this vocal cord a little bit nearby. That is into the paramedian position. Now, if both sides vocal cords are paralyzed, both sides RLN is paralyzed, both sides SLN is intact, both vocal cords are in paramedian position. Now, I am telling you RLN is paralyzed. RLN paralyzed means your abductor. Whenever you want to breathe, the vocal cord should abduct. What is the abductor? Posterior cricoarytenoid. That is supplied by which nerve? RLN nerve. Okay. All intrinsic muscles of larynx except the cricothyroid are supplied by RLN. Now, when the RLN is supplying this, when that is paralyzed, will the vocal cords be able to abduct? No. The vocal cords will be in that position. When the patient tries to breathe, both the vocal cords are in paramedian position, only 3 mm gap between them. So, breathing difficulty will be there here. Earlier here, paralyzed vocal cord is in cadaveric position. It is freely move. So the normal one is freely moving. Whenever the patient is breathing, this is moving away. So breathing is normal. When the patient is talking, this normal one is coming, but the abnormal one is paralyzed. There is a gap between two through which the air will leak out. Breathy voice will come. Bilateral may both are lying near paramedian, not moving away. Respiratory breathing problem. So here in unilateral voice problem, in bilateral breathing problem. So you see this unilateral vocal cord palsy. So try to notice that left side is paralyzed, right side is moving. See, right side moves while phonation, while breathing it is moving away. Right side is phonating, is moving better, but the left one is completely fixed here. Okay, understood? Now this is bilateral palsy. Both are not much moving. You see both, observe both. Both are not much moving. You keep watching them. I'll just come in a second. Okay. So hope you understood the difference between the two. Now, So for unilateral, you go for Ishiki type 1. For bilateral, you go for Ishiki type 2. See, what is the problem here? The vocal cord is in the cadaveric position. What you have to do? What is the problem? Voice problem. For voice to occur, both vocal cords should touch to each other. So what I will do? I will medialize the paralyzed vocal cord. Now, whenever the patient is breathing, this will go away. So through this space, breathing will occur. That is enough. Whenever the patient is talking, this will come near. Now the phonation is possible. Voice problem is addressed. Now in bilateral vocal cord palsy, both are lying near to each other. I need airway, breathing. Now lateralization, I will move both of them away and I will tie them up laterally. I will fix them up. Now, which may the airway has become widened. Now I have addressed the breathing problem. But here I have addressed the breathing problem. Now what about the voice? I have lateralized them. Now for voice to occur, they should come in midline. But this is not happening when I'm tying them away. So to address that, there are two other procedures called as arytenoidectomy. In arytenoidectomy, we just remove the arytenoid. Apart from this 3 mm space, extra arytenoidectomy space is coming where breathing is possible. Through this anterior commissure area, vocal cords are coming near to each other. At least, if not complete voice, at least some part of the voice is possible here. And best method for voice procedure, okay. If you want to give airway as well as best voice to the patient, go for Kashima's posterior transverse cordotomy. You are not staying anterior, posterior side, transversely you are cutting the cord. Okay. So this is what posterior transverse cordotomy in the same patient. So that was done, right? Okay. So posterior transverse cordotomy is done there. The cord is done, cut posteriorly, right? Okay. So 6 months after post-op, you can see the patient completely healed. So observe in that area where we have cut the cord. You can see some widened air space. See that area. Notice in that area. Okay. So patient is able to phonate as well as breathe properly. So both are being given. So ultimate inference of this entire slide is normally during phonation, vocal cords come near to each other. During respiration, vocal cords move away to each other. Now in unilateral, see the paralyzed vocal cord is staying in cadaveric position. Normal vocal cord is coming into the midline. There is a gap while phonating. So breathy voice will be there. Whereas while breathing, the normal one is moving away. The paralyzed one is staying away. So there is a sufficient gap. So breathing is normal here. Now when it comes to bilateral, both are in the paramedian, not able to move away. This 3 mm space is not sufficient for normal respiration. So suffocation, gasping, emergency tracheostomy needs to be done here. So when it comes to phonation, both are almost near to each other only. So voice is not a big problem. So ultimate inference is unilateral palsy voice problem, bilateral palsy breathing problem. That is the ultimate inference of this slide. Now coming to Semon's law. So partial bilateral RLN palsy has got worse prognosis than complete bilateral RLN palsy. Now what I will explain it later. Semon's law slide nahi. Okay. What Semon's law states is that I'm talking about Semon's law. So Semon's law. So if you take the RLN nerve, cross section of the recurrent laryngeal nerve, in that the abductor fibers are lying outside, adductor fibers are lying inside. So when there is a partial palsy, the partial palsy will affect only abductor fibers, whereas adductors are normal. Abductors are gone, adductors are normal. Then complete palsy is there, tumor is compressing the nerve completely, means both abductors are lost, adductors are lost. Here we are talking about RLN only, whereas SLN is normal in both the conditions, means tensors are normal in both the conditions. Now see, abductor is gone, adductor is gone, means RLN palsy has occurred, tensor is present. I told you when all the three are gone, abductor, adductor, tensor, RLN, SLN, all are gone, the vocal cord is in cadaveric position. If SLN is intact, it pulls the tensor action, pulls it into paramedian position. Isn't it? Now the vocal cord is in paramedian. If adductor is also intact, Now this is again pulled into median position. Now, if both vocal cords are in paramedian position, at least a small airway was present. Okay, time was present for to do tracheostomy, so you can provide airway. But in this partial palsy, both vocal cords are lying in median position, no airway at all, absolute fatal condition. Patient cannot sustain for long. So death may ensue in these cases. So very dangerous. Hope you understood that. Coming to puberphonia, so male is having female kind of voice, isn't it? Now what you have to do? Males are usually having low frequency voice. Females will be having high frequency voice. Now, what is the solution? So you have to convert that female voice to male voice. You have to convert that high frequency to low frequency. So you have to convert that high frequency to low frequency ones. Okay. So what I have to do? I have to shorten the length of the vocal cord. Now, which is held tight will get loosened. The loose end will vibrate with low frequency. Okay. So this is Gutzman pressure test. You can notice the change in my voice when I'm doing the Gutzman pressure test. Did you notice the change in my voice when I'm doing the Gutzman pressure test? So whenever I'm pressing the thyroid posteriorly, so thyroid is pressed posteriorly, vocal cord is loosened, shortened, so it is vibrating with a low frequency. The reverse. Remember only puberphonia. You apply the reverse to the androphonia. Now there won't be any confusion. Coming to the functional aphonia, so sudden voice loss will be there. No reason. Okay. Or some. Okay. Emotional disturbance has come. Nerves, muscles will be intact. So coughing will be intact, but phonation will not be there. Okay. So while doing laryngoscopy, ask the patient to cough. The vocal cords will move. Ask the patient to talk. They won't move. Now coming to vocal cord nodules, most common site anterior 1/3 to posterior 2/3. So they are usually bilateral, small, less than 3 mm. Speech therapy is the treatment choice here, first treatment choice. Seen in teachers, singers, and screamers. Okay. And now, okay. I think these you have seen in lab too. I think videos won't be of much importance here, right? So, think we are as usual running late. It's already 2 o'clock, right? So you can see, okay, both the vocal cords here, right? Okay. Okay. Now coming to vocal cord polyp. Again, the site is most common anterior 1/3 to posterior 2/3. It is usually unilateral. It is large in size. They are small in size. This is large in size. Treatment here is surgical excision. Okay. This is polyp here. There you have seen 2 nodules on either side. Here you can see polyp on one side. See the right vocal cord. See the right vocal cord there. A reddish polypoidal mass you can see there. Can you see that? That is right vocal cord polyp. Surgical excision. So this is the polyp. This is of another case. So you can surgically excise them. Okay. 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 That's how. Now coming to vocal cord granuloma, it is seen in GERD cases or prolonged ET intubation where posterior part of the vocal cord is completely, okay, abraded. Now most common site is reverse, not 1/3, 2/3. This is 2/3, 1/3 junction, mostly unilateral, and this is usually bilobed. Again, surgical excision. Ring case edema seen in smokers. Due to smoking, the vocal cords get damaged and they become diffuse saddlebag-like or polypoidal appearance. So surgical excision along with the stoppage of smoking is very important, right? Okay. So how many of you are having that? Please, okay, be cautious. Vocal cord cyst is endophytic. See, cyst means this is occurring inside the vocal cord. Polyp means it is arising from the surface of the vocal cord outside. Remember the difference. A chronic smoker presents with hoarseness of voice. Okay, say this is ringis edema. A teacher presents with following conditions. Say these are nodules, right? A teacher presented with hoarseness of voice, bilateral swelling. Again, this is vocal cord nodule. This is polyp. This is cyst. This is Rinck's edema. A patient with Rinck's edema will have dysphonia, diplophonia. Now coming to acute epiglottitis. So it is most common are streptococcus and Haemophilus. If both options are given, choose Haemophilus. Most common in 2 to 7 years. But coming to croup, it is most common in younger children. Here in epiglottitis, what happens? Epiglottis is getting inflamed. Here in croup, except epiglottis, remaining entire airway is getting involved. Okay. Now, this is bacterial infection. This is viral infection. So fever, sore throat, cough, dysphagia, drooling of saliva. Here respiratory distress. Why respiratory distress is here? Lower airways are involved. So respiratory distress, tachypnea, barking cough will be there here. Biphasic stridor. Here, what is the problem? The epiglottis only is inflamed. When I see from here, I will see some reddish mass arising upward. That is called as rising sun sign. Why inspiratory stridor? If there is any obstruction in the upper 1/3 of the airway, it causes inspiratory stridor. If there is any obstruction in the middle 1/3 of the airway, it causes biphasic stridor. If there is any obstruction in the lower part of the airway, it causes expiratory stridor. Upper 1/3 inspiratory, middle 1/3 biphasic, lower 1/3 expiratory. Here on lateral view X-ray, you see the epiglottis should be like a thin leaf-like. It will become bulkier like. This is called as thumb sign. Okay. Child tries to lean forward so that the bulky epiglottis falls anteriorly. So from posterior behind the epiglottis, airway will be open. So that is called as tripod sign. So as this is bacterial infection, antibiotics, NSAIDs, topical nebulization, so steroid nebulization can reduce the inflammation topically. Now here, this is a viral infection. So you can go for systemic corticosteroids along with the topicals. Okay. 4-year-old boy, low-grade fever, stridor, barking cough, hoarse voice, inflamed pharynx, increased respiratory rate, steeple sign. So here, antibiotics are not advised in croup viral infection. Which type of stridor occur in croup? Biphasic stridor, middle 1/3. Coming to this one, diphtheria and tuberculosis. Diphtheria is caused by Corynebacterium. Main things to remember are pseudomembrane, which bleeds on removal, grayish white, and cervical lymphadenopathy will cause bull neck appearance. Anti-diphtheric serum needs to be administered. Tuberculosis, what happens? This is painful tuberculosis. You see in TB, painful lesions are very rare. Most of the lesions are painless. In larynx, you see painful phonation due to ulceration. Mouse nibbled or moth-eaten appearance and turban epiglottis. Treatment is again ATT. A worried mother, 6-year-old unimmunized child. DPT vaccine not given. Diphtheria vaccine not given. So fever, cough, shortness of breath, pseudomembrane, bull neck appearance, that is diphtheria. Infectious mononucleosis, EBV. See the true membrane formation. Candida infection. See. Papillomatosis, actual name is juvenile. It occurs in young children. Recurrent, high chances of recurrence. Respiratory, it occurs in the respiratory tract. Papillomatosis caused by HPV. 6 and 11 are most common. Organism enters during birth only, but child presents at 3 to 5 years of age. Okay. Now, site of origin is where the supraglottis changes to glottis. From that junction, the tumor will arise, but it will fills into the supraglottis only, because this is wide open chamber, supraglottis. So even though it arises from the junction of supraglottis and glottis, it fills into the supraglottis first. So supraglottis means upper 1/3 of airway. Obstruction of upper 1/3 of airway causes inspiratory stridor. Treatment is surgical excision and antiviral. Now coming to adult and infant larynx. Infant larynx is conical. So when this is conical, the lowest part, subglottic part, becomes the narrowest part. In adults, glottis, vocal cord level, till now you have seen in all the videos, but the vocal cord level, glottis is the narrowest one. In infants, the larynx is high lying. So due to that, the simultaneous feeding and breathing is possible. Now coming to narrowest part in adult larynx airway, they have caused. That is, answer is glottis. Now coming to the laryngomalacia, most common congenital anomaly of the larynx. So the cartilages are weak and flaccid. They cannot withstand inspiratory negative pressure while inhalation. So when you are inhaling the air, the walls, the cartilages of the airway are not strong enough, they will get near collapse. So the airway becomes narrow and they will make a sound, that is inspiratory stridor. So it increases in supine and make the patient lie in supine, prone position, ulta, prone, it will improve. Omega epiglottis is seen here. So most of the times just wait and watch. Unless any peripheral cyanosis, severe respiratory distress is there, don't go for tracheostomy. Okay, if there are any dangerous signs, then provide alternative airway. So most of the times as age advances, the cartilages will get ossified, stiffened, and it will become narrow. Okay, stronger, normal. Subglottic stenosis below the vocal cord level, glottis level, the narrowing of the subglottis is there in the cricoid area. So prolonged intubations, the cuff will be there, no, ET tube cuff will be there, no, it will be compressing the surrounding tissue and cause this formation. Biphasic stridor, because middle airway is involved, biphasic stridor. Cotton Meyer has given this grading: grade 1 0 to 50%, grade 2 51 to 70, grade 3 71 to 90, grade 4 100. For grade 1 and 2, you just go for balloon dilatation. Grade 3 and 4, resect the stenosid segment and anastomose the upper and lower segments. Resection and anastomosis. 2-month-old infant presents with inflammatory stridor versus during crying and feeding was understood. So 2-month-old inspiratory stridor versus during crying. So this is laryngomalacia. Omega sign improves in prone position, which is true about laryngomalacia. Inspiratory stridor improves in prone position, most common in newborn. Surgical management is not required. Just wait and watch for 2 years. After 2 years, if not resolving, then go for surgery. So coming to carcinoma supraglottis, worst prognosis. Carcinoma glottis has got best prognosis. Now coming to the staging, I told you already in lab 2, if it is confined to any one subsite, glottis, supraglottis, subglottis, T1. If it is confined to 2, supraglottis and glottis, or glottis and subglottis, T2. Now it has extended into pre-epiglottic space or post-cricoid space, T3. Now, what happens in these 3 stages? Vocal cords are freely mobile. Vocal cord mobility is impaired. Vocal cords are fixed. Stage-wise derangement of the vocal cord mobility. Okay. So T3, fixed vocal cord. Now the tumor crossed the larynx and came anterior to the thyroid cartilage. Means it has crossed the laryngeal border. Now it becomes T4A. And it has gone spread distant vertebra mediastinum, that is T4B. So that's how you give T staging. Okay. And so for write 1, 2, 3, 4A, 4B, 4, 6. You write the stages like that. Now in the same way, you keep on giving the T1, T2, T3, T4A, T4B, like that you keep on writing. Now N1, you start from again stage 3. So you start giving N1 from stage 3, N1, N2, N3, likewise serially. Okay, so then you will get the staging methods easily. Elderly male smoker presents with progressive hoarseness of voice and throat pains in 6 months, irregular growth in the larynx, single ipsilateral mobile cervical lymph node, squamous cell carcinoma. What is the appropriate? So what is that? Irregular growth, single ipsilateral mobile cervical lymph node. So one side means N1. N1 means it is T3. So for T3, you will go for chemoradiotherapy. T1, T2, you go for stage 1, stage 2, radiotherapy. Stage 3, you can go for chemoradiotherapy. From stage 4A onwards, you go for total laryngectomy. Patient presents with hoarseness of voice, ulceroproliferative mass on the right vocal cord. Cord was mobile, means it should be T1, N0, M0, means stage 1. For stage 1, radiotherapy. Post laryngectomy, you have removed the larynx. Then how the voice? The best method is tracheoesophageal prosthesis. So you fix a prosthesis like this by puncturing the trachea esophageal common partition wall. You fix the prosthesis like this. Whenever the patient wants to talk, he presses the prosthesis. The air from the trachea is directed to esophagus and comes upward. So that's how you are providing the voice to the patient. So best method of voice rehabilitation, Blom-Singer prosthesis is most commonly used. Other methods are electrolarynx and artificial larynx. So if this image, if you see very clearly, if you see this image, see the you can see the prosthesis image also in this image. The plastic silicon-like prosthesis you can see there. Okay, so that is the prosthesis fitted there. So this trachea is brought out directly as a direct opening. From the trachea directly the patient is breathing into two lungs. Whenever he wants to talk, he blocks this opening, he pushes it backward. The air which is coming from the lungs will go through this opening into the esophagus and that will come out from there. Okay, hope you understood. Now coming to tracheostomy, usual site is third to fourth tracheal ring, high tracheostomy done during total laryngectomy. In electives, you take horizontal incision. In emergencies, you take vertical incision. Okay. So mostly you have to remember subcutaneous emphysema, which is a complication of the tracheostomy. When you place a tight suture in the tracheostomy area, whatever air is coming from inside, it will get trapped and enter into the subcutaneous tissues. That is subcutaneous emphysema. Identify, this is Montgomery's T-tube used during tracheal reconstructions. This is tracheoesophageal prosthesis Blomsinger's, and this is your grommet, serous otitis media. And airway procedures, cricothyroidotomy. So it is done in situations where tracheostomy is not available. So this provides can't intubate, can't ventilate. So it's a situation like you cannot intubate or you cannot ventilate. So in such situations, you have to go for a cricothyroidotomy. Heimlich maneuver is done for choking. Stand behind the patient, with your wrist press on the xiphisternum tightly. So the foreign body will expel outward. Endotracheal, oropharyngeal, Montgomery T-tube, you know all these things. Patient presented with a stridor. Intubation was unsuccessful. Best alternative. See, in these options, if tracheostomy was there, I would have selected tracheostomy because cricothyrotomy only buys some time. It is not a permanent procedure. It is a temporary, at least 10 to 15 minutes of time it will give you to provide permanent help. So cricothyrotomy is a temporary procedure. See, when intubation is unsuccessful, nasotracheal intubation, even from the oral cavity, the tube has to go like this. Even from the naso also, the tube has to go like that. So when orotracheal is in failure, nasotracheal will also become a failure. Bronchoscopy, again I have to use the same route. Laryngeal mask airway, again I have to use the same route. For cricothyrotomy, I can bypass this and I can directly go here. For tracheostomy, I can directly go here. Tracheostomy for years together, it will help you. Permanent airway procedure. Cricothyrotomy is temporary only. Remember that. Patient came after road traffic accident to the emergency with respiratory distress and severe maxillofacial trauma. Maxillofacial trauma. The trauma is present here. So don't touch this area. Bypass this area and go for a tracheostomy here. Foreign body. So remember, see this one picture. If a foreign body is lodged in the airway, it aligns anteroposteriorly. If a foreign body lodges in the esophagus, it aligns side to side. Okay. So when I take a AP view X-ray, the side of the coin is seen. When I take an AP view X-ray, the face of the coin is seen here. Understood? Okay. So when the foreign body is obstructed in the larynx, okay, now voice change will be there. Already the vocal cord area is a very narrow area, narrowest area, and even obstruction in that will cause even more distress. More distress will be there. Inspiratory stridor. Now, if the coin goes into the trachea, down into the trachea. Now, sorry, where is the trachea? Oh, here. If it goes into the trachea down, now what happens if it goes into the trachea? Trachea is a long conduit, long tube. So the foreign body, if it is freely mobile, with inspiration, it will go down. With expiration, it will come up. So it will be moving here and there, up and down, making sounds. So, and whenever the foreign body is touching the trachea, repeatedly irritating the tracheal mucosa, it keeps on giving cough. So biphasic stridor, cough, complete, repeatedly cough will be there. And palpatory or audible third sign will be there. So as the foreign body is moving inside, it keeps on making some sounds. Third sounds you call it as. And if the foreign body is enlarged, is lodged in right bronchus, so right lung cannot get ventilated. On auscultation, you are getting one lung hypoventilated, another lung normal ventilation. So that hypoventilated lung is not getting means that side bronchus is obstructed by that foreign body. Understood? Okay. So Now, this is how you identify, according to the clinical features, you identify the area of obstruction. Now, according to the, so treatment option, see, if the patient is unresponsive, be it less than 1 year or be it more than 1 year, whatever is the age, doesn't matter. First start CPR, chest compressions. Forget about the foreign body, first start chest compressions. This is important if the child is, or the patient is unresponsive. If the child is responsive, then do Heimlich maneuver only if the child is more than 1 year. Okay. And if he's less than 1 year, then go for back slaps and chest thrusts. So these are the five. You can repeat it till the foreign body comes out. Of all these, the child is responsive. If a bronchoscope is available in the hospital, bronchoscopy is the best and treatment of choice for foreign bodies, for airway foreign bodies. Bronchoscope, you insert a bronchoscope inside, you can diagnose the foreign body, you can see the foreign body, at the same time you can grab it and you can remove the foreign body. Therapeutic, both diagnostic and therapeutic. Bronchoscopy is the best method available for foreign bodies. Remember, see, on AP view, you are seeing the face of the coin. On AP view, you are seeing the face of the coin. This is coin in esophagus. Okay. Any doubts? Any doubts? Personal message only. Now coming to the pharynx. So coming to the anatomy of the pharynx. In larynx, 3 paired cartilages and 3 unpaired cartilages. In pharynx, 3 paired muscles and 3 unpaired muscles. 3 paired muscles are salpingopharyngeus, palatopharyngeus, stylopharyngeus. 3 unpaired constrictors, superior constrictor, middle constrictor, inferior constrictor. What are the structures passing between constrictors? Between skull base and superior constrictor, Eustachian tube. Along with Eustachian tube, muscles of Eustachian tube, levator velar palatinae, tensor velar palatinae, artery of Eustachian tube, ascending pulmonary artery. These are going in between skull base and superior constrictor. This area is called as sinus of Morgagni. Sinus of Morgagni. Now, okay, so you call it as sinus of Morgagni. Between superior and middle, 9th cranial nerve, middle and inferior, SLN, inferior and esophagus, RLN. Now, how to remember? First draw this diagram. Okay. Superior constrictor, middle constrictor, inferior constrictor, esophagus. Now, into the throat of all the cranial nerves, only 9th and 10th cranial nerves will come into the throat. No other cranial nerves will come into the throat level. Now, of all these, what is the lowest running cranial nerve? Still mediastinum one cranial nerve is running. What is that? Recurrent laryngeal nerve. So to a lowest constriction or lowest partition between two muscles, okay, lowest possible area, okay, partition area, you assign that RLN nerve. Now this is a branch of 10th nerve. Another branch of 10th nerve is SLN. So you assign that SLN to the constriction partition just above that. So 10th is over, above that 9th will be there. So you have to draw the diagram first. Superior, middle, inferior, esophagus. Now lowest nerve is RLN. Another branch of 10th is SLN. Now 10th is over. Now 9th. Hope you understood that. In lab 2 also I told you this. Patient presents with multiple swellings on posterior pharyngeal wall. So these lesions. So scattered lymphoid tissue here and there will be there on the posterior pharyngeal wall. Can you see that granular like tissue? So those are nothing but your lymphoid tissue only. Esophageal disorders, Zenker's diverticulum, you know very well, isn't it? So between thyropharyngeus and cricopharyngeus, the mucosa, triangular Killian's dehiscence is there. Through that mucosa will outpoach and form this. It is seen most commonly in elderly associated with chronic GERD. Dysphagia, so swallowing difficulty will be there due to the inflammation around there. Bad smell, food collected here will cause foul smell and it may fall into the airway and can cause aspiration pneumonia. So on barium swallow, you will see this pharyngeal pouch and treatment is excision, surgical excision called as Dolman's procedure. In diffuse esophageal spasm, you will see corkscrew type esophagus. In achalasia cardia, you will see bird beak appearance. In carcinoma esophagus, you will see rat tail appearance. Elderly patient presents with dysphagia, regurgitation of undigested food, halitosis, barium swallow, presence of a diverticulum between which two muscles, thyropharyngeus and cricopharyngeus. Cricopharyngeus and thyropharyngeus. 65-year-old male, dysphagia, halitosis, aspiration pneumonia, barium swallow was done. What is this? Zenker's diverticulum. This one is diffuse esophageal spasm, corkscrew esophagus. This one is achalasia cardia, bird beak appearance. This one is esophageal cancer, rat tail appearance. A barium swallow image of an elderly patient is proceeded. So based on the findings, what is this? Zenker's diverticulum. This is achalasia cardia. This is carcinoma esophagus. This is diffuse esophageal spasm. Posterior pharyngeal wall, you have multiple layers. So in the posterior pharyngeal wall, behind the mucosa layer, you have pharyngobasilar fascia, the red one, pharyngobasilar fascia, muscular layer beneath that, muscular layer, beneath that buccopharyngeal fascia, and beneath that you have retropharyngeal space. And behind the retropharyngeal space, you have the sky blue one, alar fascia, alar fascia. Behind the alar fascia, alar space. Behind the prevertebral fascia, prevertebral space. And then at the end, finally, vertebra. Okay, so the space between buccopharyngeal and alar is called as retropharyngeal space. This is divided by a median raphe into two separate spaces of Gillette, and each space is occupied by a lymph node of Rouvier. Now, whenever there is a swelling abscess in the retropharyngeal space, it pushes this posterior pharyngeal wall from one side, from any one side. Okay, now during my clinical examination, when I check from anterior side, when I press the tongue and see posteriorly back. Now, when I am seeing a swelling coming from one side, that should be retropharyngeal abscess. Now, if there is abscess in the prevertebral area, it pushes in the midline and the midline bulges. Now, when I am checking from anteriorly on the posterior wall, if I am seeing the bulge in the midline, it should be from the prevertebral abscess. Okay. Now coming to adenoid hypertrophy. Due to adenoid hypertrophy, the airway gets blocked, the nose gets blocked, so the child breathes through the mouth, and a small passage is left beneath adenoid and palate, so that causes the palate to cause flutter. Air will flow in this small space with high speed, that will cause palate to flutter. That palatal flutter will cause snoring. Eustachian tube is blocked. So serous otitis media, conductive hearing loss, B-type impedance, nose blocked, so no sinus ventilation is happening. So chronic rhinosinusitis, frequent cold episodes, constant breathing through the mouth, dry mouth complete, dental caries may happen, pharyngotonsillitis may occur. So as the child is constantly breathing through the mouth, the growing palate will take the air current shape, so that it becomes high arched. So when the palate is straight, the septum was straight. When the palate become high arched, the septum has to get buckled to accommodate within that space. Okay, so that causes deviated nasal septum, causes nose block again. So these sleep disturbances will be there, obstructive sleep apnea, low IQ. So sleep disturbances will cause growth hormone not properly secreted. Ghrelin is not secreted properly. Growth, stunted growth will be there. So crowded teeth, due to high arched palate, the anterior upper teeth will be crowded, and vertical, elongated, expressionless, dull face will be there, called as adenoid faces. Treatment is adenoidectomy with bilateral grommet. So again, all these questions you know, isn't it? Type of tympanogram seen in patients of adenoid hypertrophy is type B, you know that. So in adenoid, you will be having rhinolalia clausa, right? You know that very well. So these all things you know very well, right? Okay. Now coming to the tonsillitis. So if the substance of the tonsil gets infected, it is parenchymatous. If the crypts, the hidden areas are filled with the pus, they will be visible as pus follicles on the surface like that. That you call it as follicular tonsillitis. And if all these follicles fuse together and they will form a continuous layer over the surface, that is called as membranous tonsillitis. So clinical most common again is streptococcus, strep. Everywhere it is streptococcus. Cough, fever, swallowing difficulty, drooling of saliva, halitosis, foul smell, coasted tongue, pillar, surrounding areas, pillars, uvula, surrounding, gets surrounding areas, inflammation. Irwin Moore sign, if you press the tonsil, cheese material, pus will come out. That is called as Irwin Moore sign. It indicates chronic tonsillitis. For acute episodes, give conservative. For chronic, more than 3 months, go for tonsillectomy. So bed of tonsil is formed by superior constrictor. Main blood supply is by tonsillar branch of the facial artery. So these are all causes of membranous tonsillitis. Go through them once. And coming to the tonsillectomy, so it is done in Rose's position. The complications are various hemorrhages can occur for tonsillectomy. Primary hemorrhage. What happened? Primary hemorrhage on table while doing surgery if hemorrhage occurs, that is primary. First 24 hours, patient is still in the hospital, hemorrhage occurs, it is reactionary. Patient is discharged to home. Now the hemorrhage occurs because patient is not taking antibiotics properly, syrups properly. Now what happens? Infection, then bleed will be there. That is secondary hemorrhage. Operation theater, post-op ward, home. This is how. So post-op, for first day, the patient will be kept in hospital. So when the patient is still in hospital, so you have access to OT, immediately shift the patient to OT. So where the blood is coming, stop that by ligation or cauterization. Okay. If secondary hemorrhage is due to not properly using the antibiotics, so infection, give antibiotics. Okay. A 10-year-old post tonsillectomy ate a packet of chips after surgery. Now so patient is at home. Okay, this is secondary hemorrhage. Antibiotics will be the treatment of option. Now JNA, this is seen in adolescent males. This is a vascular tumor, so you should not take any biopsy. Okay, origin is from the sphenopalatine foramen, where this is located 1 centimeter behind the middle turbinate. 1 centimeter behind the inferior turbinate is Eustachian tube. 1 centimeter behind the middle turbinate is sphenopalatine foramen. Now it spreads into the nasal cavity. It can spread into the paranasal sinuses. It can spread into the orbits. It can spread into the orbits. Okay, it can spread into the intracranial, right? It can spread into the pterygopalatine fossa. So what will be the presentation? It is a highly vascular tumor. Heavy amounts of spontaneous epistaxis episodes will be there. Very high episodes of epistaxis will be there. High amounts of epistaxis. Why high amounts of bleed is happening? Whenever the blood vessels bleed, the contractile muscular part will contract and close the bleeding vessel. Here, that contractile muscular part in the vessel wall is missing. Now the blood will keep on like an open tap. It will keep on going outside continuously. Investigation of choice. This is a vascular tumor, so contrast enhancement. What is this Hallman-Miller or antral sign? Anterior. See, whenever the tumor is growing into pterygopalatine fossa, it puts pressure on the posterior wall of the maxilla. Now, when a constant pressure is getting applied on the posterior wall of the maxilla, this bows anteriorly. Anterior bowing of the posterior maxillary wall. Anterior bowing of the posterior maxillary wall is called as Hallman-Miller sign. Anterior bowing of the posterior maxillary wall is called as Hallman-Miller sign. Staging is done by radioscopy. Treatment is ultimately surgical excision, vascular tumor, do pre-embolization, reduce the blood supply, and then go for a 14-year. So all these questions you know very well, right? 14-year bald boy, recurrent profuse epistaxis, reddish mass, it should be JNA. 22-year-old male, recurrent bleeding. So again, tumor vessels lack contractility. That is a true statement. Staging related to JNA is Radkowski. And coming to nasopharyngeal, if no splits, which is most common artery? तो पूरा क्लास सुना लिया ना? Sphenopalatine, no? Nasopharyngeal carcinoma, most common site is fossa of Rosenmuller. You know that very well. So mostly seen in salted fish intake, nitrosamines, China, Indonesia, Thailand, Northeast Asia. The patient presents with unilateral hearing problem. You put an otoscope inside and you see what? Serous otitis media. Immediately take out that endoscope and directly put into the nasopharynx and see whether any growth is there or not. So you will see the normal fossa of Rosenmuller. This is nasopharyngeal carcinoma. This is Eustachian tube opening, torus tubarius, fossa of Rosenmuller, postpharyngeal wall. So conductive hearing loss, B-type impedance you will get. Posterior painless cervical lymphadenopathy. Nasopharyngeal carcinoma will spread to posterior triangle of the neck. And Trotter's triad. conductive hearing loss, ipsilateral temporoparietal neuralgia, and palatal paralysis will be there. These tumors are highly radiosensitive. Glottic carcinomas, nasopharyngeal carcinomas are highly radiosensitive. So what is the structure marked to here? Fossa of Rosenmuller. What is this Passavant's ridge? What is this Passavant's ridge? It is a forming between which oropharynx and nasopharynx. It prevents nasal regurgitation of the swallowed food, isn't it? Whenever you are swallowing the food, it prevents nasal regurgitation. From the palatopharyngeus, few fibers will come. From the superior constrictor, few fibers will come. So they will be joining to form the Passavant's ridge. 60-year-old male, painless cervical lymphadenopathy, conductive hearing loss, decreased mobility of soft palate. It is nasopharyngeal carcinoma. Trotter's triad, conductive hearing loss, ipsilateral temporoparietal neuralgia, and palatal paralysis. Most common site is area 2, fossa of Rosenmuller. 1 is posterior pharyngeal wall. The number 3 is torus tubarius. Number 4 is Eustachian tube opening. 50-year-old male, right sided serous otitis media, cervical lymphadenopathy. Probably it is nasopharyngeal cancer. Now Quincy peritonsillar abscess. It is a peritonsillar space, means the space between tonsil and the bed of the tonsil. Between superior constrictor and the tonsil, abscess occurs. It pushes the tonsil medially. Uvula is pushed towards opposite side. Okay, hot potato voice. So there is some hot substance in the throat. So the voice will be like hot potato voice. Fever, sore throat, cough, dysphagia, drooling of saliva, all this will be there. So first you have to drain. Incise. This is an abscess. You have to incise and drain. Wait for 6 weeks interval and then go for tonsillectomy. This interval is for complete resolution of the surrounding inflammation. Once everything subsides, normalizes, go for tonsillectomy. As you are waiting for 6 weeks interval, it is called as interval tonsillectomy. Ludwig's angina is from the third molar, the which is connected directly to the submandibular space. If any molar caries, third molar caries is there, unattended, non-treated, it may slowly spread into the submandibular space. And if the submandibular space abscess occurs, the abscess rapidly progresses and it pushes the base of the tongue posteriorly, obstructing the airway. So impending airway obstruction can be expected in most of the cases. So as early as possible, go for incision and drainage. Already respiratory distress is there. Now the pathology is in the upper part. Bypass this area, provide airway through tracheostomy, relieve the pathology here. Then after normalization, remove the tracheostomy tube. So that is what you need to. Indirect laryngoscopy, mirror nasopharyngoscopy. So laryngoscopy mirror is straight. With this, you can see the laryngeal structures. Nasopharyngeal mirror is curved. With this, you can see the nasopharyngeal structures. So neck nodes, I told you, 1A submental, 1B submandibular, upper jugular, middle jugular, lower jugular, along the anterior border of sternocleidomastoid. 2, 3, 4. Now go to posterior triangle, 5. 5A, 5B. Above is 5A, below is 5B. Now come to midline, 6. Now mediastinum, 7. Delphian nodes are pretracheal. Pretracheal means in the midline, means level 6. Okay. Delphian nodes are at level 6. Now don't worry by seeing this. Just study whatever I have told you. This will be enough. Okay. Now coming to oral cavity, Vincent's means acute necrotizing, ulcerative, gingivitis, gingiva, gum. Gums are okay, completely necrotizing, ulcerative. So gum bleed will be there. Borrelia and spirochetes are the causes. So you give antibiotics, gargles, and topical steroids to reduce inflammation. Oral thrush means it is fungal infection of oral cavity, diabetics and immunocompromised, candida, whitish. So if you are on the tongue, try to remove the whitish structure present. If you are able to scrape it out, that should be candida. Give antifungals, both topical antifungals and systemic antifungals. After ulcers, all of you may be having this. If not having, I can't help. Okay, you have to get this as early as possible, as you know. After ulcers caused by stress, vitamin deficit and infective. So this is the treatment. Pain and burning while eating will be there. Tongue tie is congenital, anterior attachment of the frenulum. The tip of the tongue is not mobile, so difficulty in speech and swallowing. Treatment is surgical release. Sublingual gland enlargement, it is ranula you call it as. So it's just a small painless bluish swelling will occur in the floor of the mouth where sublingual gland is present. Treatment is surgical excision. Geographic tongue, don't know why it happens, don't know what to do. So idiopathic, depression, stress, vitamin deficit, cause is not known. So treatment obviously will not be known. Okay, these are experimentally given. The patient presents with complaints of a painless, gradually enlarging swelling in the floor of the mouth. So this is nothing but your ranula, right? So this is your Ludwig's angina. This is your mucocele in the lower lip. What is mucocele? In the lower lip, minor salivary glands. What are the major salivary glands? Parotid, submandibular, sublingual. Now, apart from these three, minor, small salivary glands are scattered all over your oral cavity. In the lower lip, they are very high in number. So, trauma to the lower lip will cause the formation of this mucocele, where surgical excision is the only treatment. Okay. Now, coming to precancerous conditions, oral submucous fibrosis. Beneath the mucus layer of the oral cavity, submucous layer filled with serous glands, mucus glands, antibacterial secretions, antifungal, antiviral secretions are there in these glands. Now that layer is damaged, fibrosed. Now what happens? Oral immunity is lost and the drying of the secretions are lost. Complete drying of the oral cavity mucosa will be there. Smoking, alcohol, tobacco, nuts, all the fibrosis will cause whitishness. So trismus, pain and burning sensation. Triamcinolone, which is a topical corticosteroid to reduce the inflammation, and hyaluronidase to digest all these whitish fibrous bands, which helps in opening of the trismus. That will help you. So this is the treatment. And leukoplakia, any whitish patch inside you are seeing, you should immediately send it for biopsy. Once confirmed as leukoplakia, remove the entire whitish patch. Ask the patient to be on regular follow-up. If this has got more vascularity, it appears red in color, called as erythroplakia. So this is more vascular, means more metastatic, means more malignant. Again, treatment is surgical excision. And coming to the mumps, this is viral infection of the parotid gland, and paramyxovirus is most common. Sometimes starts as unilateral, becomes bilateral later. Pain in the parotid region and drying of mouth, pain while chewing will be there, and associated with thyroiditis, pancreatitis, and thyroiditis, myocarditis, pancreatitis, and niche dactitis. Okay, euphoritis or architis. Treatment will be, this is viral infection, so corticosteroids and NSAIDs will be given. Sudden SNHL, this can go into the spread into the cochlea and can cause sudden SNHL, can go into the brain and can cause meningitis. Sialolithiasis, most common in submandibular gland because the Wharton's duct has to ascend high up as well as the secretions are thick here. Okay, whenever you take food, the duct is blocked. So as the submandibular gland duct is blocked, the salivary secretions that come during eating will accumulate here and cause increased size of the gland. So while eating, pain and swelling will be there. So if the stone is within the Wharton's duct, if the stone is within the Wharton's duct, you can pass a endoscope inside and you can remove that. If the stone is inside the submandibular gland, you have to excise the complete gland. Now, mucocele already I told you. Okay. Pleomorphic adenoma, most common benign salivary tumor seen in middle-aged females. So most common in superficial. A hard, painless, stony hard mass will be present behind the angle of the mouth. So patient will come with that. Middle-aged female, 40-year female will come with that presentation. So superficial parotid is the most common set. Excise it, send for biopsy. Chondromyxoid stroma and myoepithelial cells you will see. Adenolymphoma is second most common seen in elderly males. Again, the same superficial parotid is the most common. Surgically excise it, send it for biopsy. Lymphoid elements are seen in biopsy. Then it becomes adenolymphoma. Lymphoid elements are not seen. Only stroma, myoepithelial cells are seen. It should be pleomorphic adenoma. Coming to carcinomas, mucoepidermoid carcinoma will have both mucin cells as well as epidermal cells. Treatment is again surgical excision. Adenoid cystic carcinoma, the main important feature is perineural infiltration. It infiltrates into the perineurium of the facial nerve. So post-op, you have to remove the facial nerve also. So facial nerve palsy post-op will be there. HPV is associated with oropharyngeal, nasopharyngeal carcinoma. EBV is associated. Laryngeal and hypopharyngeal, most common for you all. Smoking, drinking, okay, chewing, tobacco, all those things, okay, will be. Okay, so with this, finally, we completed. So I took 40 minutes more out of the, I was in my mind that 10 to 3 was the time given to me, I thought. Okay, fine. Chalo, sorry for taking 40 minutes more, but I have tried to cover the maximum. Chalo. So take a short break and go for the next session. Chalo, I'll take leave. Okay, any doubts, please do message. Any doubts, please do message. Okay. Chalo. Chalo, I'm signing off.